Почетных гостей форума приглашаем на сцену занять места за президиумом. Martabali mehmonlarimizni sahnadagi prezidiumda joylarini egallashlarini so'raymiz. Hurmatli Asilbek Anvarovich, hurmatli Mirzagalib Nigmatovich, уважаемый Andrey Dmitrievich, hurmatli doktor Muhammad Ismoil Gaydari, doktor Penharkar Dinesh va hurmatli Kerimli Azat Aydin. Marhamat. Sahnadagi rayosatdan joy
kindly take your seats, and dear panelists, we would like to ask you to go on stage. Thank you so much.
Assalomu alaykum, hurmatli mehmonlar, aziz hamkasblar.
Dear guests, dear colleagues, dear ladies and gentlemen, so it is our pleasure to welcome all of you at the 5th Congress of Oncologists and Radiologists of the Republic of Uzbekistan. Thank you so much for your kind attendance.
Господа, от лица организационного
On the behalf of the steering committee, it is our pleasure to welcome all of you at the 5th Congress of Oncologists of Republic of Uzbekistan. Dear guests, you are aware that we are conducting significant reforms in Republic of Uzbekistan under the leadership of the President of Republic of Uzbekistan, His Excellency Mr. Mirziyoyev. So, as a result, you know that recently we have inaugurated new state-of-the-art center of oncology, which is equipped with the most advanced equipment and fully complies with international standards. And recently we had a contest yesterday for our young scholars, for our young scientists, and they have shared their ideas. And today we are eyewitnessing historical event, opening of the 5th Congress of Oncologists and Radiologists of Uzbekistan with the participation of our esteemed foreign guests.
Президента Шавката Мирзиёева реализуется масштабная работа в сфере здравоохранения. В частности, отдельное внимание уделяется развитию онкологической службы. И как свидетельство данного внимания, недавно начало свою работу современное онкологическое здание онкологического центра, оснащенного передовым лечебным и диагностическим оборудованием, отвечающим мировым стандартам. Отрадно, что в конференц-зале данного центра вчера состоялся конкурс для молодых ученых-онкологов, где выступила одаренная, перспективная молодежь нашей страны и тем самым заявила о себе. И сегодня мы стоим у истоков еще одного исторического события – торжественного открытия съезда, объединившего ведущих онкологов-специалистов на съезде, в ходе которого сегодня нам предстоит обсудить вопросы борьбы с онкологическими заболеваниями. Желаем всем продуктивной работы и высокой результативности. Hurmatli xonimlar, janoblar, bugungi tadbirimizni ochish uchun so'z O'zbekiston Respublikasi Sog'liqni saqlash
Уважаемые коллеги, с вашего позволения, слово для
forumi
Dear colleagues, we would like to give the floor to His Excellency Mr. Asilbek Khudayarov, Minister of Health of Republic of Uzbekistan, to inaugurate today's event, please. Dear ladies and gentlemen, dear colleagues, it is our pleasure to have you here.
Что медицина не должна знать границ, вне зависимости от вероисповедания, вне зависимости от принадлежности к той или иной страны, нас объединяет общее дело – это помощь страдающему человеку и подарить радость.
And definitely we would like to bring a joy to not only to the patient but also to his family members, to his close circle. I am very thankful to all of you for your hard work, for your efforts, and definitely as years go by, though we have very significant developments and advancement in development of technologies, it is not easy to verify this disease, though we have high-tech equipment which can even at the genetic level help us to diagnose oncological disease, but unfortunately the number of oncological disease is growing year by year, and today's forum is very important not only for us but also for our country, because it highlights the important advancement and development in economic reform, in the healthcare, and in the country as the whole. So within these 8 years, we had the 5 presidential decrees which have been dedicated to the development of oncological services, and as a result, we have introduced a vertical system of management which helps us even to render assistance to people at the level of local communities, at the primary level, which is the closest to the citizens, to ordinary people. And definitely we are now able to efficiently control the quality of medical service rendered to our people. So several years ago, our country had only 5 units of equipment for treatment, but at the moment we have over 50 of them, and definitely it helps us to introduce the most advanced methods of treatment, and the funding also it grew 11-fold, and so it previously it was 1.2 million of USD, but at the moment it's 14 million USD, and government definitely will invest even more in procuring the equipment and to help our patients to overcome the disease. And at the moment the coverage with drugs grew up to 95%, and the government actually is focused on promoting free of charge treatment and advanced access to advanced equipment, and we are also trying to resolve all of these issues which are related to limited access to medical equipment. Previously, 8 years ago, we couldn't even imagine that we will have a private sector in oncology, but at the moment we have them, and all the reforms which we are having underway, I can tell you as a minister that I am strongly concerned with early screening, and at the moment we have embraced 3.5 women with screening, and 2.5 million of these women have already underwent the preliminary screening for breast cancer, and 1.5 had been monitored, the early monitoring for cervical cancer, and according to the international surveys, we discover around 19 million of malignancy on annual basis, and 10 million people unfortunately die due to cancer disease annually all across the world. This statistical data shows the importance of uniting our efforts, and last year, based on the initiative of the President of Uzbekistan, we have inaugurated the state-of-the-art oncological center, which is one of the most advanced medical centers of this kind in the Central Asia, and we have been searching for a good, I would say, manager, and we to operate it, and we wanted to introduce the state-of-the-art methods of management, and we also have been focused on promoting international standards and protocols of treatment and diagnosis for oncological disease, and this center of the new age has 650 beds and 100 of outpatient visits, and it has 16 surgery rooms and 17 clinical treatment rooms, and as well as you are well aware, like yesterday we had a contest of young oncologists of Uzbekistan. You know that our youth is the key pillar of our future, which will definitely make its meaningful contributions in development of our country and improving quality of life of our patients. Today we have the 350 specialists from all across the world and Uzbekistan, and we have 20 famous and reputed scientists from Russia, Kyrgyzstan, Iran, Azerbaijan, Turkey, and we are embracing today the most important, comprehensively, the most important domains of the state-of-the-art oncology, even up to palliative assistance and molecular diagnostics. So the platform is here for our unique exchange of experience and boosting international cooperation. So I'm pretty sure that the work of our forum will be important step towards strengthening our international cooperation and improvement of the national system of oncological medical assistance. Dear colleagues, I hope that our discussions will be fruitful and new ideas will be introduced to practice. I would like to wish all of you solid health, inspiration for the sake of our people. And once again, I would like to express my sincere gratitude to our foreign colleagues who have paid visit to Uzbekistan for today's event. I am very thankful to our sponsors, our colleagues from Uzbekistan, for their participation at today's event. And I would like to wish you all the best. Thank you so much for your kind attention. Thank you so much, Mr. Minister, for your meaningful comments and your contribution to the development of oncology in Uzbekistan. It cannot be underestimated. And this is the signs of your loyalty to development and improving quality of life. I would like to give the floor to the Chief Oncologist of the Republic of Uzbekistan, Mr. Mirzagali Kalashaykhov. Please, sir, floor is yours.
Yapıldı mı? Selamünaleyküm.
Dear participants of today's event, dear participants of our Congress, here in Republic of Uzbekistan we have 1,200 oncologists, and we have third of them participating today with us. It is called Congress, and it is held once in 5 years, and we have a conference of oncologists which is conducted biannually. So we are checking what we have achieved, and we will be discussing it. Upon your kind permission, I will proceed in Russian. Dear colleagues, dear friends of mine, today is the opening of the 5th Congress of Oncologists of Republic of Uzbekistan, which is held once in 5 years, and we definitely check what are our plans for coming 5 years. It's very important, and actually we have to have it, and I know we have the conference of oncologists which is held, I would say, in provinces also, and we also develop our plans for coming 5 years. So I would like to thank all of you on my own behalf, and our reputed guests, and we have representatives of more than 20 countries with us, and definitely we are very happy to have our famous and reputed doctors, Mr. Kaperin Andrei Dmitrievich, we have Mr. Ismail Gaidaria, we have Mr. Kerim Azat Aydınoglu, we have our representatives from Kazakhstan, Mr. Bekbulatov, director of the Center of Oncology of Kazakhstan. I can see my friend, Mr. Helmut Khan, who is my long-standing friend for a quite long period of time. And, we have the Society of Mechnikov Koch, and we have also Society Avicenna Koch community, and we have our co-chairman, my colleague from Germany, who is very famous, and Mr. Roland, also our good friend, who is rendering his possible assistance both online or even pays his visits as renders his assistance on national plan for combating oncological disease, and we are closely cooperating within these 2 years, and hopefully by October we will finalize our work on development of a national plan on combating oncological disease. We have reputed scientists. We have Madame Zilara Razikovna, our famous colleague from Kazakhstan, and we have colleagues from Kyrgyzstan, we have colleagues from Tajikistan, and we have directors of center, professors, and we have I would say leaders, the directors of centers of urology, of other centers, and it's my pleasure to have you here and to greet you. And I would like to mention that within these 5 years our achievements have been highlighted by our minister. He has embraced all of our achievements in his speech, but talking about important treatment procedures, like for example beam treatment, beam therapy. At the moment, our patients should not go abroad for such kind of treatments. They can get everything in their provinces, and the level of drugs provision jumped up to 98%, and all of the equipment is available in each of the provinces. And recently, our patients, they had no other chance but to move to the other countries like India or Russia for medical treatment or for analysis, for tests. But now we have everything, I would say, not only the consumables for labs, but also the equipment and assay methods. So, and also scientifically, we have our specialized center with us. On monthly basis, we have 1 or 2 PhD dissertation defended within the framework of this center, and this center has also affiliates in the subsidiaries in the provinces of Republic of Uzbekistan. So we are nurturing our oncologists, our radiologists for our country, and we are very proud that we had 280 of our oncologists have been trained in foreign countries, in Turkey, Belarus, Russia, France, India, Germany, and everything was paid. I mean, the training fees were fully covered from the government budget, and we had 5 presidential decrees within these 8 years, which were dedicated to the improvement of oncological assistance, medical assistance to population, and definitely within these 8 years, 5 decrees. I would like to reiterate that this is the sign of the president's attention. This is the president's initiative to improve the quality of life. And we had also the project with Islamic Development Bank, ISDB, totaling 80 million USD on equipping the hospital with the best equipment, and the 280 oncologists have been trained in foreign countries, and the training fee was covered up by the government. And very important achievement is equipment which meets all the requirements is our center of oncology. We have 9 facilities, and we have also for CT scan, we have also MRI, and in all of the actually provinces of the countries we have our departments, and their premises have been fully refurbished and equipped. So availing myself of the opportunity, I would like to wish you successful event ahead. Welcome to Uzbekistan, welcome to Tashkent, which has always been a star of Orient, and today we will have all the day long event, and we will also have some cultural program for us, and I'm very delighted to have all of you here, and I do hope that today and tomorrow will be the days which you will remember. You will make a great memories. Thank you so much, Mr. Talashaykov, for your warm welcome speech, and I'm pretty sure that thanks to your professional expertise and long-term vision, we are progressing with the development of medicine. Upon your kind permission, I would like to give the floor to representative of Russia, director of National Center of Radiology, the chief oncologist of the Ministry of Health of Republic of Russian Federation, the merited medical doctor of Russian Federation, Mr. Andrei Kaprin. Please, sir, floor is yours. Thank you so much for such an introduction. Dear colleagues, dear Minister, dear Mr. Talashaykov, my dear friends and colleagues who have dedicated their life to combat oncological disease, and definitely all of us, my colleagues, like-minded persons, you're absolutely right, and His Excellency Minister was absolutely right to mention that we experience no boundaries in fighting oncological disease, and oncological disease required multifaceted approach, and definitely they require significant investment. I mean, treatment from oncological disease is very expensive, and you know we have a lot of new dimensions in oncology. And even when we were taught in medical higher education institutions, we have been told that you should go to, for example, how we have been developing, who will go, for example, for chemical treatment, for chemotherapy. If they will be able to open a door, then he can go. But at the moment, if he cannot, then he will not go. So at the moment, we have cardio-oncology, new direction. We have oncogerontology. We have the patient with significant failures, organic failures. So you can see that we have new methods of treatment, and whenever we have been talking about surgery, for example, even my doctorate dissertation was dedicated to bladder, and or talking about cystectomy, and look what we have. We have so many patients who can we treat. Previously, they were telling it is not possible. I mean, the surgery is impossible for this patient. But I can tell you that at the moment everything is available. So I'm always coming to Uzbekistan with pleasure. I will not consume so much of your time, because we do understand that I will have a lot of other reports actually to deliver in front of you. Last year when I came here to February, it was a heavy snowfall, but anyway, Uzbekistan is very, very, I would say, sunny and shiny country, the country of the sunshine. That's why I know the people who are living here, and I'm very happy to have our colleagues from Germany, and definitely we haven't seen each other for quite a long time, and I'm very happy that we have opportunity to meet each other, and I would like to congratulate all of you with our event, and we will learn more about our research areas, and I always tell that this will be also a good platform to train our personnel, and we have a lot of specialists also from Uzbekistan who are undergoing training under us, and trust me, they are very talented. They speak several foreign languages, and I can tell you that the best friendship you can have is when you are cooperating, when you are becoming friends, lifetime friends, because you are focused on solving problems together, on combating oncological disease together. And definitely I would like to thank you for invitation and for decorating these days for me with such a beautiful event. Thank you so much, Mr. Kapran. It's very important for us, and I can tell you that we will have a representative of Islamic Republic of Iran, who is the head of the most reputed medical universities of the country, with 13,000 of students and 1,300 of teachers. Sir Muhammad Ismail Gedari. Please, sir, floor is yours.
Good morning, ladies and gentlemen, Your Excellencies, distinguished guests, our dear colleagues. I'm sorry not to be able to speak your language. It's a great honor to be here with you today. I'm Professor Mortazavi. I'm talking on behalf of the Rector of Shahid Beheshti University of Medical Sciences, Tehran, Iran. Unfortunately, our Rector has fallen ill and it's not possible for him to be here with you today. I would like to take this opportunity to briefly introduce our university. Shahid Beheshti University is the second-ranked university in Tehran, Iran. We were established in 1961, starting with the medical school, and later on the School of Dentistry, Pharmacy, and the other faculties. Overall, we have 11 faculties, as stated: medicine, dentistry, pharmacy, all the way to traditional medicine. As you know, Iran is really strong and has in-depth knowledge on traditional medicine. Also, advanced technologies. One of the fields which is done in the advanced technology faculty is the field of cancer research. We have around 14,000 students whom are being taught in 288 different disciplines and educational programs, right from the bachelor degree to master, PhD degrees, fellowships, different specialties. Our university has 90 research centers and 7 institutes. We have around 7 collaborative parties, with WHO. We are active in the field of cancer. We have a cancer research center in Iran, which was established in 2005. This center obviously do research in the field of cancer, various cancers. Also, it has a number of clinics, right from breast cancer to palliative care, nutritional clinic, also clinic on traditional medicine, use of traditional medicine for the treatment of cancer. Also, they are in collaboration with a number of knowledge-based companies, and as a result of that, they've managed to come out with technologies on plasma technology for the treatment of cancer. They have managed to produce gamma probe technology in Iran for the treatment of cancer. They have used exosomes for the treatment of cancer, and they are some of the main advances which have been made in that center. They also work in the field of lutetium therapy for the treatment of cancer, and also they publish an international journal called International Journal of Cancer Management, which is being cited in different databases, and they surely would be pleased to have articles from our distinguished guests present in this conference. Overall, our university is active, as I said, not only in the field of research, but also in the field of educational programs. We have over 1,500 international students. We do have students from Tajikistan. We do have students, unfortunately not Uzbekistan, we haven't had. We hope that we have students in the future, and from other countries worldwide. I myself, I'm a pharmacist, and I do work in the field of cancer research. My main field of interest is drug targeting and the use of targeted drug delivery systems, particularly the use of nanotechnology, use of nanocarriers like as nanoliposomes, also nanowires, and also use of radiation alongside nanocarriers. So we were more than pleased to have collaboration with our dear colleagues. I think the world belongs to all of us, and we're all scientists, regardless of where we live. And I'm sure that we could start good ties between the two countries. It is my first visit to Uzbekistan, and I'm sure that it won't be the last visit. I'm sure that I get the chance to visit our good colleagues in different cities in Uzbekistan, Tajikistan, and other countries. I would like to extend our warmest greeting to all our colleagues, and also suggest that we have common conferences between the countries. We are more than pleased to start links with our dear colleagues in the countries mentioned. I hope that you enjoy this magnificent conference. It's a pleasure for me to be here. I would like to thank the esteemed chairman of this conference, His Excellency the Chancellor of the University of Tashkent, and all the people present in this conference. Wish you a pleasant stay, and thank you for listening to my speech. Thank you very much.
Thank you, Mr. Gidari, for joining us today. Your leadership ties strengthen medical international development in oncology. Теперь слово предоставляется.
And now we would like to give the floor to the representative of India, famous Mr. Dinesh Pendharkar, famous scientist. He has dedicated 35 years of his life to the treatment of medical disease and for his contribution to the combat against cancer. He was awarded with Fosco's award, and he is focused on breast cancer and treatment of paraneoplastic syndromes. Please, Professor Dinesh Pendharkar, floor is yours.
Ассаламу алейкум. Здравствуйте, глубоко уважаемый министр, доктор.
Your Excellency Minister, dear colleagues, everyone, it is our pleasure to be here. I am very happy to be at this Congress. For several years I am cooperating with you, and we are seeing how intensively oncology in Uzbekistan is progressing. When I have started our cooperation, we had only in 2 or 3 cities we had X-ray therapy, but at the moment we have it all across the country in all the cities. So all of us who are here with us have produced their meaningful contribution in achieving this result. It's my pleasure to be here to cooperate with you, and I'm very happy that you have granted me with opportunity to collaborate together with you. We have achieved nice results, and I'm pretty sure that the Institute of Oncology became a very good, I would say, role model about to developed countries, developing countries, how can we establish such a beautiful and advancedly equipped centers, and how can we operate it. All of you have produced your meaningful contribution for us to, to reach these days, and we need to move forward. We move forward both in clinical research, and we have His Excellency the Minister with us, and I would like to address to His Excellency that we should enter the area of clinical research, and if, for example, you will look at the, I would say, model of Russia, of Moscow, because you know that Russia was very proactively taking part in all the areas of clinical research, and I would like Uzbekistan to move forward with clinical research, which will give us knowledge, which will give us a new treatment methods and drugs before they will be marketed, and I am pretty sure that we can start. And actually in oncology we have so-called cell therapy and we have gene therapy, so I'm pretty sure that we, together with you, can achieve this height in coming future. I would like to wish you all the best, and I would like the conference to be successful in all of the endeavors. And thank you so much for your kind attention.
Глубокую признательность ведущему ученому.
We are very thankful to reputed scientists from India. Your scientific achievements and expertise will produce its meaningful contribution. We would like to give the floor to the Chief Oncologist of the Republic of Azerbaijan, Director of National Oncology Center, Mr. Azat Aydin Oglu Kerenli. Please, sir, floor is yours. Good afternoon, everyone. How are you? I would like to wish you solid health. First of all, I'm not a director of the institute. We have director Mr. Jamil, and unfortunately he couldn't join us today. And on behalf of Mr. Jamil Arzi, I would like to wish our Congress successes, and I would like to thank Mr. Tilashaykhov for his kind invitation extended, and I would like to express my gratitude to the oncologist of Uzbekistan. So we are here at the FIS Congress of Oncologists, and it shows that you are paying significant attention from the government to the development of oncology. I have heard that you have a new premises, I mean your oncology center, which and I would like to congratulate you with this, and I would like to wish successes in the activities of this center. Recently in Azerbaijan we have held the first conference of Turkic language speaking countries for oncologists, and I'm very thankful for Mr. Tilashaykhov that they have paid their visit, they have participated at this event, and we have heard a lot of interesting reports by Uzbek oncologists which shows that you have a lot of interesting developments, and I would like to wish you successes in all of your endeavors, and I would like to wish you family happiness, prosperity, and keep up the good work.
Благодарю вам.
Спасибо, господин Азад Айдын Оглы Керемли. Слово предоставляется председателю немецко-узбекского медицинского общества Кох Авиценна, профессору медицинского университета Шарите в Берлине, доктору медицинских наук.
We would like to give the floor to very well-known scientists and microbiologists who have meaningfully contributed to the development of cooperation between Uzbekistan and Germany in the field of oncology. Mr. Helmut Hahn, please, sir, the floor is yours.
Mr. Chairman, Minister, dear colleagues, dear friends, it's a great honor and a great pleasure for me to be able to speak to you at this occasion. The relationship in medicine between the Republic of Uzbekistan and the Federal Republic of Germany is based on our long experience, and the foundations of our Western medicine actually were laid by Ali ibn Sina, whom we call Avicenna, who lived around 1000 AD, and whose book, the Quanon, was the leading medical publication for many centuries in Western Europe. So cooperation between European states such as Germany and the Republic of Uzbekistan has a long tradition. And I'm very proud that I was elected president of this Objestva, this organization named after Avicenna, the leading Uzbek doctor, and Robert Koch, one of the greatest German doctors of all times. We have, over the last few years, had some very good successes thanks to the support of the Uzbek government, thanks to Minister Udaryakov, and thanks to our colleagues, Professor Tilashaykhov. And the highlight of cooperation in this year was a partnership between the newly started, by fusion, started TransMed, the big medical university of Tashkent, and the University of Lübeck, the State University of the state of Schleswig-Holstein. And if I may add my hope, it is my sincere hope that as many as possible academic institutions will become partners between Uzbekistan and Germany, because universities are the future. These are the students who will carry on the work of the ancestors for the next generation. So I'm very happy to be able to relate this message to all of you and ask you to further support our activities, the medical cooperation between Germany and Uzbekistan. Thank you all very much indeed, and I wish you good luck for this wonderful, most impressive conference. Thank you.
Thank you, Mr. Helmut Hahn, for your participation in our forum. Уважаемые участники, дорогие
Dear participants, dear friends, and since we have very agenda, very, I would say, hectic schedule of our minister, we would like to thank His Excellency for his kind participation, and with your applauses, we are saying bye to His Excellency, and we will proceed with the work of the forum.
Слово для приветствия предоставляю.
Now we would like to give the floor to Mr. Bekmuhamedov Yerbor Jasulanovich, to the principal of West Kazakhstan University. Well, you have a bit old-fashioned information, because recently the Ministry of Health of Kazakhstan, we had a meeting on the preparation of the Days of Kazakhstan Medical Kazakhstan Medicine in Uzbekistan, and we have paid a significant attention to oncology. And so, upon your kind permission, I would like to read the congratulation letter to Mr. Telashaikov. So we would like to congratulate you on the opening of 5th International Congress, Opportunities and Prospects of Modern Oncology. And we would like to mention that consolidation of the efforts of Uzbekistan and Kazakhstan has a strategic importance for strengthening cooperation, and the Congress will become a platform for strengthening professional dialogue and development of professional solutions. I would like to wish you fruitful event ahead and meaningful discussions for the sake of serving health and prosperity of people. I would like to hand over the letter to His Excellency Mr. Telashaikov and our Kazakhstani National Research Institute of Oncology and Radiology, and we have National Oncology Center. So we have 2 scientific research centers are ready to cooperate both in clinical research, in the training, education, and research and development. Thank you so much, and we would like to express our gratitude to you, Mr. Yerbol, and let us proceed. We'd like to give the floor to the professor Madam Dilara Kaidarova, President of Association of Oncologists and the Chief out of Staff Oncologist of the Republic of Kazakhstan, please. Dear friends, dear colleagues, good afternoon. It's our pleasure to have all of you here on the behalf of Kazakhstan Oncologists Association. I would like to express my gratitude for a chance to be a part of today's event. Our friendship lasts for 60 years by now. I mean, the friendship between oncologists and Kazakhstan and Uzbekistan, and we can feel and can see the intense development of oncology in Uzbekistan, and we are very happy for our colleagues that they have started their work in new premises, which is absolutely equipped with the advanced and state-of-the-art equipment. I mean, their long time dream came true, and of course I have one address from the principal of Kazakhstan Scientific and Research Institute of he is a principal of this research institute. He expressed his sincere gratitude for us to have a chance to be here, and at the moment the development of science, of education and of research and development goes hand in hand, and all of the scientific discussions which we are going to have here, I'm pretty sure will be very useful for our young scholars. And I would like to give you the address. Let me hand it to you hand in hand in person. Yes, thank you so much, Madam Dilara. And now we would like to give the floor to the Minister of Health of Karakalpakstan, Mr. Murat Kurbanov. Please, sir, floor is yours. Good afternoon, dear panelists, dear guests and colleagues. On the behalf of the government of Republic of Karakalpakstan, I would like to express my sincere gratitude and my best wishes to the participants of the 5th Congress of Oncologists and Radiologists. As well as you know, Republic of Karakalpakstan is the area which has been significantly affected by the Aral Sea drought, and therefore a special focus on the health of the people of Republic of Karakalpakstan, which is paid by the president. The special attention which is paid by the president of Republic of Uzbekistan is very important, and oncology is not left aside. So according to the presidential decree number 310, we have started construction of a new oncological center in Nukus city. They have allocated a significant budget, and we have our oncologists guiding us on this way, and I'm pretty sure that they will be very successful, because our center has significant experience in introducing new technologies, and these technologies will be working, will be producing their meaningful impact, and it will be in Nukus city. So I would like to express my sincere gratitude to His Excellency President for paying such a special attention. I will not take much of your time. A lot of things have already been said. I would like to wish you successes in today's forum's work and fruitful endeavors ahead. Thank you so much, Mr. Minister. And we would like to give the floor to the Health Management Manager, Mr. Delmurat Agül, please, who has been who is a graduate of Hacettepe Medical Faculty of Medical University. So for 21 years he has been working as a manager of hospital, and he works in Turkey, in the Republic of Uzbekistan, as the head of center.
Valued scientists, I feel great honor to be here with you at the International Oncology Congress. This Congress is not merely a scientific gathering, but also represents a coalition of strength in our common fight against cancer, one of the humanity's greatest health battles. We take pride in serving in the management of the Republican Specialized Scientific Practical Medical Center of Oncology and Radiology within the scope of the project carried out through the valuable initiative of the Ministry of Health of Uzbekistan. As Turkish administrators, we will contribute not only to the administrative and financial structuring, but also to the preparation of the institution's strategic planning. I would particularly like to emphasize that the Republican Specialized Scientific Practical Medical Center of Oncology and Radiology is one of the most important oncology centers in the region, with its modern diagnostic methods, advanced treatment applications, experienced specialist staff, and patient-centered approach. The achievements in surgical oncology, radiotherapy, and medical oncology have made this center a reference point not only for Uzbekistan, but for all of Central Asia. Our mission is to further develop the existing strong infrastructure, maintain quality at international standards continuously, and increase the center's contribution to global oncology literature through scientific research, particularly the studies to be conducted on next-generation treatment approaches. Immunotherapy and targeted therapies will enable much more promising results to be achieved in the future. These visionary steps toward making Tashkent a regional health and research hub in the field of oncology will strengthen not only Uzbekistan's but the entire region's capacity to fight cancer. This cooperation between Turkey and Uzbekistan is an indication of both our common cultural values and our shared responsibility for human health. As I conclude my remarks, I wish that the Congress will lead to new scientific collaborations and serve as a source of inspiration and strength for all of us in the fight against cancer. Last of all, we should all be open to innovation and not only scientists, but also managers. Thank you, with my respects.
We extend our sincere gratitude to Murat Akgül for joining us today. Уважаемые дамы и господа, для
Dear ladies and gentlemen, we would like to give the floor to the public deputy of Oli Majlis, very famous medical doctor who is supporting the development of oncology service in Uzbekistan, Madam Yelena Borisova. Please, floor is yours. Dear ladies and gentlemen, good morning, dear participants of FISC, Congress of Oncologists and Radiologists. We who are focused on the development of oncology and radiology, whose efforts are focused on oncology and radiology, and I'm very thankful for your invitation to participation of event. I am Deputy Chairman of the Committee for Labor and Health Care of the Legislative Chamber of the Parliament, and I am a medical doctor by my educational background, and the Legislative Chamber of the Parliament we are closely supporting the reforms in healthcare and oncology has its own, I would say, specific dedicated place in our focus area. Under the leadership of President of Republic of Uzbekistan, Mr. Mirziyoyev, we have achieved significant successes in medical treatment and in reforms conducted in the healthcare sector, including three-stage model, and we will have 3 levels, which is the primary medical assistant and of course emergency medicine. So we are planning to expand also private sector's participation and expand the coverage and drug provision. So I would like to especially mention that in order to ensure legal basis of reforms in healthcare, the Parliament of Republic of Uzbekistan is adopting respective legislative acts, and each of the citizens of the country can experience positive changes which we have in healthcare. And according to Uzbekistan 2030 development strategy, we are focused on strengthening our capacity and enhancing our potential and improving life expectancy up to 70-80 years and reduce early mortality from oncological disease 2.5 times, which is very important indicator. And in recent years, the average life expectancy grew from 73.8 years to 75.1 year. And the 17th goal of this strategy is early diagnostic of oncological disease and reduction of indicators of mortality, and indicators which are supposed to be achieved by 2030 is early identification of oncological disease in 69 years age category, and increasing twofold oncology life expectancy after surgery should be increased to 5 years, and reduce mortality from oncological disease up to 1 year. So within these 7 years, dear ladies and gentlemen, the funding of medical and healthcare institutions grew several times, and we had over 400 of high-tech oncology surgeries are conducted not only in Tashkent but in all the provinces of Uzbekistan. So people now have no need to travel to Tashkent to get high skilled and high quality treatment. And we had a comprehensive system of oncological assistance in the country. We had a single vertically integrated system of oncology assistance, and we are providing the high tech advanced equipment, and also we are nurturing our people, we are nurturing our specialists and scholars. And in the today's opening inaugurational speeches by Mr. Telashayev and by His Excellency ministers, they have already highlighted the important milestones of developments of oncology in Uzbekistan, and you will hear a lot while today's Congress in our presentation regarding the development of oncology. But I couldn't but mention with all of my pride that based on initiative of our president in Tashkent, we had new oncological center which was constructed and inaugurated in Central Asia. And one very important I would say indicator which I would like to draw your attention is that the funding to chemotherapy were grown 11-fold, and our legislative chamber of the parliament has a public hearings on report reports by ministers, by the head of entities on funding, construction, reconstruction and refurbishment of medical entities, and growing the number of growing the number of funding and medical centers and medical doctors. So previously we have been also sending our report regarding the work on improvement of medical assistance to oncological patient, and we want to actually have interregional hospices, and we are working this particular direction, and definitely it will be done in coming years. And by 27th of May 2025 we had considered the reply by the Ministry of Health on prevention and early detection of oncological disease among population. So we in the Parliament are focused on improving legal framework of healthcare reforms, and we render all of our possible support to development of healthcare. And I would like to express my sincere gratitude to a leading scientists for their contribution in development of scientific reforms, and I'm pretty sure that today's event will be very important, and it will render a platform for exchange of opinions and developing new strategies in combating oncological disease and improving health of our people. As a concluding remark, I would like to wish you a solid health, peace, prosperity, and definitely fruitful work ahead. Thank you so much for your kind attention.
Благодарим вас за...
We would like to thank you so much for your meaningful speech, and dear guests, dear friends, since we are not meeting the timeline, with the coffee break will be at 11:30. And now we would like to move to a plenary session. And according to our schedule, I'm supposed to give the floor to Mr. Telashaikov, but I would like to give the floor to the first deputy center, please. Mr. Yusupbekov, floor is yours. Dear guests, dear friends, while we do not have Mr. Telashaikov with us, I would like to deliver his report, which is dedicated to oncology of Uzbekistan, state-of-the-art status. So talking about disease prevalence, you can see we have 76.3, this indicator, and definitely we have the number of, in Uzbekistan we experience both the growth of population, the growth in number of population, and at the moment we have 38 million of people in the country. And you know that 75.1 years is life expectancy, which we have managed to achieve, and we have mentioned that the indicator is 50. I mean, the prevalences is from 168 cases per 100,000 of people, and you can see the disbursement between men and women. You can see that for men it's stomach cancer, and for women it's breast cancer. So you can see that for men also the second place is held by lung and bronchus cancer, and the third place is occupied by rectum cancer. And for women it's breast cancer, cervical cancer, and of course it's very important to mention that we are having we are also having the ovary cancer, and that's why we are focused on preventive care. We have mentioned that the number of patients which are registered is 133,000, and the number of primary early detected oncological disease totaled 28,300 persons. So we are identifying 26% of disease at the early stage. Talking about the colorectal cancer or stomach cancer, we are identifying them quite early. So talking about early detection of disease, of course we are working, and we are focused not only on modernization of the premises of the Center of Oncology, but also of our affiliates in the provinces, and it's very important. But unfortunately what we are facing that all across the country, only at the first and second stages, 50% of disease are detected. So that's why first place is held by Namangan, Fergana, and Andijan, where around 67% of cases are detected at the first and second stage. And talking about third and fourth stage, unfortunately, indicator is 43.5%. And of course, in Tashkent, we detect 56.3 cases in Tashkent province, and the less, the indicator is, I would say, the smallest number is in Navai province, and 5-year survival rate in Republic of Uzbekistan was around 42%, and you can see that it produces, our efforts are producing the impact on growing number of people who are having these 5-year survival rates. And talking about mortality, it's 41%, and 1-year mortality is 16.3% among primary detected patients, and we are focused to reduce it by 13%, and we are trying to achieve these good results in reducing 1-year mortality rate. And you can see that we have the presidential decree number 2866, which has shaped the system of oncological assistance vertically integrated under the Ministry of Health. We have 15 affiliates of the Republican Scientific Medical Center of Oncology and Radiology, and 223 oncological departments all across the regions. And talking about hospital beds, you can see we have plus 200 beds all across the country, and we can embrace 2,500 patients with beds in hospitals, and we are also having private sector who has around 500 beds for oncological patients additionally. And as our minister has mentioned, we had 5 presidential decrees within these 8 years plus 3 decrees by the cabinet of the ministers of Republic of Uzbekistan, by the government I mean. So we have invested not only the budget funds but also the funds from our international financial institutions, partner institutions, and we have the first project number based on the first tranche by Islamic Development Bank, and we had 15 all of our, I would say, oncological hospitals. They have been transformed as affiliates of Republican Oncological Center. We had conducted reconstruction of 8 oncological affiliates. 3 of them have been capital refurbished and 3 of them have been constructed from scratch. We had 18 equipment for beam therapy and 2, I would say, line accelerators, and 11 gamma therapeutic and 7 brachytherapeutic equipment. And at the moment we have 27 radiological apparatus which are fully covering our demand for X-ray therapy. And together with International Agency for Atomic Energy, based on the loan from ISDB, we had trained 53 of our medical doctors in foreign countries, and it was fully funded by the government budget. Well, and talking about second project which was funded by Islamic Development Bank, which was also funded together with the government budget. You can see we had our oncological center premises which has been constructed, and it has 650 hospital beds and capacity for outpatient treatment, and we have procured equipment, and certain part of these 80 million USD were also channeled to equip our affiliates in the provinces. We had 3 line accelerators, for example, procured, and the third project is construction of our oncological center, and the construction commenced in 2021 after the visit of the president to our previous center, and we have decided that we must construct a new center and have the state-of-the-art equipment and create all the best possible conditions for this, and thanks to this center we had the measures which have been taken by our government. You can see now the snapshots of the visit of His Excellency to the center, and it's not just a new equipment. We have also the specialists who are meeting the, I would say, the most important requirement, who have been trained in foreign countries, in the leading foreign institutions in South Korea, for example, and in the leading centers of Turkey and partially in Germany. So at the moment our new center has all the opportunities, and we are working at the large scale, and we have the fourth project, and we had the declaration which was approved by the president and the government. So we are planning to construct new oncological center in new Tashkent city with 300 hospital beds, and we will be attracting 150 million loan from Korean Exim Bank, and we are working on elaborating feasibility study. We are very thankful to our foreign colleagues from Korea, and we are very thankful to Mr. Dr. Dinesh, who helped us to adjust the standards and clinical recommendations on oncology. And Of course, all of them are reviewed and approved by the Ministry of Health on annual basis, and we have the presidential decrees also. We have a lot of, I would say, chemical labs, and I mean, it is something which is unimaginable. It was unimaginable 5 years ago, but at the moment, our center has a lab for molecular researches, and we have invited not only our own specialists but also the specialists from CIS countries. And talking about nuclear medicine at the moment, our center, as I have already mentioned, we have radiological equipment, and we have line accelerators in our center, and in Tashkent, in Bukhara, in Tashkent province. So we are having also the plans to engage a private sector based on PPP, and at the moment, I can tell you that we are having CT, which is called a positron PET tomography. We have a PET at the moment equipment, and our medical doctors are using this nuclear medicine based on PPP, and also our government. And also research are funded by the fund, which means that the patients are getting treatment absolutely for free, and I at least can share you the data, and thanks to guaranteed government assistance, our patients underwent this important treatment for free, absolutely for free of charge. And talking about screening for cervical cancer, for ovarian cancer, and for breast cancer, we are very thankful to World Health Organization and to the expert from other international organizations under UN umbrella. They are taking very responsible approach, and it started with a pilot research, and of course we had assistance in terms of having breast cancer screening in Karakal, Pakistan, and near Aral Sea disaster area, and we are having ovarian cancer and breast cancer screening. So we are covering all the remote areas with our mobile visit, and you can see that here at least we had women who underwent this screening, and of course they have been checked for the pathologies in reproductive system. And a very important thing which we would like to mention is having our single so-called reading center, which is a unique center based on Turkish model, where we are having the screening of breast cancer, and the prior preliminary reading is done there, and the important screening is done, the key one is done in our center, and we have the personnel with us, and of course we are focused to help our regional screening centers also. And one very important thing which I would like to mention is that we have been working on so-called cancer registry, and we have embraced a lot of specialists, and as I have mentioned, we had a training on treating our specialists, and I have already mentioned we have our oncological patients registered, and this cancer register will give us the best opportunity to check our patients, to check the prevalence of disease in the regional disbursement, and we have so-called the situational analysis center, and it will give us an opportunity to develop the strategies on early screening. And talking about treatment in terms of availability of drug, we have mentioned that 5 years ago we had only 1.2 million USD for these drugs, and at the moment the drug supply grew 11-fold, and budget is allocated 13 million of USD. And all of these targeted drugs are bought from government budget. They are procured from government budget. And at the moment we have quite high indicators of efficiency of chemotherapy. And we are having so-called outpatient replacement methods. We have outpatient methods, and it showed itself as very feasible and efficient. And we had so-called outpatient chemotherapy rooms, departments, and this is one of the, I would say, biggest departments, not only in Central Asia, but I can tell you in Eurasian region, for 100 beds. And as Mr. Dinesh has mentioned, not only all the center has such a good conditions, and of course they have all the required facilities. And also I would like to draw your attention to so-called palliative assistance, and we have our young enthusiasts who are closely cooperating with various entities, and at the moment we have 3 hospices, and we are also planning to have central hospice in Tashkent city, and we have finalized our construction works, and these hospices will be fully refurbished. So palliative therapy is very important, and within this in framework of international cooperation section, I would like to mention that we had 26 MOUs which we have entered with leading international institutions and clinic. And MOU is not just a paper, to certify that we have entered in a certain agreement with somebody. No, it shows that our specialists underwent significant training, and of course I would like to express my sincere gratitude to Mr. Kaprin and also to Mr. Sergey, so I mean all of our leading specialists for their assistance in training our specialists in your medical entities. So, of course, they had the chance to undergo training in Germany, in Belarus, in US, in the leading centers. So we have underwent training everywhere where they had a chance to be trained. And so we have specialists not only from Tashkent trained, but from all across the country. So we have 3 centers of so-called nuclear medicine, 2 of them private and 1 of them is fully government funded. We are having PPP relations with private centers. And talking about prospective directions of cooperation, we will be focused on screening of breast cancer, ovarian cancer, and cervical cancer. And also we will be focused on colorectal and stomach cancer, and we will be rendering these services, and we are going to embrace the whole country with these services. And of course we are going also to focus on development of outpatient hospice and palliative assistance, but we hope that this hospice assistance will be also included in the oncological assistance. And talking about full-fledged operation of oncological assistance all across the country, we can tell you that we should be focused on the so-called cancer registry, and definitely these we have departments of transplantology, and we have all the possible conditions for transplantation of bone marrow. Because in our country we have transplantology of organs, we have already trained personnel, but if you will not be treating them properly, of course it will not be successful. And we are also going to be focused on so-called less invasive surgeries, and so you were also absolutely right that thanks to Professor Teleshaykhov, we are doing not only on oncourology but also in pelvic, in oncogynecology, and colorectal surgery. So we have also a treatment of esophagus and of stomach using less invasive methods. And we will also receive the second tranche of funds from Islamic Bank of Development, and next year we are planning to boost in surgeries, less invasive surgeries, not only in Tashkent but also to develop them in the provinces. So it will create new opportunity for us. We will have all the chairs of oncology, and they will unite the efforts with regional oncology chairs, and it will boost both theoretical and practical knowledge of our students. And of course you will, dear students, have more opportunity to learn from practice. And we will be focused on development of molecular medicine. There are a lot of work which we have to conduct at the moment, and of course we have the clinical radiology with us, and we will be working in this particular domain. And of course all of these prospective directions are included in our national program of combat against cancer, and definitely this project has been developed. I'm very thankful to our coordinator, Mr. Delshode Gambirdeev, and availing myself of the opportunity, I would like to express my gratitude to Mr. Rolando, who is rendering his meaningful assistance, and we have our NSCP program by 2035. So where should we invest our efforts? And of course it is very important because this project has already been inaugurated, and I'm pretty sure that together with our foreign partners we can produce some meaningful results. Dear colleagues, thank you so much, and in case of any questions, I'm at your services. Thank you so much. Dear colleagues, now I would like to invite all of our moderators. Please, sir, we would like to call all of you on stage. Professor Kaprin, please kindly do not leave us. I would like to call Dr. Axel Richter. I would like to call Mr. Rolando Comacho, Mr. Khatskov, we would like to give the floor to Mr. Kaprin. development of oncological assistance in Russian Federation. Please, Mr. Kaplan, floor is yours. You have mentioned it will be interesting report, but what we will do if it will not be interesting? So, and now I would like to mention very important fact that we are having oncological assistance developed. And we will not be talking about statistical data. We will be discussing new methods which we are introducing in Russia. And one very important thing which I would like to mention, we definitely have not thought about this, but we have such important scientific area as proper organization of oncological assistance. And we used to think that it's not that important, but now we understand that it's extremely important, and it produces meaningful fruits, including channeling patient to a specialist and everything. You know, when you are trying to do something, you should think out of the box. So you can see our famous oncologists Herzen and Petrov, who have helped us with oncologies, and they have their own medical, I would say, schools established. And Mr. Petrov was the one who had the screening of cervical cancer put in place, and also we had 30 years of oncological service of USSR, and look at when it was signed. It was signed in 1945 on 30th of April. So we had the Second World War, but still people were thinking about how can we combat oncological disease, the enemy which will take the people's life just for granted. Several days before victory in the Second World War, such a decree was approved, and everyone was taking into account that if you have no leader, you cannot proceed. Therefore, we have heard from President Putin that there should be an indicators that and you can clearly see the survival rate, and you can see the 1-year mortality. And I guess only here in Uzbekistan and probably in a couple of CIS countries they have it, but in other countries, no, they do not have it. So we think it's quite important indicator. How do we have this service organized? You can see we have a lot of important things introduced. For example, we had 4 national medical centers. One of them is ours, which is headed by me. And we had we have also dispensaries and hospitals, and we have 18th reference centers. So we are having the vertical systems from lower tier to upper tier, and we are also having medical consultations rendered, and medical consultations. We have understood it even at COVID period that though we had such isolation at that period, and that we need to render the assistance to our colleagues in provinces, and each of these centers has 20-25 consultations, and we are sending the I would say images in very good quality of image, and we had around 6,000 of, I would say, glasses, expanding glasses. So we had 569 centers and outpatient assistance. Previously, these oncological centers, they were not properly equipped, but at the moment we have everything, and for us to render chemotherapy at a proper level, we are working on this. And when we have been creating it, we had a lot of people opposing us, but now everyone got used to it. And even before my trip, the chief oncologist of Dagestan came to me, and he told us they have very remote, rural, mountainous village, and they can have such a lab. So I mean that it produces impact, it's meaningful, and we are very happy that we have it. And we had very strong oncological registry, I can tell you, and our institution has 3, I guess, registries, and I had pictures. And you know, we have previously been sending them in envelope from one place to another, and so we are having this, and this registry has a lot of parameters, and we are sharing absolutely for free with everyone. You can go and you can check it, and we are also printing it, and we have some other also printed materials with us. We have very interested registries, and because all of them are fully funded by the President of Russia, and they are located in Obninsk city, and they have a lot of people who are dealing with the national registry. And the registry, which is embracing radiological and epidemiological registry, and we have people who are working with people who are working with nuclear industry. So we have 800,000 of people who are working, for example, in nuclear submarine and others, and it gives its fruit. You know that we had problems. You probably have heard about the tragedy disaster in Fukushima, and they visited us also, and for 2 years they have been closely working with us. They have been thinking about should they relocate people from from Fukushima area to the other area, and they have been always checking, and now we are not closely cooperating with them, but I'm pretty sure that we have such a competencies comparing the others. And so in 2024, Russian Federation for the first time has identified 698,000 cases of new cases of cancer. And what we have to understand is that epidemiological and demographic indicator which we cannot produce our impact to, and we are talking about for example, bad environmental condition that we have, for example, 470 persons per 100,000, we cannot produce any impact on prevalence. We can move patient from the 3rd stage to the 2nd stage, rather from from 3rd stage to the 4th stage, which is mortality. So, for example, we have countries with I would say Norway, Denmark, these countries with a small, number of population, but they have a very, I would say, good conditions. So when somebody tells that you are having a small number of cases detected, it means that you are not working properly. But if you are having less mortality, that's great. You should work not on detections number reduction, rather on reduction of mortality. So it is also additional load, but still we need to work on this. And you should work on treating patients. And what we have witnessed within these years, you know that government introduced the program on combating oncological disease, and government is rendering its assistance. And one thing which I have to mention is that we had 841 so-called line accelerators and etc. Unfortunately, we do not produce them by themselves, but we are buying them. And technical services, it's also technical maintenance, it's also very expensive thing. And of course, the equipment, should we have our own equipment, it would be much easier for us to live. But very interesting thing is that these reference centers which we have, including the center where I am working in, and it's very important because also it helps us to reveal the pathologies. And what I know and what all of us know is that we are having the deficiency not only in medical doctors, the number of medical doctors is true, the whole world lacks 4,300,000 of medical doctors. Therefore, we need to have these consultations, we need to render our assistance. And I couldn't but mention the development of radiology, which is one of the most prospective treatment methods, and it's very important. And of course it's very meaningful because it produces also significant amount of profit, because the government funds the treatment. And you can see the people, the scientists behind. Everything started with a nuclear energy project, and so in 1958 we had the first nuclear power station in Obninsk city constructed, and we had together we have been working with our scientists because the medical doctors were called to check the impact of nuclear radiation on the human health, on cells, on living organisms. So it's very important equipment. And I have mentioned that we hadn't breakthrough technologies previously, but it's our engineer, Mr. Balakin, has developed this equipment. This is called proton accelerator. I do not know, have you seen this one or not, but this is very good because this accelerator, you can place 4 accelerators in one room, and it's not just a gantry, around the patient. It's a patient which is located in the beam. So it means that it's a focus beam, streamlined, targeted. And of course, our Japanese colleagues have also understand the importance of proton therapy, and you can see that we have actually some niches for proton therapy, and we have the brain, we have of course pediatrics also, and here, I mean, our center is assembling so-called neutron generator. It will be quite small, and it was produced by Rosatom's Dukhov Research Institute, and we do hope that it will help us to overcome radio resistance of such malignancies as sarcoma. And we also have so-called nuclear drug stores where we can synthesize all of the incomes with radionucleotide inside, and so we have the drugs which we produce and which we use, and we know that all of these namings are for patients who have advanced degrees, for example, metastasis or visceral metastasis. So we have very interesting protocols about cancer, about the chemo and radiotherapy. So you can see very interesting localization which have not, which have been resistance. For example, the thyroid, you know it better, but also Lutathera is a very interesting drug which works for neuroendocrine cancers, because they cannot undergo neither radio treatment nor drug treatment, and we have so-called diagnostic. You can see that how the certain, for example, malignancy is receiving this radionucleotide, and it is colored, and it will become a very good target for a radionucleotide. So we have very good drug for cancers also, and you can see a very interesting drug, rhenium-188, and it is very good in case of arthrosis, and we think that this drug is has very good prospects. And also we have hepatoren, MRNC. So you can see how we have endovascular impact. So it is used while liver cancer, in case if we cannot conduct surgery, and we are conducting so-called radioembolization. You can see the reduction of the cancer, and of course it helps us to conduct resection, and we are studying this disease, and you can see so-called pathomorphosis. Sometimes it's complete fibrosis, and it was fully patented by our center, and of course we are ready to provide so-called endovascular surgeries, and we are ready to exchange experience, to share our experience, and talking about biotechnology drugs, we can say that it can be done. We have one GMP production with us. It has been patented by us in Obninsk, and in Institute of Herzen we will also get the patent for CAR-T therapy, not for hemoblastosis, which was quite understandable for everyone, but we have done it for so-called cellular disease, but we need to work, we need to have so-called GMP production, but anyway it should be done. And for us to have this therapy developed, you have to have so-called the passport of this malignancy, and we have received the patent by the Ministry of Health Ariadne system, which helps us to conduct genome sequencing, and we have it's quite expensive, and we can render these services free of charge. Otherwise you will not have the profile of the malignancy for vaccine production, but we are working on individual, on so-called personalized vaccines produced, and we are together working together with the Institute of Engelgard. So for us it's very important, and our center is focused on the development of so-called telemedicine. We are open, and it's not expensive for us. I would say it's absolutely free of charge for our centers, but we are rendering our consultation, and it's quite interesting. Why? Because if you are, I would say, heading one of the major oncological departments, and when you see how you are I would say recommending certain treatment to your patient, would it be a drug treatment, and you are as an expert checking whether these tactics was correctly chosen, and it's very important for you because you are having the idea about the level of development of your specialists, and even if you can see that your specialists are moving, I would say, in the wrong direction, you know that something he's missing something, and of course you need to learn more, and we are open for cooperation, and I will show you that if I am running short out of time, or if I have consumed your time, let me know, and just 5 minutes of your time. We are having a lot of less invasive disease, and we are having mucosectomies, and our center is the leader in so-called oncology and reconstructive surgery. So for head, for tongue even, and I will tell you a very interesting story. Unfortunately I cannot show you. You can see that this patient, he had half of his tongue removed, but he can speak. And we have so many patients, and here we have Mr. Professor Kopotov with us, and he is very good surgeon, and we have two departments run by Mr. Polyakov, and you can see that they have their own prosthetics, so that they can fully restore all these patient, and we had microsurgery grafts. So for 7 hours we had surgery. Now the surgery is conducted for 2 hours, and we are having so-called 3D printing in surgery. We have 3D printers, and we are conducting a lot of proactive efforts, and we are not just a clinical center, we are also a training center, so we are rendering a lot of educational opportunities. So I would like to mention that our PhD fellowship degrees is proactively developed together with Uzbekistan, and it will be absolutely for free for your, I would say, fellows. So I can show you the prospective areas of our cooperation. I will leave the presentation for you, and you can identify the areas of cooperation. Thank you so much for being so patient to listen up to my report. I'm sure it was not interesting, but it was too long and too time consuming. So, dear colleagues, we would like to give the floor to strategy of combating oncological disease. Please, Rolanda Camacho.
Эксперт пост по планированию борьбы с раком.
Здравствуйте. That's the only word I can say. But good morning. I want to thank first the organizer for inviting this invitation to the meeting. Really, I am very proud to be here today because of the people I am sharing this experience. The National Cancer Control Program the concept is important because sometimes we see so many things that are ongoing in the development of oncology, in investment, in research, in treatment, in everything, but the Cancer Control Program is the only structure or policy that can plan everything for one country, one full country. It's a public health program designed to reduce cancer risk factors in collaboration with the NCD program, the incidence of cancer, the mortality for cancer, and the inequality in cancer care. Improve quality of life of cancer patients and their families, because also the family has to be considered. And through the systematic and equitable implementation of evidence-based. That's extremely important, evidence-based. We do many things sometimes without justification in the evidence to our setting. For the promotion, prevention, early detection, diagnosis, treatment, and palliation, including the best use of available resources. That is extremely important, and this is the concept, the definition of WHO for cancer control programs. WHO has been providing guidelines for this from the 80s, but in 91 was the first guideline for preparing National Cancer Control Program. This is the yellow one that you see there, the book in the bottom. I have the honor to be one of the youngest oncologists at that time who participated in the development of this document, and then during years, WHO was preparing this type of documents until 2002. But there are many modules, there are many documents that have been developed afterward, and then really has been an important steps in the development of cancer control program. The way to do that is planning in different steps. First step is where we are now, the assessment of the situation that we have. Where we want to be, and how do we get there. So it's important, these three steps. And also, it's important to consider that the National Cancer Control Program has to be included in all actions that you do for improving the health in the country, in the context of the NCD programs, in the context of the health system, in the context of the countries and the country itself, and also in the world context. The key issue with the National Cancer Control Program is the leadership of the Minister of Health. Without the leadership of the Minister of Health, it will not work. And then the support of all sectors, including private sector, civil society, and so on. And it's a way to strengthen regional, national capacity, leadership, governance, multi-sectoral action, and partnership. Doing the cancer control program, the country gets all these parallel benefits. and also must cover all area of cancer control, from prevention, early detection, diagnosis, treatment, and palliative care. That's extremely important not to exclude any area of cancer control. All of them are important to guarantee the best care of the patients. There is a background that normally you find in every place. I will not read it extensively because I will refer to the case of Uzbekistan. So the example of this you will see in the example of Uzbekistan. But the most important thing is that all the investment we do, you have been seeing many investment from this country, which is I applaud, but has to be in the comprehensive national cancer control strategy, because it's the only way to plan ahead. For doing that, the first thing is to do a co-drafting group. You have to have a group who really start to work. It's not a matter of one person or one external expert or so to draft the program, but to have a small group of committed people. I want to insist in that because that's extremely important to do the best cancer control program, and to have a leader, a coordinator, and the specialist should be representing all area of cancer control, and has to have a very well-defined time frame. Also, in the structure of the cancer control program, you have to have a technical external advice. In this case, WHO normally provide this. And then prepare the drafting group, prepare the draft zero. This is a situation analysis, a specific objective, priorities. You have to be the whole, to see the whole, to decide what are the most important actions to be done, the most effective actions to be done now. And then after that, they have this draft to go in virtual consultation with the national stakeholders. Every people here who works in cancer control should provide the input in that. And then after that, also a workshop to discuss the draft, and then consultation with the international organizations. The strong governance is important step here, because if you don't have a strong governance, it will not be probably easy to implement the cancer control plan, no matter how well designed it is. So you have to have an advisory committee, which is the high-level people, the decision makers, and then they should not meet every day. They should meet at least once a year, and to review the progress of the cancer control. The objective is to review and approve what is the next step that we will do in the country. And also a technical advisory committee, very technical, not the high-level decision makers, but the people who really knows about the specialty, those who are leaders in the country, and also include people that will be responsible for the implementation, so they can advise in how to do it in practice. And should be officially appointed. It's not people that you invite. People who have to be appointed when you approve the National Cancer Plan. And also, not to be so big. They have to be a good number of members, from between 10, 12, and then have groups that each of members will work with this group. And this one meet more often. Then, it is important for the implementation to ensure that the focus of the actions that you do are based on the most common and important cancers, preventable cancer, curable cancer, because sometimes you cannot do everything that you know that is possible to be done. It is important to understand that. You have to have a selection of actions that will impact, not everything that you know that could be done. And then has to be cost-effective, using a viable resource, because sometimes we can plan whatever we want that is probably viable in Russia, for instance, with a high-income country, and then we don't have the resource for doing that. So we have to be careful in this, what we can plan for our context. And then to evaluate the outcomes. You have to keep monitoring and evaluating this program all the time. Have the budget, activation and implementation has to be adopted. I'm sorry that the member of the parliament left, but it is important that even the parliament approve this program and is aware of this program. And then communicating and marketing. What is the current situation in the world of these cancer control programs? There is an international cancer control partnership as a group who has been assessing 98 cancer control programs in the world. What is the situation? You can see that even those who have cancer control programs have problems with the identification of the needs. For instance, nearly 75 of the plans will not include financing strategy. If you don't have financing strategy, you cannot implement your plan. You have to have it. Only 23% of the NCCPs include evidence-based reference. So sometimes actions are not supported by reference. And also 50% of the plan do not include radiotherapy strategy, which is how can you have a plan without an important element of the cancer treatment? And only 26 mention WHO list of essential oncology medicine. So you have to follow some kind of pattern, especially in the medicine. We are very costly nowadays. And many show challenges in connecting screening programs with quality of treatment. So you do not do nothing with detecting patients early if you cannot guarantee the proper treatment. What is the case of Uzbekistan? When this ICCP analyzed the case of Uzbekistan, it was not applicable. You have no qualified, you have no plan. But these are important documents. I will say the Presidential Decree 242 about the modernization of oncology, and then also you have the impact mission in 2022 who recommend to develop the cancer control plan. You have one of the specific actions of this recommendation was specifically in this development of the plan. I will just pass this because it's and then what is going now? Leadership of the Minister of Health, yes. So what we were talking at the beginning, the Minister of Health is convinced that it needs this. So we have the support, or you have the support of the Minister of Health for doing that, and leadership of the Minister of Health. It's a multi-sectoral action plan. It's preparing with the incorporation of private sector and so on. And you know, the standard of this, the preparation of this plan is around 1 year in most of the country, or more than 1 year. Here was planning the ISDB project for 4 years. The people who did it here did it, the first draft, which is now ongoing, was done in less than 6 months. Also, the cancer strategy covered 10 years with the action plan covering 5 years. So you have to plan to see long, far away, but for planning, for implementing, you have to reduce the time. 2 years and 5 years. The Minister of Health of Uzbekistan decided to work on the development of the first national cancer control strategy and action plan. It was a decision, and the preparation of the draft requested the support of the WHO. That's why I am here. The Minister of Health of Uzbekistan decided to work with the development of the first national cancer control strategy and action plan. This is the preparation of and it was for that it was created this group of national experts, the core drafting group. I will please interrupt my speech to ask the people from this group to stand up if they are here. Anyone who are here, please stand up, please. Please, they are the ones. They are the champions, and I really want to congratulate them because they are the future, not only of this country, but also the region. Experts in cancer control are not common. You too. This is the areas of cancer control and the name of the experts who are here. It's just, you see, it's a small group, but they work really very hard. And more than work, I think that they did also a master's degree in the activities that they were doing this. So they are prepared to help other countries. The drafting group defined the structure of the document, the situation analysis, and also identify priorities and activities. That's why it is important, the composition of the group with all the specialties. And in April, during April and part of March, we have interaction, virtual interactions, about 15 individual virtual consultations. Many hours really of consultation and learning and doing. These are the example of this type of teleconference. And then in the preparation, the coordinating group analyzed the draft 0, which is called the first draft, with the strategy and the action plan. And there was virtual constitution with the WHO experts in the country office, regional office, and headquarters in Geneva. And the virtual national consultation was held in July. It was sent to many people for listening to their opinion. Then the drafting group presented a very short summary of the draft National Cancer Strategy and Action Plan in the workshop a few weeks ago, with the presence of the Deputy Minister, the Director of the National Center, and the WHO people. And then in governance, I will say that what are the key issues. Here they are in the plan to prepare this, all these three groups, who are the National Cancer Control Committee, the Technical Advisory Committee, and also to have a focal point at the Ministry of Health for coordinating all things between the different specialties. This is the Technical Advisory Committee. As you see, the members are in the first row, not so many, but then they have groups, because you have to involve many people. You have to listen to many people. And then there are something that is pending now, which is complete the draft, based on all the input that we have receiving from the workshop, from the consultation, and also from the next consultation with the WHO colleagues. And then we also have to complete the document with the monitoring and evaluation framework, with the human resource development plan, with the budget estimated, because costing is very, very difficult, but estimation of the budget can be done, and the resource mobilization plan. And of course, a communication or advocacy plan. This is the last one. This is the two drafts that we have now, still ongoing, and we hope in the rest of the month and October we can finish this. And thank you very much to the Minister of Health, but thank you very much also to the core drafting group of this document. Thank you.
Хорошо? Не укладываемся в программу, может, сейчас одно выступление сделаем, потом кофе-брейк, и затем пленарное заседание продолжим. Сейчас у нас выступит директор Московского клинического научного центра имени Логинова, уважаемый профессор Хатков Игорь Евгеньевич, в принципе, организация онкопомощи в Москве. Пожалуйста.
Глубоко уважаемые коллеги, во-первых.
First of all, I would like to express my sincere gratitude to the steering committee and the chairperson for your kind invitation. It's our pleasure to be here, and we are very happy to see how the city is developing and how everything is developing, and we would like to share our, I would say, results which we have achieved in development of oncological services in Moscow. Here we have the main indicators which we are monitoring for several years, and in 2022 you can see the reduction of number of pensions, because while COVID no one was doing any registration, and we have changed drastically diagnostically our cancer register. We have developed a special service of cancer registry. We have checked a lot of data, and we are pretty sure that all the data that are included here, they are included together with clinical specialists, and it enables us to conduct our I would say research and registry, consuming less research, and I can tell you that the Ministry of Health, which shows us as early diagnostics, and we have reached 68%, and also we have a quite good drug provision, and it's not just I would say reduction. It's very difficult to reduce the number of patients at the fourth stage, because but anyway, we will try to reduce. We are we have managed to have it at the at a significant level, but anyway, we are trying to improve the oncological services in Moscow city, and we are trying to render specialized medical center, and we had also dispensaries, and they have both all the resources of Moscow's healthcare system, and I can tell you that we had dispensaries which have been also included in hospitals, so we can tell you that it helps us to improve the communication between these services. And one thing which I can tell you that we have some illustration of stationaries, and we have 5 clinics from Moscow, and still we are moving on the way of creation of multi-sectoral centers, and we at least do think that we have around 40% of patient in cancer registry over 70 years, which definitely implies a comorbidities, high degree of comorbidities, and together with medical doctors from other fields, we are trying to improve the diagnostics, and we have all the stationaries, I mean medical and outpatient treatment facilities, and in case if you have some suspicions to medical degree, definitely all of these I would say tests are sent to our reference centers, so we are checking at least 1.5 thousand of centers, and I can tell you that at least you can, at least in online format, you can easily see all of the tests taken in these medical stationaries, and because you, at least we do think that we have a single cancer registry, and I'm pretty sure that each of the medical doctors will have the opportunity to check everything, to see it. So and I can tell you that it helps us to resolve all the issues, and we are having the I would say, artificial intelligence models, which helps us also to analyze properly. And I can tell you that we can develop and take decisions in very, I would say, smooth and still in very prompt manner. So all of the actions of medical doctors have been highlighted here. Why? Because we are also trying to improve the quality of service at dispensary services, and it helps us to route the patient properly. And in case if you have, I would say, some failures, you can definitely help by addressing these bottlenecks by adding personnel and etc. And we also have various monitoring activities. You can see dispensaries, reception. You can have a dashboard also. We are showing you several dashboards, several of them on your screen, and you can see some oncological assistance indicators which are changed in online, and definitely availability of drug is the most, I would say, problematic issue. So we had 10 nosologies at the moment, which are included in the program of mandatory medical insurance, and all of us can execute control over the registry, and we can execute control over the nosology and plan our procurement. And also if we will have oncological concealment, it will also help us, and we will have some I would say standards, the standards which are approved by the City Council of Medical Doctors of Oncologists, and you can see the composition of the specialists from the medical centers all across the Moscow, and you can see the number of you can see the number of patients who underwent treatment which was not prescribed by standard protocols, and so some sort of pilot methods, and all of these methods will be gradually introduced to real clinical practice. And based on our research, you can see certain drugs have been approved, and they will be included in the government funding programs. You can see that they are for cervical cancer, for breast cancer, and for kidney cancer. And early diagnosis is the basis for us to reduce mortality from oncological disease, and you can see the indicators which we have managed to achieve in Moscow. We have various programs and screenings, which I would like to mention that at the moment we have 5 endoscopic centers established, and they are quite powerful institutions which have been refurbished and equipped with the state-of-the-art equipment. They work from 7 a.m. to 11 p.m. in 7 days a week, and the patients have, I would say, indications and preconditions to go, and so we do not want these centers to be overloaded. Therefore, only the patients who actually need I would say these tests are channeled there, and you can see the number of patients who had pre-cancer or conditionally pre-cancer patients, for example, even in intestine. So we have managed to prevent, for example, for 15 years certain oncological disease, and you can see how indicators of early diagnostic is growing. For example, for cancer, we have for stomach 56%, but when I have started my activities 10 years ago, it was just around 10%. But anyway, we have potential to go for, and we have also various programs of artificial intelligence to be employed, and we have a single center where we collect all the pictures from CT, and definitely here artificial intelligence is quite a good it renders quite a good platform for us to prevent pathologies and helps us with early diagnostics. And one thing which we are proactively working at is improving the oncology services, because a patient should feel himself comfortable when he or she is diagnosed with cancer. Therefore, we have for example, all of these disease, and we are we are ready to see all of this information, to look through all of this information in all the device, and sometimes even you have and we will have we have rendered we can also see that we will have some ranking of medical organizations, so we are having some sort of competitions between medical institutions, and it will help us to come to a good result. And it's very important for us to have the schools of professional growth also, and also we can tell you that I can tell you that all of our outpatient services are working, and you can go there and you can learn all the days long. And we have also so-called entry control, which means and we are having Moscow's doctor such a situation, and it's such a program. And as of the 1st of October, all of the heads of oncology departments, they should pass exam, and it's, I trust me, it's very quite complicated exam. They will have to undergo for they undergo interview, they pass exam. Otherwise, if they will fail to pass exams, they will be acting the head of the department. They will be downgraded. So one thing which I would like to also mention is the basis for development. They are scientific research, and of course we are focused on development of science, and we have Moscow Centers of Innovation Technologies, and we are having a special competition procedures which are also they are funding all the possible research. And also I can tell you about our center, which was created on the basis of the Loginov's center, and we have genome sequencing, and I can tell you, even in the Journal of Precision Oncology, one article has been published based on our work, and we have a lot of, I would say, our research published, the research outcomes published there, and I'm pretty sure that all of the works which we have been developed based on this research is very demanded. And I will not consume much of your time. I will show you our scientific opportunities, and you can see that here even in medical institutions, most of these, I would say, patients were rejected, but we have these recurrent cases of degree, and of course it's very interesting case, and we have been conducting it together with our patients and together with our colleagues, and these patients were rejected by other medical institutions, and we can tell you just about brief cases, but we have a lot of more things which we would like to share with you, and we are pretty sure that this close cooperation between government of Moscow, I mean mayor's office of Moscow city, who is, you know, the person who dives into medicine, and deputy mayor, they are closely monitoring the activity of the department, and it's very important to hear the position, to listen on the position of the specialists, and they are creating conditions for our development. Thank you so much, and I would like to mention that we are very open for cooperation, and we are closely cooperating with everyone, and we are ready to share our experience. Thank you so much, sir, and thank you so much, sir. And before coffee break, we will have one last report before coffee break.
Okay. Yes, forward. Yes. Okay. So, здравствуйте, дорогие коллеги.
Dear colleagues, dear friends, good night. Дорогие коллеги,
from the German Uzbek Medicine Society, and we will talk about the past and the future, about our cooperations with the health system here in Uzbekistan. So why we are here? The initiative comes from your president, Mirziyoyev, and the Embassy of Uzbekistan Republic in Berlin. They asked us to organize a system of cooperation between our countries and our medical health services. And your Ministry of Health, Herr Kudayarov, says that health system in Republic of Uzbekistan and Federal Republic of Germany by regular meetings of the Uzbek German Medical Society. And we have two names, the famous Robert Koch, you know, he was a founder and big researcher against the tuberculosis, and about Avicenna told my colleague Helmut Hahn something. So everything starts with a wonderful first forum in 2023 in Samarkand. It was a large step in our relations. Over 600 participants were in Samarkand in this wonderful Congress hall, and we have our first contacts also to the oncological center here in Tashkent. And the second forum was in Berlin in 2024, and some of you were here, were also in Berlin, I remember, and this was the intensify of our cooperation. And if you remember, the oncology was a main focus in this forum. So, and these are some pictures for remember in the embassy and also in the forum with the minister, with the ambassador, and so on. It was very overcrowded, also with many officials from Germany. And in November we were here for a special masterclass course with Professor Keck from University of Lübeck in pancreas surgery. So the areas of our cooperations are here highlighted. We're working in a comparison of our healthcare models in technology and innovation, evidence-based patients' care in oncology, skill training, continuing medical education, CME, as we do in whole Europe and everywhere. And also, and this is a special point, in cooperation between university hospitals from Germany. In Lübeck, we have signed a contract in this summer, and Heidelberg will be the next, between the German hospitals, university, and Tashmet University here in Tashkent. We have a program of exchange medical students and young specialists. The first group visit in this summer our university hospital in Lübeck. We have joint research projects sponsored by the GIZ, and we are working in telemedicine and digitalization. So one back. So, and the next project will be, oh, sorry. This is the last. Okay, yes. This one. Yes, thank you. And the future outlook is that we will introduce a big skill course. It was held in Germany. It is one of the biggest in Europe, and we will transform it to Tashkent this year, next year, with the whole staff from Germany, with you together, and so we can adapt this model. Every experience is there. We have all the faculties and industries with us, so I think maybe it's a point for the future. Not only for Uzbekistan, maybe for Central Asia, because you see that is very, very interesting for young doctors. Yeah. So let me say at least that is a big step and milestone that you can open now the oncological center here in Tashkent, and congratulations to you, Dr. Mirza Tilyashaikov and his team, and we will cooperate with you in the next years. Thank you very much.
Thank you very much, Mr. Excel. Уважаемые друзья, у нас еще три...
Dear colleagues, so let us go for coffee break, and in 10 minutes we will get back.
Imagine a world where information is at your fingertips. Literally. Where the room was set up perfectly. Every time. Because perfection, well, it's on display. Where every second counts. And connecting is anywhere, anytime. Where drag and drop, well, it goes through walls. Where patients get the big screen treatment. And anesthesia, they get the same. It's a world where setup is the touch of a button. And visualization is like nothing you've ever seen. Any way you want it. Where control is in your hands. For everyone and everything. And when there is something unexpected, well, the room is ready for that. Automatically. If you need a second opinion, it's on demand. Virtually. And for the family, well, they're in the loop too. And the story of the day is in your hands. And more importantly, in the record, automatically. This is the world we live in. One day, one enterprise, one solution.
From the beginning, science has been at the front and center of everything we do, taking us to places we never thought possible. This is the adventure of what science can do. Science can change the way we see the world, change how we live our lives, make us pioneers. Science can impel us to take risks, share and collaborate. Harness data, technology and AI to accelerate change. Bring people together to achieve the impossible. Fast forward the future. Science can create novel therapies and vaccines. Help people with chronic diseases live better, healthier lives. Redefine cancer care. Pioneer treatments for rare diseases. Prevent, modify, and one day, even cure. Make patients partners in their own treatment. Science can inspire us to do incredible things. Give more and more of us access to healthcare. Transform the lives of billions of people. And unite us all around the single aim of improving lives and life chances. Science can do all of this ethically and sustainably. Leading the way to a low-carbon world. Making healthcare systems more sustainable and resilient. Being bold and ambitious to make people, societies and the planet healthier. This is the limitless adventure of what science can do. This is AstraZeneca.
information is at your fingertips. Literally. Where the room was set up perfectly. Every time. Because perfection. Well, it's on display. Where every second counts. Connecting is anywhere, anytime. Where drag and drop? Well, it goes through walls. Where patients get the big screen treatment. And anesthesia, they get the same. It's a world where setup is the touch of a button. And visualization is like nothing you've ever seen. Any way you want it. Where control is in your hands. For everyone and everything. And then there's something unexpected. Well, the room is ready for that. Automatically. If you need a second opinion, it's on demand. Virtually. And for the family, well, they're in the loop too. And the story of the day is in your hands. And more importantly, in the record, automatically.
Уважаемые коллеги, с вашим позволением. Профессор Осман Костек, персонализированная медицина с разбором клинических случаев. Прошу вас.
Okay, and thank you very much. It's a big honor for me to be here, and I would like to thank the organizing committee and particularly Dr. Hurshid for this kindly invitation. My topic is precision medicine and the evolution of the treatment paradigm in oncology. I would like to briefly introduce myself. I am the clinical oncologist and the faculty of the Marmara University School of Medicine, and with the population transition and aging, the cancer has been moving from second to the being first leading cause of the death worldwide. And this diagram highlights the need for this highly cancer burden, that the early detection program and effective treatment strategies are needed. And as Agatha Christie once said that the time is the best killer. Yeah, the time sometimes wears down cells and paves way for cancer. And it becomes the source of a prestigious transformation as in the peril. And our challenge is that to understand the both role of the, understand the dual role of the time, as risk or as an opportunity to scientific discovery and innovation. And the cancer fundamentally arises from the DNA mutation in cells. They come from DNA mutations due to the hereditary changes, radiation and chemical agents, or spontaneous errors during the DNA replication, and leads to the uncontrolled hyperproliferation. And this proliferation, at the right side, you see the holistic view of the hallmarks of the cancer. And the cancer gains some distinct features, that uncontrolled proliferation leads to the immortality and leads to the immune escape.
И, конечно же, когда мы говорим о
that the multi-omic studies, together with the clinical data across the multiple type of the cancers, revealed that this disease is not the same disease. It's a multi-heterogeneous disease that leads to primary tumors may differ from the metastasis, and metastasis can make a new metastasis as well. And this is a very complex molecular and immune landscape, differs from patient to patient. And this is the reason why the same treatment for same disease does not conclude the same outcome. Someone conclude better prognosis, someone have worse prognosis as well. And by the help of the precision medicine, we can classify the disease as a subgroups in same organ, in same disease as well. And the cancer's complex molecular and immune landscape differ patient to patient as well. And the critical issue is to define a cohesion of somatic mutations that transform healthy cells into the cancer cells. And which way is preferred for us to define this somatic mutation. It differs from the type of the cancer and the tissues. And mostly we use the 5 fundamental tests for this evaluation, and immunohistochemistry and FISH, polymerase chain reaction, next generation sequencing, or whole genome expressing profiling as well. Someone is cheap and rapid, someone is the high true output. And we get the true outs and classify these biomarkers in 2 major groups. One group is prognostic biomarkers that you informed about the disease, or you get the predictive biomarker that you predict your treatment will respond or not during the treatment. And as the precision medicine help, some mutations classified into new title, actionable gene alterations, and briefly called druggable mutations. Yeah, if you have a druggable mutation and you give this drug to this mutation, you can easily control the disease. And in the past, these druggable mutations was undruggable mutations, then they transformed into the druggable mutation by the help of the scientific discoveries. Now, the main aim is for precision medicine is to give the better or proper treatment to the right patients. And if we get some data about the mutations, how we will evaluate this data, you can use some links, websites, and I usually prefer to use OncoKB. If you write the mutations to this link, you can learn what these mutations means. It is a driver mutation or a passenger mutation, and is this mutation is druggable or not. And whatever the mutation it is, your management must be based on the scientific evidence that's supported by the guidelines and the discoveries as well. And I will continue with some small cases of my patients. One is a female patient, 53 years old, was admitted to medical oncology with the chief complaints, nausea and headache. And after the workup studies, we diagnosed the patients that the de novo metastatic lung cancer adenocarcinoma with she harbored the ALK rearrangement. And before this data, precision medicine area, we know that the de novo metastatic lung cancers unfortunately has a median overall survival is about 8 months, together with limited efficacy with chemotherapy combination and higher toxicity profiles. But by the help of the discovery of the ALK fusion, we know that the ALK is a driver mutation. This fusion causes some drivers for genome to make the more proliferation and progress the disease. Then ALK inhibitor blocks this pathway and causes the efficiently disease control. Yeah, we started the ALK inhibitor, then after the 2 months we get the response, and our response was complete response. And this deeper response also more durable than the conventional treatments. And another topic for precision medicine is the drug resistance. If drug resistance is inevitable issue for the treatment of the cancer, and precision medicine also results in more durable and more deeper responses, but after that, unfortunately, the disease inevitably progresses. And the best way to overcome the drug resistance, also precision medicine is the best way. This is another example of my patients. This is a 60 years old male patient diagnosed with the EGFR mutation of lung cancer with exon 19 deletion. We give the standard of care as osimertinib. Then after the 1 year, the patient had progression. And this must be questionable because we know that the pivotal trial, the FLORA trial, concluded that it was about 17.2 months for median duration of response. This is a shorter response. You must explain this. And we know that for EGFR resistance, there are multiple pathways that you can explain the resistance. And we get the new biopsies from the lung. We saw that the ROS1 rearrangement, ROS1 fusion. And we added our therapy to the osimertinib, and we get the complete response after a short time. And which way better, driver mutations or passenger mutations? How we can manage this patient? Both mutations are important. And the other patients from Turkmenistan comes to our clinic, and we offer a chemotherapy, but patient refused that, and we ordered genomic analysis for the tumors, and we get the driver mutation for red rearrangement, and together with some passenger mutations and a high PD-L1 expression. And we give the driver mutations together with immunotherapy, we get the nearly complete response to the patient, and the patient is good as well. And precision medicine issues, another topic is that to avoid the serious toxicity, as you know, DPD activity may vary between the peoples, and in our country, the DPD deficiency in our country is about 1%. And in literature, global population, it arounds to 5%. If you do not know this DPD population, when you give the 5 uracils to patients, your treatment may kill the patient, or your patient may experience serious toxicity. Also, precision medicine may avoid the serious toxicity for your patient. And also, this way may avoid the unnecessary chemotherapy for patients. And it is the very famous test, Oncotype DX, for female patients who are diagnosed with breast cancer, in early breast cancer. When you order the Oncotype DX, and in conventional way, maybe you can offer the chemotherapy, but by the help of this genomic test, if genomic score is low, you can not give chemotherapy. There is no benefit for patient, and you can avoid the unnecessary treatment now. And this is the time for us there is an evolving of oncology concept from the traditional medicine. Now we are in the guideline-based treatments, and we are evolving for further precision medicine, more personalized medicine as well. And the governments, I think they should adopt the systemic approach to the personalized cancer medicine as well. And in conclusion, the cancer complex molecular and immune landscape and can vary from patient to patient, and transformative therapies are needed now. And critically applying precision is concept that right combination of drugs must be chosen for each patient and used at the right stage of the disease. Rahmet. Teşekkür ederim.
Thank you very much. Thank you very much, Professor Kuster. Now is to introduce Organization of Oncology Services in the Republic of Kazakhstan, Dr. Aldibek Mukashanov is Deputy Chair of the Board, National Scientific Oncology Center in the Republic of Kazakhstan. The floor is yours. Thank you. Where is this guy? It is already? Yeah.
Yes, yes. Assalamualaikum, құрметті Өзбек бауыр.
Dear colleagues from Uzbekistan, it's my pleasure to be here, standing in front of you, my brothers, my brotherly Uzbek nation, and I am very happy to have such a guest from oncologists and radiologists from Uzbekistan, and it's my pleasure to welcome you here in Uzbekistan, in such a city of sunshine, and I'm representing you, Kazakhstan, also a very sunny country, and definitely I would like to greet you on the event, on such a reputed and large-scale event, and I would like to express the greeting of my senior, because in Kazakhstan we are now having Kazakhstan's participation at the International Agency for Atomic Energies in Vienna, in Austria, so he is in Austria, but anyway, it's our pleasure to share our experience. And Kazakhstan, as well as you know, the total number of population is 20 million of people, and of course we are facing the problems with oncological disease in recent 20 years. The number of patient is growing around 30%. There was a total increase of the number, and in recent years we are having 205 cases per 100,000 of people, and you can see that in most of cases it's on the north and south of Kazakhstan, where we have respective climate conditions, and also we have the disbursement of disease. At the first place we have breast cancer, and the second place is colorectal cancers, and you can see that oncological assistance is rendered in Kazakhstan by 1,000 specialists. We have radiologists, pathomorphologists, physicians. We have we had in the Soviet period, we had a 3-layer system, a 3-tier system. It's like assistance we have at hospitals, at clinics. We have around 530 oncological reception rooms at clinics, and so I can tell you that we have 20 specialized dedicated institutions. So in Kazakhstan we have 20 provinces, and in each of these 20 provinces we have specialists who are rendering dedicated assistance. And at the third level, as we have mentioned, we have scientific centers, our National Scientific Research Center in Astana, and our center also research center in Astana, in Almaty, and we are rendering our assistance, oncological assistance to population, and government is paying special attention to this, and we are having our action plan for 2023-2027, and 460 million of tenge has been allocated. It's around 900 million of USD for 40 years for modernization of health care and procurement of medical drugs. You can see the budget which was allocated, and as you have seen here on your left, in 2010 we had just 9.1 million of tenge allocated. And if you will see the middle part of the chart, in 2023 we had 61.6 billion of tenge, and 41% of these funds are allocated to procure equipment. And of course, the patients with oncological disease in Kazakhstan can use all the advanced drugs which we have in the state-of-the-art treatment protocols, international treatment protocols. So I can tell you that it's around $150 million in 2024, and we are paying significant attention to screening. We have a lot of funds dedicated for screening, and we had around 20 million of tenge allocated. We have three types of screening of colorectal, screening of cervical cancer, screening of breast cancer. So we in 2024 we had observed around 5 million people, and 20 million of tenge was allocated for screening. And thanks to the screening, we have managed to identify we have managed to have early identification of screening, and pre-screening enabled us to identify 71.3 cases at the early stage of cervical cancer. So we have also joined the vaccination program. So girls after 11 years are vaccinated with human papilloma virus vaccine. So we are also having vaccinations counter papilloma for girls from 11 years and do hope 11 plus years. So we hope that in coming 10-15 years Kazakhstan will be able to reduce the prevalence of cervical cancer. And also what I would like to show you here is regarding our National Oncology Center, which was created which was constructed based on the resolution of the president of the country, and we have started construction of new premises of oncological center to equip it with the state-of-the-art equipment, and without stopping the research and reconstruct the premises of the old premises. We had the presidential decree and the resolution of the government, and new premises have been constructed for 210 beds and 150 outpatient care beds, and we can have 6,000 hospital treatment per year for 600,000 patients. So the construction was B&A contractors. This is the Mabitex company's affiliate, which has equipment in construction of Kazakhstan. They have constructed National Center for Mother and Child Care, National Diagnostic Center, National Cardiosurgery Center. So they have constructed over 40 facilities all across the world for the healthcare sector. And since we had a very significant funding we can tell you that we had 100 we have invested around 280 million USD for this, and also we have decided that from before we have construction with Deloitte, and they had the project, they have rendered the assistance to the project, and they have exercised control over the construction and equipment with medical devices. And this new corpse is not just a treatment corpse, we are also having so-called cyclotron equipment, and we will be producing 11 radiological drugs, and indeed we will be producing these drugs, and we will provide both diagnostics and treatment with radiological drugs, and we are having the PET, which is a gold standard for cervical cancer and for pelvic cancer. So I can tell you that we are having so-called MRI simulation, and when you have MRI simulation as a gold standard in case of brain cancer, and we are treating, I mean, in all the possible ways, because we have 4-line accelerators, and we can have a treatment with.
Также аппарат
we are also having brachytherapy equipment, which can also help us in treating patients. We are also having a strong demand for radionuclide therapy, and in Semey City we had a special room for radiotherapy, and also we are having no need for our patient to go for radiotherapy to foreign countries, and we are very proud. And Mr. Andrei has also mentioned about this, that in Kazakhstan for the first time, and in the Central Asia, we are going to have so-called the proton therapy center. We have only one in Russia, in 3 cities in Russia, in Obninsk city, and in St. Petersburg, and number 4 will be our center in Astana, in our center. You are well aware that the proton therapy is a gold standard, especially in case when your malignancy is located close to the eye or to the critical importance organs, and if previously they have been visiting, our patients have been visiting foreign countries for treatment, but now we can close our demand for proton therapy in our country, and we are ready to domestically, and we are ready to render our assistance to our neighboring countries. We have 2 innovative linear accelerators, Varian Ethos and Varian Edge, and both of them having artificial intelligence. So before each session they are conducting a CT scan, and of course they are conducting a high precision radiotherapy, which is very important high-tech service. And we can also render assistance with so-called gamma cyber knife, and you can have a treatment of disease not only of brain but also of liver, of kidney, and without any surgical intervention you can treat the cancers, you can manage these cancers. So we have immune cell therapy, which we are planning to do, and of course we have National Center for Biotechnology, and what I can tell you is that we have all the types of treatments in our hospital. We have many invasive surgeries, palliative assistance, plastic surgeries. We are also focused on nuclear medicine, and we have opportunities to treat around 10,000 patients and have around 6,000 of mini invasive surgeries. We have 10 surgery rooms fully equipped with and video equipment, and 2 of them having so-called hybrid surgery rooms with angiography equipment, and you can treat the patient properly. And it's not only oncological assistance, but we are also conducting transplantation of the organs and tissues. You know that according to the WHO standard, in case if certain medical institution conducts transplantation of bodies, of body organs or of tissues, it's one of the very important indicators of the high level of development of medical service in particular countries. So within these 15 years since we have embarked on our journey, we had around 900 transplantation of bone marrow, and we are conducting transplantation of bone marrow, all types, aula, gaplo, transplantations of the bone marrow. We are also transplanting both liver and kidney, and we had around 119 transplantations of liver and 726 transplantation of kidney. And of course, a very important project which we have undertaken. It was not undertaken all by ourselves. So we had the World Bank, we had WHO, we had the International Cancer Society, European Medical Oncology Society, and of course our neighboring countries like Russian Federation, Belarus, Uzbekistan, and neighboring countries, and together with Korea, USA, Japan, and etc. And of course we are also having MOUs with Gerson Institute, with Koch Institute, and with Israel, and we are exchanging experience, we are teaching, and we are sharing our knowledge, and we are ready to proceed. And though we had, for example, COVID pandemics outbroken in our country, but anyway we have been sharing our experience online and offline, so you can see the slides. I will not waste your time, but we have been working both Germany, with Korea, with Turkey, with all the neighboring countries, and of course what I can tell you is that we are closely cooperating, we are working in this extent, and since our center is not just a medical center but also it's a production center, so we are also dealing with medical programs. We have so-called residential programs, we are we are training personnel on 11 years for nuclear medicine, for pathological anatomy, for other domains. So we are ready to share our experience to treat, and we can render you our services. And of course, scientific research. If you have probably seen the scientific research which were funded by the Ministry of Education, and you can see that we are working for 2026. We are having innovative technologies of treatment together with Al-Farabi Institute and National Center of Biotechnologies, and for 2026-2028 we will have our project on integration of molecular genetic, radionomic and radionucleotide technologies for personalized medicines. We have joint projects with Nazarbayev University, so we will be focused on diagnostics and the new methods of treatment of patients with oncological disease. And as I have already mentioned, since we are at the 3rd yearly level, we are focused on coordination of oncology disease, coordination of diagnostics, and having reference centers. We have reference pathomorphology centers which we are conducting for oncological disease, and we are having a personal treatment, and we are transferring technologies and from Kazakhstan and etc. And of course we are treating also patients. We are rendering palliative treatment to the patients. Thank you so much, colleagues. In case of any questions, please feel free.
Now I have the pleasure to introduce
Сейчас мы хотим дать слово
Julia Lamicina, Charitable Foundation, Ishnoch. Maybe it's not the right pronunciation.
I do it myself? No, how do I change it? This one. Okay. Andrea. Уважаемые коллеги, гости столицы Конгресса.
Dear colleagues, dear guests, my name is Julia, and I have very important missions on creation of ENG Foundation on the basis of the center, which was created on the basis of the decree of the Cabinet of Ministers 892, which is focused on assistance to patients who need this assistance. And I do think that it's very unique case for all of us, and everyone has been awaiting for this. I guess this psychological assistance to the patients is also important. It's not just for the patients who are at the final stage, but also according to international standards from the moment of diagnostics. And we will be rendering not only the medical assistance, but we are going to I will not waste my time on reading what is written on the screen, but anyway, you can easily see what can be funded from the funds of our foundation, and you can see that it's International Day to Combat Cancer. It's a charity day. We will not exclude the International Children's Day or 15th February, the combat to children's oncology, but Pink October and etc. So I will not waste so much of your time. We are very happy that today's foundation has been created, and you can see on your right our roll-up, and we are having our conference at the first floor, and it will be our pleasure if you will also join us and render your assistance in our combat against oncological disease. Thank you so much, the participants. I guess that this is the end of our plenary session. We have heard the reports of strategic importance which were presented by our colleagues from all over the world, from all corners of the world, and I'm very happy that we had our presenters who shared their visions to combat cancer, and I can say that the world oncology is moving forward with meaningful results and efficient actions, and now I guess it's a very quite nice period of time. We need to make everything right in time, and we will try to make it. And please kindly let us get back, because we will have a lot of sections which we have to proceed. Thank you so much. And Ms. Nazakat will inform us about our luncheon, and then we will go for lunch. Okay. Dear colleagues, we have a vehicle. We will go to Nasri Baba restaurant, and we are invited for pilaf.
Всех приглашаем в ресторан Басри Баба, где мы организовали плов торжественный для наших гостей. Добро пожаловать. Вас ждут автобусы. Он так называется?
Imagine a world where information is at your fingertips. Literally. Where the room was set up perfectly. Every time. Because perfection. Well, it's on display. Where every second counts. And connecting is anywhere, anytime. Where drag and drop? Well, it goes through walls. Where patients get the big screen treatment. And anesthesia, they get the same. It's a world where setup is the touch of a button. And visualization is like nothing you've ever seen. Any way you want it. Where control is in your hands. For everyone and everything. And when there is something unexpected, well, the room is ready for that. Automatically. If you need a second opinion, it's on demand. Virtually. And for the family, well, they're in the loop too. And the story of the day is in your hands. And more importantly, in the record, automatically. This is the world we live in. One day, one enterprise, one solution.
From the beginning, science has been at the front and center of everything we do, taking us to places we never thought possible. This is the adventure of what science can do. Science can change the way we see the world, change how we live our lives, make us pioneers. Science can impel us to take risks, share and collaborate. Harness data, technology, and AI to accelerate change. Bring people together to achieve the impossible. Fast forward the future. Science can create novel therapies and vaccines. Help people with chronic diseases live better, healthier lives. Redefine cancer care. Pioneer treatments for rare diseases. Prevent, modify, and one day, even cure. Make patients partners in their own treatment. Science can inspire us to keep doing incredible things. Give more and more of us access to healthcare. Transform the lives of billions of people. And unite us all around the single aim of improving lives and life chances. Science can do all of this ethically and sustainably. Leading the way to a low-carbon world. Making healthcare systems more sustainable and resilient. Being bold and ambitious. To make people, societies, and the planet healthier. This is the limitless adventure of what science can do. This is AstraZeneca.
Imagine a world where information is at your fingertips. Literally. Where the room was set up perfectly. Every time. Because perfection. Well, it's on display. Where every second counts. And connecting is anywhere, anytime. Where drag and drop? Well, it goes through walls. Where patients get the big screen treatment. And anesthesia, they get the same. It's a world where setup is the touch of a button. And visualization is like nothing you've ever seen. Any way you want it. Where control is in your hands. For everyone and everything. And when there is something unexpected, well, the room is ready for that. Automatically. If you need a second opinion, it's on demand. Virtually. And for the family, well, they're in the loop too. And the story of the day is in your hands. And more importantly, in the record, automatically. This is the world we live in. One day, one enterprise, one solution.
From the beginning, science has been at the front and center of everything we do. How we live our lives make us pioneers. Science can impel us to take risks, share and collaborate. Harness data, technology and AI to accelerate change. Bring people together to achieve the impossible. Fast forward the future. Science can create novel therapies and vaccines. Help people with chronic diseases live better, healthier lives. Redefine cancer care. Pioneer treatments for rare diseases. Prevent, modify, and one day, even cure. Make patients partners in their own treatment. Science can inspire us to keep doing incredible things. Give more and more of us access to healthcare. Transform the lives of billions of people. And unite us all around the single aim of improving lives and life chances. Science can do all of this ethically and sustainably. Leading the way to a low-carbon world. Making healthcare systems more sustainable and resilient. Being bold and ambitious. To make people, societies and the planet healthier. This is the limitless adventure of what science can do. This is AstraZeneca.
Imagine a world where information is at your fingertips. Literally. Where the room was set up perfectly. Every time. Because perfection, well, it's on display. Where every second counts. Connecting is anywhere, anytime. Where drag and drop, well, it goes through walls. Where patients get the big screen treatment. And anesthesia, they get the same. It's a world where setup is the touch of a button. And visualization is like nothing you've ever seen. Any way you want it. Where control is in your hands. For everyone and everything. And when there is something unexpected, well, the room is ready for that. Automatically. If you need a second opinion, it's on demand. Virtually. And for the family, well, they're in the loop too. And the story of the day is in your hands. And more importantly, in the record, automatically. This is the world we live in. One day, one enterprise, one solution.
From the beginning, science has been at the front and center of everything we do, taking us to places we never thought possible. This is the adventure of what science can do. Science can change the way we see the world, change how we live our lives, make us pioneers. Science can compel us to take risks, share and collaborate. Harness data, technology and AI to accelerate change. Bring people together to achieve the impossible. Fast forward the future. Science can create novel therapies and vaccines. Help people with chronic diseases live better, healthier lives. Redefine cancer care. Pioneer treatments for rare diseases. Prevent, modify, and one day, even cure. Make patients partners in their own treatment. Science can inspire us to keep doing incredible things. Give more and more of us access to healthcare. Transform the lives of billions of people. And unite us all around the single aim of improving lives and life chances. Science can do all of this ethically and sustainably. Leading the way to a low-carbon world. Making healthcare systems more sustainable and resilient. Being bold and ambitious to make people, societies and the planet healthier. This is the limitless adventure of what science can do. This is AstraZeneca.
information is at your fingertips. Literally. Where the room was set up perfectly. Every time. Because perfection. Well, it's on display. Where every second counts. And connecting is anywhere, anytime. Where drag and drop, well, it goes through walls. Where patients get the big screen treatment. And anesthesia, they get the same. It's a world where setup is the touch of a button. And visualization is like nothing you've ever seen. Any way you want it. Where control is in your hands. For everyone and everything. And when there is something unexpected, well, the room is ready for that. Automatically. If you need a second opinion, it's on demand. Virtually. And for the family, well, they're in the loop too. And the story of the day is in your hands. And more importantly, in the record, automatically. This is the world we live in. One day, one enterprise, one solution.
From the beginning, science has been at the front and center of everything we do. Taking us to places we never thought possible. This is the adventure of what science can do. Science can change the way we see the world, change how we live our lives, make us pioneers. Science can impel us to take risks, share and collaborate. Harness data, technology and AI to accelerate change. Bring people together to achieve the impossible. Fast forward the future. Science can create novel therapies and vaccines. Help people with chronic diseases live better, healthier lives. Redefine cancer care. Pioneer treatments for rare diseases. Prevent, modify, and one day, even cure. Make patients partners in their own treatment. Science can inspire us to keep doing incredible things. Give more and more of us access to healthcare. Transform the lives of billions of people. And unite us all around the single aim of improving lives and life chances. Science can do all of this ethically and sustainably. Leading the way to a low-carbon world. Making healthcare systems more sustainable and resilient. Being bold and ambitious. To make people, societies, and the planet healthier. This is the limitless adventure of what science can do. This is AstraZeneca.
Imagine a world where information is at your fingertips. Literally. Where the room was set up perfectly. Every time. Because perfection. Well, it's on display. Where every second counts. Connecting is anywhere, anytime. Where drag and drop, well, it goes through walls. Where patients get the big screen treatment. And anesthesia, they get the same. It's a world where setup is the touch of a button. And visualization is like nothing you've ever seen. Any way you want it. Where control is in your hands. For everyone and everything. And when there is something unexpected, well, the room is ready for that. Automatically. If you need a second opinion, it's on demand. Virtually. And for the family, well, they're in the loop too. And the story of the day is in your hands. And more importantly, in the record, automatically. This is the world we live in. One day, one enterprise, one solution.
From the beginning, science has been at the front and center of everything we do. Taking us to places we never thought possible. This is the adventure of what science can do. Science can change the way we see the world, change how we live our lives, make us pioneers. Science can compel us to take risks, share and collaborate. Harness data, technology and AI to accelerate change. Bring people together to achieve the impossible. Fast forward the future. Science can create novel therapies and vaccines. Help people with chronic diseases live better, healthier lives. Redefine cancer care. Pioneer treatments for rare diseases. Prevent, modify, and one day, even cure. Make patients partners in their own treatment. Science can inspire us to keep doing incredible things. Give more and more of us access to healthcare. Transform the lives of billions of people. And unite us all around the single aim of improving lives and life chances. Science can do all of this ethically and sustainably. Leading the way to a low-carbon world. Making healthcare systems more sustainable and resilient. Being bold and ambitious to make people, societies, and the planet healthier. This is the limitless adventure of what science can do. This is AstraZeneca.
Imagine a world where information is at your fingertips, literally. Where the room was set up perfectly, every time. Because perfection, well, it's on display. Where every second counts. And connecting is anywhere, anytime. Where drag and drop, well, it goes through walls. Where patients get the big screen treatment. And anesthesia, they get the same. It's a world where setup is the touch of a button. And visualization is like nothing you've ever seen. Any way you want it. Control is in your hands. For everyone and everything. And when there is something unexpected, well, the room is ready for that. Automatically. And if you need a second opinion, it's on demand. Virtually. And for the family, well, they're in the loop too. And the story of the day is in your hands. And more importantly, in the record, automatically. This is the world we live in. One day, one enterprise, one solution.
From the beginning, science has been at the front and center of everything we do, taking us to places we never thought possible. This is the adventure of what science can do. Science can change the way we see the world, change how we live our lives, make us pioneers. Science can impel us to take risks, share and collaborate. Harness data, technology and AI to accelerate change. Bring people together to achieve the impossible. Fast forward the future. Science can create novel therapies and vaccines, help people with chronic diseases live better, healthier lives. Redefine cancer care. Pioneer treatments for rare diseases. Prevent, modify, and one day, even cure. Make patients partners in their own treatment. Science can inspire us to keep doing incredible things. Give more and more of us access to healthcare. Transform the lives of billions of people and unite us all around the single aim of improving lives and life chances. Science can do all of this ethically and sustainably, leading the way to a low-carbon world, making healthcare systems more sustainable and resilient, being bold and ambitious to make people, societies, and the planet healthier. This is the limitless adventure of what science can do. This is AstraZeneca.
Choyni quyib berma.
Imagine a world where information is at your fingertips, literally. Where the room was set up perfectly, every time. Because perfection, well, it's on display. Where every second counts. And connecting is anywhere, anytime. Where drag and drop, well, it goes through walls. Where patients get the big screen treatment. And anesthesia, they get the same. It's a world where setup is the touch of a button. And visualization is like nothing you've ever seen. Any way you want it. Where control is in your hands. For everyone and everything. And when there is something unexpected, well, the room is ready for that. Automatically. And if you need a second opinion, it's on demand. Virtually. And for the family, well, they're in the loop too. And the story of the day is in your hands. And more importantly, in the record, automatically. This is the world we live in. One day, one enterprise, one solution.
From the beginning, science has been at the front and center of everything we do, taking us to places we never thought possible. This is the adventure of what science can do. Science can change the way we see the world, change how we live our lives, make us pioneers. Science can impel us to take risks, share and collaborate. Harness data, technology and AI to accelerate change. Bring people together to achieve the impossible. Fast forward the future. Science can create novel therapies and vaccines, help people with chronic diseases live better, healthier lives. Redefine cancer care. Pioneer treatments for rare diseases. Prevent, modify, and one day, even cure. Make patients partners in their own treatment. Science can inspire us to keep doing incredible things. Give more and more of us access to healthcare. Transform the lives of billions of people. And unite us all around the single aim of improving lives and life chances. Science can do all of this ethically and sustainably, leading the way to a low-carbon world, making healthcare systems more sustainable and resilient, being bold and ambitious to make people, societies, and the planet healthier. This is the limitless adventure of what science can do. This is AstraZeneca.
Imagine a world where information is at your fingertips, literally. Where the room was set up perfectly, every time. Because perfection, well, it's on display. Where every second counts. And connecting is anywhere, anytime. Where drag and drop, well, it goes through walls. Where patients get the big screen treatment. And anesthesia, they get the same. It's a world where setup is the touch of a button. And visualization is like nothing you've ever seen. Any way you want it. Control is in your hands. For everyone and everything. And when there is something unexpected, well, the room is ready for that. Automatically. And if you need a second opinion, it's on demand, virtually. And for the family, well, they're in the loop too. And the story of the day is in your hands. And more importantly, in the record, automatically. This is the world we live in. One day, one enterprise, one solution.
From the beginning, science has been at the front and center of everything we do, taking us to places we never thought possible. This is the adventure of what science can do. Science can change the way we see the world, change how we live our lives, make us pioneers. Science can impel us to take risks, share and collaborate. Harness data, technology and AI to accelerate change. Bring people together to achieve the impossible. Fast forward the future. Science can create novel therapies and vaccines, help people with chronic diseases live better, healthier lives. Redefine cancer care. pioneer treatments for rare diseases. Prevent, modify, and one day, even cure. Make patients partners in their own treatment. Science can inspire us to keep doing incredible things. Give more and more of us access to healthcare. Transform the lives of billions of people. And unite us all around the single aim of improving lives and life chances. Science can do all of this ethically and sustainably. Leading the way to a low-carbon world. Making healthcare systems more sustainable and resilient. Being bold and ambitious to make people, societies, and the planet healthier. This is the limitless adventure of what science can do. This is AstraZeneca.
Imagine a world where information is at your fingertips. Literally. Where the room was set up perfectly, every time. Because perfection, well, it's on display. Where every second counts. And connecting is anywhere, anytime. Where drag and drop, well, it goes through walls. Where patients get the big screen treatment. And anesthesia, they get the same. It's a world where setup is the touch of a button. And visualization is like nothing you've ever seen. Any way you want it. Where control is in your hands. For everyone and everything. And when there is something unexpected, well, the room is ready for that. Automatically. And if you need a second opinion, it's on demand. Virtually. And for the family, well, they're in the loop too. And the story of the day is in your hands. And more importantly, in the record, automatically. This is the world we live in. One day, one enterprise, one solution.
From the beginning, science has been at the front and center of everything we do, taking us to places we never thought possible. This is the adventure of what science can do. Science can change the way we see the world, change how we live our lives, make us pioneers. Science can impel us to take risks, share and collaborate. Harness data, technology and AI to accelerate change. Bring people together to achieve the impossible. Fast forward the future. Science can create novel therapies and vaccines, help people with chronic diseases live better, healthier lives. Redefine cancer care. Pioneer treatments for rare diseases. Prevent, modify, and one day, even cure. Make patients partners in their own treatment. Science can inspire us to keep doing incredible things. Give more and more of us access to healthcare. Transform the lives of billions of people. And unite us all around the single aim of improving lives and life chances. science can do all of this ethically and sustainably. Leading the way to a low-carbon world. Making healthcare systems more sustainable and resilient. Being bold and ambitious to make people, societies, and the planet healthier. This is the limitless adventure of what science can do. This is AstraZeneca.
Imagine a world where information is at your fingertips, literally. Where the room was set up perfectly, every time. Because perfection, well, it's on display. Where every second counts. And connecting is anywhere, anytime. Where drag and drop, well, it goes through walls. Where patients get the big screen treatment. And anesthesia, they get the same. It's a world where setup is the touch of a button. And visualization is like nothing you've ever seen. Any way you want it. Where control is in your hands. For everyone and everything. And when there is something unexpected, well, the room is ready for that. Automatically. And if you need a second opinion, it's on demand. Virtually. And for the family, well, they're in the loop too. And the story of the day is in your hands. And more importantly, in the record, automatically. This is the world we live in. One day, one enterprise, one solution.
From the beginning, science has been at the front and center of everything we do, taking us to places we never thought possible. This is the adventure of what science can do. Science can change the way we see the world, change how we live our lives, make us pioneers. Science can impel us to take risks, share and collaborate. Harness data, technology and AI to accelerate change. Bring people together to achieve the impossible. Fast forward the future. Science can create novel therapies and vaccines, help people with chronic diseases live better, healthier lives. Redefine cancer care. Pioneer treatments for rare diseases. Prevent, modify, and one day, even cure. Make patients partners in their own treatment. Science can inspire us to keep doing incredible things. Give more and more of us access to healthcare. Transform the lives of billions of people. And unite us all around the single aim of improving lives and life chances. science can do all of this ethically and sustainably. Leading the way to a low-carbon world. Making healthcare systems more sustainable and resilient. Being bold and ambitious to make people, societies, and the planet healthier. This is the limitless adventure of what science can do. This is AstraZeneca.
Imagine a world where information is at your fingertips, literally. Where the room was set up perfectly, every time. Because perfection, well, it's on display. Where every second counts. And connecting is anywhere, anytime. Where drag and drop, well, it goes through walls. Patients get the big screen treatment. And anesthesia, they get the same. It's a world where setup is the touch of a button. And visualization is like nothing you've ever seen. Any way you want it. Control is in your hands. For everyone and everything. And when there is something unexpected, well, the room is ready for that. Automatically. And if you need a second opinion, it's on demand. Virtually. And for the family, well, they're in the loop too. And the story of the day is in your hands. And more importantly, in the record, automatically. This is the world we live in. One day, one enterprise, one solution.
From the beginning, science has been at the front and center of everything we do, taking us to places we never thought possible. This is the adventure of what science can do. Science can change the way we see the world, change how we live our lives, make us pioneers. Science can impel us to take risks, share and collaborate. Harness data, technology and AI to accelerate change. Bring people together to achieve the impossible. Fast forward the future. Science can create novel therapies and vaccines, help people with chronic diseases live better, healthier lives. Redefine cancer care. pioneer treatments for rare diseases. Prevent, modify, and one day, even cure. Make patients partners in their own treatment. Science can inspire us to keep doing incredible things. Give more and more of us access to healthcare. Transform the lives of billions of people. And unite us all around the single aim of improving lives and life chances. Science can do all of this ethically and sustainably. Leading the way to a low-carbon world. Making healthcare systems more sustainable and resilient. Being bold and ambitious to make people, societies, and the planet healthier. This is the limitless adventure of what science can do. This is AstraZeneca.
Imagine a world where information is at your fingertips, literally. Where the room was set up perfectly, every time. Because perfection, well, it's on display. Where every second counts. And connecting is anywhere, anytime. Where drag and drop, well, it goes through walls. Where patients get the big screen treatment. And anesthesia, they get the same. It's a world where setup is the touch of a button. And visualization is like nothing you've ever seen. Any way you want it.
Надо.
Глубоко уважаемые гости, просим вас пройти на места. Людей много видно, но не присаживайтесь.
Dear guests, please kindly take your seats.
Мы продолжаем работу.
We will proceed with our section, which is called Minimal Invasive Technologies in Oncological Surgeries, and we would like our moderators to go on stage. Mr. Vyacheslav Aliyev, Mr. Azat Chinaliyev, and I would like to draw your attention to our first report in laparoscopic surgery in treatment, in cancer treatment. I would like to ask our dear colleagues to be very short, otherwise we are not meeting the schedule. I hope that if we will concentrate our efforts, we can have, I would say, more productive time ahead. Yes, I will be delivering my speech on laparoscopic treatment and less invasive sections. So, dear colleagues, we would like to share our experience, which has been introduced in 2017 for the first time. And our colleagues helped us to, I would say, see the experience, and we are we are having the indicators here on the screen, and the kidney cancer is on the 12th place in terms of mortality, one of the major causes of mortality. We're talking about the history. You know that probably since 1869, when for the first time nephrectomy has been conducted, such as surgery, and in 100 years this surgery was introduced into the practice, and we have also shown that together, these principles significantly contributed in life expectancy growth of the patients with kidney cancer. And you can see the models of surgery, of surgeon's hand, and you can also see that this methodology is the same actually, and just the approaches are changing, and it leads to the best outcomes, like full recovery of the patients. And talking about the laparoscopic nephrectomy, in most of cases we had the problems with medical treatment, but at the moment you can see that all these laparoscopic surgeries are 100% surgeries with no contradiction, and we have radical nephrectomy, and of course it is very good for us to have a laparoscopic surgery with a nice cosmetological impact, and of course it's a very good, I would say, outcomes, and because it helps us also to avoid bleeding, and of course we are facing the most important things in medicine is Robson rules, which we have to stick close, and this helps to save people's life, patients' life. And one very important thing which I would like to mention: should we comply or shouldn't we comply with the Robson's rules? And sometimes patients are coming for us in 3 months or in 6 months after nephrectomy, when the disease, the malignancies have not been radically removed, and in such a situation definitely we need to remove all of these recurrent I would say metastasis, and then the patients have quite good chances for longevity. And of course we need to come with target therapy, we need to come with immune therapy, and of course chemical treatment specialists can show us that we are the one who are granting them long years of life. And for talking about dissection, sometimes we are facing the infiltration of malignancies, but it's not easy to, I would say, identify it in the period of the first stages, and of course they can infiltrate into vessel system, blood vessel systems. Of course, all of these I would say indications should be based on evidence-based medicine, and of course we need to have our researches in place, and we have identified several research of so-called lymphodissections, and what are the indicators for resection. They can be both absolute, and medical doctors are selecting the patients, but the patients anyway undergoes a resection. We are trying definitely to preserve the kidney, but you know that even if you have one kidney, you have to, in case of one kidney available with the patient, you need to find some, I would say, solution. You need to be very careful, and we are showing how we will major blood vessels of aorta and lower vein, and here of course we would like to see it, we would like to help to the patient definitely, but you can see is that when you have learned properly how to work properly, and if you have laparoscopy still, and if you are having this inter-aorta cavalis lymphodissection, when you are changing these lymphatic characters, then you are simply lifting up the vena cava inferior, and in case if these blood vessels have been augmented while the research, while the exam stage, you can enter and you can radically remove all these things, and in intra-aorta caval area you can see that you can have radical changes from according to the rule of Robson. You can resolve the issue with blood vessels, and here you can see expanded blood vessels, especially when you have so-called metastatic changes, and in such a situation you had no option but to expand it up to the bifurcation of aorta stage, and you can also see that there will be a small bifurcation, and you can also see the opened mesenteric arteries, and it helps you to resolve the issue with blood vessels, and it's quite easy to do it more, I would say, in your learning curve, but anyway each of the surgeons try some other ways, I mean the ways they are I would say trained to clip the aorta, and we have oncological and onco-urological surgeries, and why I'm showing you the pictures of, I would say, open access surgery. It can be done as open access, it can be done as I have mentioned laparoscopy, so we have various forms of thrombosis, and you can see we have a full occlusion of vena inferior cava, and of course here also you have the surgeries which comes up to thoracic ectomy, and even malignancies which are penetrating the heart. So we are mostly focused on so-called laparoscopic access, and in our clinic we have conducted surgeries on malignancy thrombosis, and you can see you can do it with I would say easily with some, I would say, easily technological access methods, and you can see that you can also come across malignancy thrombosis which might require you open access surgery, and in case of nephrectomy 15% of them have been related to thrombectomy also, and I will show you the resection stage where we have opportunity to remove malignancy malignancy not meeting all the requirements and the standards. So here we can have it even at the posterior surface of kidney, and in most of cases we are facing the problem with traumas of vena inferior cava. And in most of cases, we resolve the issues with your, I would say, a clipping of your arteries, and we have changed certain laparoscopic approach. And in oncology, we will still have open access surgery, because sometimes you cannot even take all of these, I would say, malignancies. You cannot take all these tumors away from the organism through laparoscopic gaps. So the only way to remove it is to have open access surgery. And in such a situation, especially at the stages of early diagnosis, when we are happy that we have patients with a small size malignancies, tumors, in most of cases patients are asking whether it will be done laparoscopically or not, because they do not they do not see the difference. They do not understand why should we go for open access surgery in certain cases. So this is the most important anyway of the directions of so-called abdominal surgery. Colleagues, questions? Please, it was a very interesting report. I would like to just ask one question. Yes, you have shown very interesting result laparoscopically. And what was the maximum level of tromb malignancy? It was around 5 centimeters up to diaphragm, but we at least came to such I would say conclusions that it's not easy to conduct surgery laparoscopically, because we do not want the tumors to be kept after the surgery for a long time in in the body of our patient. So thank you so much, and now we would like to give the floor to our next presenter, Mr. Azat Analiyev from Astana, and he will inform us about chemical embolization in case of carcinoma. Dear colleagues, good afternoon, dear panelists. So I have checked the program of today, and definitely we had a lot of interesting about vascular surgery, and I do hope that the number of such surgeries will grow. And we will be discussing chemoembolization in case of carcinoma exceeding 5 centimeters. I will not be focusing on statistical data. And I would like to mention that unfortunately, if annually we identify over 41,000 of patients, 12,000 of them are dying on annual basis, and the majority of them are people before retirement age, so that active labor age. So we need to be able to help them to preserve our labor force, and therefore according to Barcelona classification, we have embolization, chemoembolization of feeding vessels. So we are trying to introduce ESAL, AAL, SLD standards and state-of-the-art American standards, and of course, we are identifying new cases of carcinoma a year. In Asia, we have around 50% of new cases of carcinoma, but in 2020, it was, the indicator was around 70%. So one thing which I would like to mention is that we have the primary clinical research. I will not be focused on this slide, considering that we are running short out of time, and we have various approaches, and you can see that we have so-called drug evaluation methods, and also we have the technologies of a controlled release of the drug, so that you will not be producing any negative impact on your liver. So it helps the patient to preserve the function of liver, and of course there's no problems related to kidneys to liver's malfunction. And according to Barcelona classification, which is renewed on annual basis, and as I have already mentioned previously, we have been doing for transarterial chemo embolization. At the moment, we can also go for holmium or yttrium also for X-ray treatment. So of course it might be some quite problematic kidney coagulation, and we are having multidisciplinary medical exam, and you can see that they are giving their own conclusion regarding whether this test is feasible or not. And in most of cases we are using chemical drugs, and in most of cases regarding drug elution bits, they are providing steady and controlled release of the drug. And of course we are using so-called super selective technique, which is called CBCT, which improves supply of the drug and preserve the functions of liver. And for us, we need to have a selective approach. And according to the last clinical guidelines on treatment of carcinoma, in case if malignancy is exceeds 5 centimeters, of course it cannot be removed surgically, and as a first line drug we recommend TACI. And here you can see we are using so-called live pearl microspheres, and we have the also in tandem, and the clinical efficiency has been approved since beginning of 2000. And also I would like to share with you a clinical case with my patient 2000. We had him in 2006, 2024, in January. He is 69 years old, and he has a carcinoma, and he has a tumor around 11 centimeters, exceeding 11 centimeters in size. And by 12th of February this year, they had 5 sessions of TACI, which helped to stabilize the tumor process, and they have resected the fifth segment of liver. And after histological treatment, they have seen 70% of necrosis in 6 and 100% in 7 segment of the surgeon. And enabled to fully resolve the issue, and the patient went for treatment, and we have managed to upgrade operable surgery into operable surgery, after which the surgery was conducted, and we had one male patient, 76 years old, with carcinoma at the first stage, and it was 7 centimeters in size, and from 8th of November 2023 they had 4 courses of TSE conducted, and on 14th of October 2024 Cherny laparotomy was conducted, cholecystectomy was conducted, and we have also morphological research showed the tumor with necrosis up to 80%, which was caused by TSE, and it also proved the efficiency of these methods of treatment. I would like to show you the video. You can see this angiographic data after embolization, and on your left is the malignancy. You can see the it is painted now, and after embolization you can also see, so we have received quite nice results, and also we had nice results from embolization. We have MRESIST very good criteria for measuring the reply to TACE, and also we have IRT assessment for retreatment with TACE, and a lot of doctors are in argument with each other what is the period of chemical embolization, and these particular indicators are giving us opportunity to I would say assess the situation of the patient, and probably we can help patient in 2 or in 3 weeks after the first session of TACE. And also we have a CHLPU classification, we have a CLBC classification, and treatment response. So in 2023-2024 we had this 66 patients with carcinoma exceeding 5 millimeters, and in 30% of cases we have reduced in 30% of cases the size of carcinoma. Of course, carcinoma treatment is not, I would say, easy thing, and of course everything has its own limits, but anyway, TACE's importance is growing, and we see that TACE can be integrated with other ablations and radiofrequency ablations, and it will give us a better chance, a better opportunity to check. And you can see the equipment which we have. One is for microwave ablation, which can be conducted for, which can be used for various types of soft tissue tumors, and by 2023 we have been using this equipment of ablation, of radiofrequency ablation. Thank you so much for your kind attention. In case of any questions, please feel free. Yes, sir. It was very interesting presentation, to be fair, and what is the thing which we can conduct, and what can we do it? How can we do it? You have mentioned about these types of treatment. Yes, thank you so much for your interesting and valid questions which you have raised to the floor. I have shared with you, I mean, the several results, and I guess tomorrow, I mean next year, we are going to share our results. what is the category of patients, or how are you doing it, some sort of palliative treatment, and what is the difference? I would like to know, because actually it's very interesting for me to know about I would say treatment. Probably this is just some sort of opportunity to prolong people's life. No, this is for the patient with whom you cannot conduct the surgery with them. And actually our, I would say, major assignment is to improve, to upgrade this particular disease. So, for example, if when you have been mentioning 80% of positive results, how you done it? Probably you have been resolving the issue with pathomorphosis, or how have you resolved? No, actually we are doing so-called vessels invasion, and we are checking it whether it's possible or not. But because the major purpose of chemical embolization is to have ischemia and produce its impact, would it be pathomorphologically, etc. And how would be, I mean, how easy would be to conduct the surgery when the surgery is less than 3 centimeters? So indeed you have a quite I would say quite difficult understanding of what can or what cannot be I would say operated. So I would like to now give the floor to our colleague, Mr. Sanjar Khudayarov. Please, the floor is yours. Dear colleagues, dear panelists, indeed, pancreas cancer is a very significant issue, not only in Uzbekistan, but all across the world. I will try to be very brief and embrace the major issues, as well as, you know, the major treatment strategy is a total gastrectomy, and of course we are conducting so-called esophagus anastomosis, but this sort of approach called significant issues after treatment. In most of cases we are facing so-called syndromes, and patients having so-called damping syndrome, and the patients are facing anemia also, and one of the major problem becomes alkaline esophagy, which reduces the quality of life. And we, since 2007, we had a total gastrectomy in 63% of patients, and as you can see, we are not talking about gastrectomy. We would like to mention that first of all we are having anastomosis, and of course after this we are creating artificial reservoir from intestine, and I can tell you that it should meet several questions. The patient has to have significantly enough of reservoir, and of course this reservoir would be unloaded to a tiny intestine, and of course we have to prevent reflux, and you can see this is the method which we are supplying after gastroectomy. We are conducting reservoir up to 500 milliliters from the intestine, from the small intestine, and we are having this passage restored, of duodenal the passage restored, and you can see that after we are having this reservoir in place, the patients are having significant weight loss, and it improved the better results, and so the, I would say, lack of body weight became 30. It has reduced from 87 to 37%, and in cases of anemia, they had in 100 patients, but after reservoir, cases of anemia reduced up to 54%, and talking about the hypoproteinemia, we had it previously in 67% and now in 40% of patients. So the most important step of gastrectomy is anastomosis, and the most important problem is that anastomosis sutures cannot be kept properly, and in most of such cases they end up with mortality in 40-70% of cases. Therefore, we need to reduce so-called after surgery complications, and you can see the anastomosis here. Everyone is well aware, and you can see the number of the, I would say, failures. In 9% of cases, anastomosis fail, and this is our message, so-called the intravaginal anastomosis, and we are showing how we are now having this anastomosis put in place, and we have invagination of esophagus in lumen of intestine, and we are putting on its upper side also anastomosis, and as you can see that after standard anastomosis according to Gelerovich, we had 9.6% of failure rate, and after our invented method, the number dropped tenfold and became 0.4%. And the reflux esophagitis after new anastomosis, total 16.7%. But in previous cases it was up to 70% the cases, and dysphagia was totaling 46% in other cases, and in our case it was only 20%, and regurgitation also reduced from 73 to 23.3%. And what are the conclusions which we can draw? First of all, that if you will be having a reservoir which is replacing stomas, it has reduced majority of events, adverse events, and of course our methods of invaginal anastomosis reduces the frequency of failure of esophagus and intestine anastomosis, and it provides after surgery treatment related adverse impacts and consequences, improving quality of patients' lives. Thank you so much. Do we have any questions? Yes, we do not have, but as far as I know, Mr. Mikhail also had conducted the same questions, and both Mr. Mikhail and us, we had I would say the same success rate and the same efficiency rate. Thank you so much. And now we would like to give the floor to our next reporter, Mr. Madyarov, who is representative of Lapin School, Mr. Madyarov, who will inform us about those technologies. Dear colleagues, good afternoon, ladies, gentlemen. It's our pleasure for this presentation. I would like to thank all of you for the opportunity to share our experience with you with what we're doing. I mean, whatever presentation you are starting is surgery is the only way of treatment of colorectal treatment, and the surgery always improved their methods, and of course we have tried, I mean all of us are working on improving survival rate and reducing mortality rates, and in most of cases we are working on surgery, and we have moved from hand-assisted laparoscopy, we moved to a 100% laparoscopy, and all of these intralumen surgeries became one of the best resolving methods for cancer treatment, and robotic consoles help us to treat cancers and tumors with precision, and of course it helps us to address the issues of patients of the patient's quality of life, and we have shown in results as a la carte color 2 or color 3. You can see we have a bit issues. It's like around 5 centimeters. When you're talking about 5 centimeters, it can be used for creating intraintestinal anastomosis. When we are talking about mini anastomosis, we can tell you that this is some sort of, I would say, a reason behind the reason why our patients are getting additional anesthesiology. We didn't have at that period anesthesia, and in most of cases we are facing the problems with anesthesia, and also we had some additional, I would say, adverse impact, including hernias, which call for recurrent surgeries, and as I have already mentioned, it is always a problem because it is some sort of additional budget burden. So with previously they have used single port access, then they have using several methods, and everyone was asking, why can you do it, this surgery? Because you can use it only for noses technology, so that macro preparation can be removed from this area. I'm sorry, it is not moving. gross specimen. Yes, thank you so much. And these accesses become some sort of new technology, and is it a new access? And in PubMed you can find the first article which was which dates back to 1984. But in this period, the government, the surgeons decided to remove all of the cancers through natural orifice, and you can see that the interest to this surgery was in 2022, when we have been combating COVID, and we had 50 scientific publications even in the COVID era. So if we will check the gross specimen removal was, I would say, transvaginally, transrectally, or anally. So this, I would say, transrectal became the most important, I would say, methods of gross specimen removal. So we have two articles dates back 1990s, and we have gynecologists and we have surgeons. In case of endometriosis, they had so-called segmentary resection, which were removed vaginally, and there were no problems, no, I would say, adverse impacts, and it caused a lot of, I would say, changes, a lot of growing trends, and it was just general gynecology. It was segmentary resections in case of endometriosis, and the patients faced no adverse impacts or complications, and the hospital stay period was only 4 days. So why oncologists should lag behind? One of them from US and second one from UK decided to have right hemicolectomy, and they have conducted this surgery, and they have transvaginally specimen retrieval, and the patient has no complication or adverse impact. They have spent only 5 days in hospital stage, and we had a lot of retrospective changes, then prospective research, and the first meta-analysis was published in 2020, which embraced around 2,400 patients, and we can see that in case of noses, the frequency is less than 9%, and pain syndrome was less, as well as serums and purulent cases was lack, and the number of hospital stay days also reduced, and you can also see that our patient has changed, I would say, they have studied a very important issue is the surgery time. I will tell you why this can be seen as, I would say, a disadvantage, but we have several methods of noses technology of gross specimen, natural orifice retrieval. So cooperation between a Russian and Chinese scientists led to publication of one book by Pyotr Tsarkov and Van Shishan. I will not enter so deeply into this topic, but first 3 are related to I would say below department of intestine, and they have been finalized with transvaginal retrieval, and everything has been or transvaginally or transanally, and the last 3 noses were related to left side hemicolectomy, and 8, 9, and 10 noses were related to right side localization of surgeries and so-called synchronized tumors, which required noses retrieval. I cannot answer you this question because I'm not the one who supports this idea, but this technology is very commonly used in Southeast Asian countries. You will see a lot of new technologies, and all of the surgeons who are dealing with colorectal surgeries, it can of course take a quite long period of time, and of course all of these linear methods calls for new treatment and learning curve. So for you need to, I would say, focus, and I can tell you that is it such a good method? No, and you have data. All of the data actually date back to 2020. First of all is contamination, bacterial contamination faced in 50% of cases, but we also have antibiotic treatments, and we can use everything, but what I'm scared is 9% indicator of tumor cells penetration, and it sometimes it can increase in T4 to 33, and in L2 it can reach up to 50%, and in most of cases we are having such cases, and we know that when you can I would say retrieving a specimen from intestine, you can have a problem with mesenteric vein. So and of course we might face a problem with area, and you can also have problems with anus muscles. So we have a lot of problems with sphincters, and this is, I would say, such a high price to be paid for cosmetic impact. So before you are selecting certain message, you need to conduct this, I would say, analysis. We had 17 patients to whom we have conducted I would say treatment, and transvaginally we have removed gross specimen. Body mass index was 24, and average age was 54, and the women were dominated among gender group, and anastomosis have been done in 2 rows manually, end to end, or laterally to end, and in most of cases we had so-called preventive stomas, colostomes or ileostomes, and 258 minutes was the surgery time, and blood loss was 120 milliliters, and paresis easily were resolved, and hospital stay totaled 7 days, and the quality of TME was G3. So I would like to share one case. We had the woman, she is 47, she is also from Tashkent, and In 2019, she had this disease outbreak, and she had MRT4B and M2MX. It was invasion into posterior wall of vagina, and you can see the MRI. So we had combined chemo and X-ray therapy and 2 sessions of chemotherapy, but to have the full clinical response, she had 8 TNT therapy, 8 sessions of therapy, and we had the chemical, I would say, reply. At the first time, she had she has to undergo surgery, but we came up with alternative, so-called watch and wait protocol, and she agreed for this. So each 2 months she had the MRI, and in 1 month she had the growing, she experienced the growth of tumor into rectum, and you can see that the metastasis has been clearly seen in the upper lobe or upper right lobe of lung, and she had a simultaneous resection and thoracoscopic atypic resection of lung. We are showing you the, I would say, important part. We had surgery, we had mobilization of left side. We have been working according to all the rules of TME, and we had the so-called retractor, we had anal channels. We have removed the part of the specimen, gross specimen from the vagina. You can see how it's seen, that it's a G3, and also we had 2 stages, so-called colonal anastomosis, and after the surgery we have the sutures on your vagina and how it looks like, and also we, together with Mr. Davidov, we had thoracoscopic atypic resection of right lobe, right upper lobe of your lung, and you can see that the surgery time was 3 hours and 40 minutes, and no complication of no anesthesia, and the blood loss was 100 milliliters, and your hospital stay period was 6 days, and we also have the analysis which confirmed result, and it's me with Mr. With my scientific supervisor and our patient. So of course we are just sharing our own experience. So this is, I would say, the ideal, the perfect patient who can undergo this treatment. So, number 1, it should be a female with a big, I would say, pelvic, and the body mass index should be at least 25 centimeters, T1, T2, small tumor surgery. If it's anal access, it should be 3.4. It should be, and in case of transvaginal, it should be 5 centimeters. And so thank you so much for your kind attention. Thank you so much. Very interesting report. And of course we have a lot of questions to be asked. I guess after this session I will also address to you, dear colleagues. Try to be very short in your presentations, not 12, not 15 minutes, but 1 or 2 minutes. And now I would like to give the floor to Mr. Vyacheslav Aliyev, less invasive surgeries, please. Be very short. But the most important thing actually in the video, I would like to thank all the organizers for giving me the floor. And of course I will try to be very short, because my certain colleagues of mine have touched upon this topic, and why I have focused on this particular surgery. I can tell you that I am the surgeon who have been working for I would say the most important rules, and one thing which I would like to mention is that as we have new technologies advancing in medicine, you should have the according to the quotation of Kocher, your incision should be as bigger as possible, and still it should be as small as possible. So if you have these robotic technologies, this is one of the most important things, and of course what should we keep in mind is that surgery should be very safe, and we have also mentioned that we should not forget that whatever the access we have selected, they should be, they should meet the so-called lymph dissection, especially if we want to preserve the sphincter. It should be safety, of course. We should have the adequate drainage, and we should, I would say, treat this category of patients properly. And we are treating patients meeting all the oncological rules, but what we would like to mention is that there should be methods of reconstruction and preservation of vegetative nerve system, and of course we need to keep these intestine reservoirs. And shortly I would like to mention that the most important fact that Dmitry Ott in 1901 has conducted the first less invasive interaction, and Michael Moses Jacobs has conducted in the 1990s, and we have various surgeries from less invasive surgeries and robot-assisted surgeries. And the first important information which we had in literature, it was in 2001, and historically we had the first robot which was used, and in 1994 we had the surgery for a surgery on spine cord, and it was used, and at the moment technology significantly changed, and these technologies are of fourth or fifth generation with single port access. And talking about Da Vinci development in Russia, Russia has only 59 systems of Da Vinci, and by August 2025 we had only 42,000 of robotic surgeries accomplished, and the number of this surgery is growing 6,000 to 8,000 surgeries a year. At the moment we had 11,500 Da Vinci system installed, and around 6,600 of them are in US, and 2,200 of them are installed in European countries. But anyway, 59 is not such a big number for such a big country as Russia, and we have the literature, medical literature data regarding learning curve, and of course we have around 43,000 publications we have been introducing this surgery and checking whether these surgeries can be accomplished using robots and medical robots. And if you will address to the medical literature data, you can see one of the major meta-analysis conducted by 2020. It embraced 8,700 of patients with the best indicators of less invasive surgery, but all of these researchers embrace not only robotic but also transanal and laparoscopic research, and also whether these surgeries are required. Conversions are not mistake, but if you want to conduct some less invasive surgery, if you are starting your surgery with less invasive access, definitely you want to finalize the surgery with not converting it into open access surgery. So real study also showed the conversion rate is 40%, and in robotic surgeries it showed 1.4%, and they have identified specific features of these patients. Of course, for us it's very important to know we had 50 research and meta-analysis which conducted robotic surgeries with laparoscopic surgeries to check the number of nodes, lymphatic nodes, and also regarding blood loss. But these surgeries are a bit more expensive, and treatment expenditures are quite significant, but long-term results are compatible. So they have been, of course, checking also the quality of TME, conversion rate, and the frequency of conversion. And also the last research we had in June 2025, and it showed both clinical research and local recurrences. It was 1.6 in case of laparoscopy also. So of course indicators were very interesting, and of course we have the good techniques. We are also seeing how we can, I would say, resolve these issues. For example, each of these robotic systems has their own disadvantages, because first of all they're quite big, which means that the surgery should be also bigger, and also it's quite expensive surgeries, but still you do not have any unified devices and consumables. So Chinese colleagues are more competitive, and surgery of 2021 showed a very significant maintenance cost, and as soon as the things are, more you are proceeding with this surgery, more you are having the learning curves of the patient, you can see that the number of complications is reducing, and the conversion rate is also less comparing to laparoscopic surgeries. And so the one another research show us the I would say cost of surgeries. So for example, the for us it's the most important and the most complicated surgeries is open access resection. So it will be around 13,000 USD per patient, including medical treatments, nurse, hospital stay, and patient service. But also it shows that the robotic surgeries are a bit I mean, the price is growing. Robotic surgery became 17,000 USD, and the reduction of hospital stay and the reduction of recurrent cases leads to such economic benefits. Hopefully, we will get back. And moreover, robotic surgeries is one of the components of abstract protocols and they have quite short learning curve. They have a lack of tremor impact, and they reduce fatigue feeling in surgeons. And we are ready to share our experience. So we have the experience of Mayo Clinic. So it shows the reduction of adverse neuromuscle impact in surgeons is much less comparing to laparoscopic surgeries. And here you can see that even the surgeons which are conducting so-called robotic surgeries are having a shorter learning curve, especially the one who have the experience with joysticks when they were kids. And the way we put the patients, I mean the tables should be properly prepared, and of course it's very important to have so-called docking philosophy, because there are some nuances which should be kept and each of the surgeons should learn it. And we can see that it's not easy, and even by now we are having all this line marked to plan surgery properly, because our surgeries can begin for example from upper part of abdomen or from smaller pelvic areas. So we should not move patient, and the port installation techniques, we have two hand left, two hand right. We are using both of methods, but for me is two hand left, because you can use your left hand instead of wasting your time on repositioning the patient. We had 55 patients analyzed. Well, on 14th of October last year we had Da Vinci technology. Previously we had 4 console surgeons, and we had 96 surgeries, robot-assisted surgeries. And the most complicated surgery is abdomen anal resection. And I can tell you that the most aged patient was 87, and obese patient with 32 body mass index. And you can see that T4 was in 4 patients. So in all of the cases we had X-ray therapy or chemotherapy or combined therapy, and the surgery was 55 minutes, and at the moment we have managed to reduce it up to 18 minutes. And laparoscopic methodics also helped us to ensure preservation of internal organs. And also we had the learning curve, and on treatment surgery, on 20 surgeries, the docking time reduced, and our young colleagues can cope with sometimes much faster than I can do it. And definitely we have fixed the reduction of the time of surgical intervention. In maximum time was 450 minutes, and so we had quite a small number of complications, and in 92% of patients they had no problems, no complications, and Clavien-Dindo was 1-2. I mean 4%, and Clavien-Dindo 3 was just 2 patients. So we face no problem with this identification, and we can easily conduct these prevention activities. I'm trying to move it. Can we? I would say, I mean, we are having the same methods of mobilization. And on your left you can see all of the layers, and unfortunately we cannot, I would say, move it faster. So we are running short out of time. I wanted simply to, I wanted to be more, I would say, fast. And today, unfortunately, we had not only access, but also we are having these sections. Yes, they are moving forward. Can we move this faster? So you can see surgery is conducted with no blood loss. We are using the same approaches as we had in open access surgery. We're having lipolayer, and we are preserving the arteria. Let us move faster, and we can use robotic hook also, which can help us to work in hard to access areas. And you can see a man's pelvic here. And also these are the measures which we see, and we have robotic method. So we are conducting here anastomosis. Now we are having anastomosis. And finalizing my report, once again, I would like to thank all of our organizers and participants, and availing myself of the opportunity to invite you to our conference. Please kindly pay a visit to Moscow on 16th, 17th of October. It would be our pleasure to host you. In case of any questions, I'm pretty sure that you will get your answers. And let us give the floor to Mr. Khurshid Abdukarimov, state-of-the-art approaches to organ-preserving surgeries.
Assalamu alaikum.
Dear colleagues, good afternoon. Dear panelists, colleagues, and my report will be dedicated to state-of-the-art approaches to organ saving, preserving treatment. I have only 10 minutes to deliver to you, but it would be my pleasure to inform you about, say, brief history. When I was just intern, when I came to oncology center, and our director told me, you should be very good mammologist, or you should be good thoracic surgeon. And I have told, no, I wanted to be just oncologist. I want to deal with skeleton and muscles. oncology? He was like, don't you have a time? Do you want to do amputation of the soldiers? And I have told, no, I want to preserve their hands and legs. And he sent me to Mr. Mirzaliyev, and who is the father of onco-orthopedics in 1994. Our department was organized, and 31 years we have been dealing with so-called preservation surgeries, and I am proud to announce that within these 30 years we had over 10,000 of surgeries, and probably 6,000 of surgeries were surgeries on bones, and 90% of them were preserving bodies. I do not want to come up with scientific report regarding survival rates and etc. I just want to share with achievements which can be attributed to our efforts.
Куда это? Деньги с собой? Ну, всем известно, что...
You are well aware that the surgeries or I would say bone tumors is just 2% of all the malignancies, and 40 years ago it was probably the major treatment, major I would say approach to treatment was just surgery, or previously also we used chemotherapy, but at the moment we are helping the patient to conduct preserving surgeries in 60-70% of cases. Yes, I'm trying to move as fast as possible. As you can see, we are having the technology of preserving surgeries in all the I would say bones and on skeleton, and of course one thing which I would like to show you is one little girl, and she has a surgery and after endoprosthetic surgery you can see her movements. And we have the patient who had the osteosarcoma of distal epimetaphysis of his femur. You can see after surgery his movement, and also here we have proximal osteosarcoma of metadiaphysis of right femur, and you can see the result also. And you can see the activity. So we have the proximal part of shoulder bone, and you know that this is alternative to endoprosthetic, so the surgery, I mean metastatic surgery, and it was a resection and alloplastic with metal and concrete, and the so-called chondrosarcoma, highly differentiated, and we have reticulosarcoma of diaphysis, and you can see the resection which was conducted, and we have the patient with osteosarcoma, and you can see the movement and you can see the results of his movements. So So we have our patient with surgery with humerus, and he has recurrences and resection and endoprosthetic. So here are the surgery, and you can see the result. So endoprosthetics, they had the so-called prosthetic, endoprosthetic, and the result that all the functions have been preserved. And you can see the distal surgery, and the child, it was a 20 years old child, and so parents wanted his legs to be saved. We had resection with endoprosthetic, but within 2 years, unfortunately, this child passed away. So we had the lungs, and the lung cancers metastated in femur, and we had osteosynthesis with concrete plastics blocking. So here we have chondrosarcoma of distal section, and we have removed all the femur and installed endoprosthetic, and two of joints were chaired, and you can see functional results, and in 3 weeks and in 2 months you can see the movement. And also we have the patient with osteosarcoma of right femur of distal section. So we have conducted surgery, we have removed the femur, and it was endoprosthetic, and you can see the result. And since 2018, we have also entered into resection of ileum, and the first surgery was conducted in 1998 together with Zatsepin, Professor and we had Mr. Hamraev also helping us, and at that period we had so-called ileum resection, and at the moment we are conducting also the prosthetic of the pelvic bones. So you can see 3D modeling at the moment on your screen. So patient has indeed significant, I would say quite huge tumor, and we had so-called the metal and concrete prosthetic. And you can see the result in 2 months after the surgery. So all of these surgeries are having, I would say, advantages comparing to interferences which might lead to organ losses, and they have to maintain the quality of life and functional restoration of the patient's qualities of life. And so in case of primary tumors and metastatic tumors, the most important method is segmental resection with endoprosthetic, and in case of diaphysis malignancies, we can go for segmental resection with endoprosthetic. Thank you so much for your kind attention. Thank you so much for your interesting report, and we do not have a time for Q&A sessions, but we are lagging behind. But we should also give the floor to our participants from online. We had Mr. Dr. Lucas Sanz, the treatment from sorry. We have Mr. Professor with us from Santa Cruz D Clinic, Tenerife, Spain. Sir, are you with us?
My name is Lucas, Dr. Lucas Sanz. I came far away, I'm from Spain. I came from the Canary Islands, I don't know if you know them. These are in the middle of Africa, but belong to Spain. And imagine a place that is surrounded by crystal water, that has colorful fresh fish, and in the middle stands a big mountain. In fact, it's a volcano, it's called the Teide, and it's the highest peak of Spain. There, the weather is very stable. You don't have freezing winters or overwhelming summers. And the rhythm there is marked by its beauty, by its fragility, but there we have another reality. In the southern part where I work, patients do have to face poverty, have to face isolation, and have to take long travels to receive their care. That's why we propose to open an oncology department there, which is now treating women with breast cancer and gives the treatment in their dignity and with their needs. First of all, I would like to thank you to the organization, to the Congress for the invitation. It was an honor. I'd like to thank Ever Pharma for their support, for their help, for their friendship. And I'd like to thank also Uzbekistan country, because I was very impressed with the country itself. It shows it's very beautiful, it shows a lot of development, and the people are very warm. So I think you should be very proud as a state. So once we started, let's imagine this scenario. We have a 55-year-old woman diagnosed with hormone receptor positive breast cancer. She started on an aromatase inhibitor, but now she shows progression. So what can we do next? And it's now our duty as doctors to decide what's going to be the patient's journey. What we are going to talk about today. Well, first we are going to talk about the foundations, the endocrine therapy. Then its major limitations, the resistance. We'll face the important role key player in resistance, which is the nuclear estrogen receptor. And then we'll come to fulvestrant and why fulvestrant, why this drug is so interesting in using in this setting. And finally, we'll get up with some conclusions, bringing up the case I presented. So, 70% of all breast cancers are hormone receptor positive. These are generally associated with a better prognosis than triple negative or HER2. And they are most frequent in postmenopausal women. You can imagine the malignant cell such with the receptors in the interior, and from many years ago there were designed some drugs to deal with the receptor. First was the tamoxifen, which takes the receptor and modulates its action. And later on were designed the aromatase inhibitors, which don't allow the conversion and don't allow the production of estrogens, so they can't face the estrogen, the receptor. But we know the limitation is the resistance going to come. And it's going to happen within the first 2 years. And then what can be the objective? Now the objective would be to prolong the control and to delay the start of chemotherapy, since we want to win time and win quality of life. So we could define first primary resistance as those patients that do not respond to the treatment. And we could expose acquired resistance to all those patients that eventually progress to tamoxifen or aromatase inhibitors. And which mechanism do they use? Well, they have ESR1 mutations, PI3K, AK2, mTOR activation, or cyclin D, cyclin D alternative pathways. But if we want to understand this better, we are going to focus on the nuclear estrogen receptor. There are two main of nuclear estrogen receptors, and they are coded by two genes, ESR1 and ESR2. And in the absence of estrogens, they are in the cytoplasm. But when the estrogen binds the receptor, they release chaperones, they dimerize, and they get into the nucleus. Inside the nucleus, they can bind to specific DNA sequences called estrogen response elements or interact with proteins, and that's going to drive the gene transcription. So let me show you with a picture. On the left hand, we have these steroids with these estrogens which bind to the receptor. They form this complex, they release these chaperones, and they recruit coactivators. These coactivators start the RNA polymerase machinery and deal with the transcription. But as we can see in the right part of the drawing, the receptor activity can also be modulated by phosphorylation in independent alternative pathways through MAPK, PKA, or signaling pathways. That's the non-canonical nuclear estrogen receptor activation. And what does produce the receptor in our body? Well, these genes that are regulated by this receptor include key players in cell cycle, proliferation, and survival, such as MIZ, cyclin D1, BCL2, IGF-1, among others. And these receptors also play roles in metabolic and vascular protection. But why? Why is it so bad, the estrogen receptor? Why was designed to be malignant? I have to say, in our bodies, we're not designed, we as humans are not designed to be malignant. The estrogen receptor has a function itself, because in women's development during puberty, in the environment of estrogens, they develop their breasts, and during pregnancy in the hormonal environment, these estrogen receptors will stimulate the breast cells to grow, proliferate, and prepare for breastfeeding. I mean, that's nourishing what's going to be a new life. Let's check fulvestrant. Fulvestrant, let's check this drawing. You see it binds to the estrogen receptor and inactivates the transcription factors. In fact, with these factors inactivated, there is no recruitment of coactivators, there's no possibility to encode for the DNA, and there's no transcription to the DNA. So this is a blocking of the act of the receptor, but not only this, it also produces the elimination. So this dual mechanism of action is what makes this drug so interesting. And the clinical evidence comes from different trials. We saw in the confirmed that the dose of 500 milligrams is much better than 250, and now is the current dose. We saw in the Falcon that in first line, fulvestrant was superior to anastrozole in selected specific populations. And we also saw, which is very relevant in the Parsifal study, that fulvestrant remains effective after progression to aromatase inhibitors. And this is also effective in mutations of the ESR1 and with a good safety profile. And the Paloma 3, Monarch 2 were the canonical pivotal clinical trials that set the fulvestrant with the cyclin inhibitors as in the first line. And what can we do when our patients progress to these current standard first line cyclins plus in aromatase inhibitors? Well, the BILIF tried to study patients with PA3 mutated cancers who had progressed to this first line. And they show promising results. They show at 6 months, almost 50% of the patients remained without progression, with a median progression-free survival of 7.3. The safety profile was quite easy for us doctors because we learned how to deal with the hyperglycemia. So fulvestrant served as the key backbone on which alpelisib was tested in this second-line setting. But now let's focus in another topic, because as far as we can tell, some gynecological cancers can be hormonal-driven too, and our European guidelines tell that it could be used hormone therapy, especially in grade 1 receptor-positive tumors, and they suggest agents like progestins, tamoxifen, aromatase inhibitors, and fulvestrant. And maybe for fulvestrant, the solidest evidence comes from the GOG study from 2010, which showed modest efficacy in overall response rates, but with almost a 30% of disease control rates in highly pretreated patients. And there are reported some cases of long-lasting reports. So fulvestrant should be an option in this kind of patients after finishing all the previous lines. And then we get to why fulvestrant, why Ambiful? Because its consistency and reliability. His high-quality formula ensures a good bioequivalence. In fact, the intramuscular delivery guarantees the complete estrogen receptor degradation. And that's an advantage over oral new degraders because avoids the variability of the absorption, the food interactions, and helps with the adherence issues. And why fulvestrant? Because of its practical advantages. Simple dosage schedule. We start with 500 milligrams in day 1, and we repeat the 2 next weeks, and then every month. There's no daily pill, so reduces the patient's fatigue and improves the compliance, and the local tolerability is good, since there's low discontinuation rates. Why fulvestrant? Because its safety profile, because there are decades of safety data, because maintains the low toxicity profile. Just mild injection site reaction, no major systemic effects. And we know there are fewer unknown long-term toxicities versus next-gen degraders that we are still on study. And finally, why fulvestrant? Because it's economical, because it's affordable. And that's very interesting in health systems where cost effectiveness matters. So this may be one of the most important slides in the presentation, because not only because it's the treatment flow, because since it's the coherence, the logistic we follow to treat our patients. We would start with the aromatase inhibitors, since they are effective, and they guarantee a stable effect and a gentle treatment in the patient. But whenever they progress, we don't have to rush into chemotherapy. We can make off fulvestrant, we can continue the endocrine sensitive line, because delaying chemo is in fact a clinical victory, because patients get less hospitalized, we avoid hair loss, especially in women, we diminish the chance of neuropathy. And whenever we are in advanced phases, we should opt for new options. We should for innovation to keep pushing through the disease. So this is not only a treatment flow, this can be a philosophy of how should we treat our patients, because we don't have to forget that in every box, every step we are trying to maximize, there could be a 55-year-old woman that's struggling with a cancer, that's beloved by her family, by her children, and worried about her future. So, to take home messages, and I'm almost about to finish, 70% of breast cancers are hormone receptor positive, and fulvestrant is an estrogen receptor degrader. It has proven efficacy, as we saw in the trials. It's scheduled simple and intramuscular, and it's well tolerated, and it keeps patients away from chemotherapy longer. So we are dealing today with dehumanized times. I mean, medicine's growing fast, and sometimes clinical decisions are very quickly, and in fact, we are confronting our patients. Besides, artificial intelligence would replace us in the choice of clinical decisions. But what a machine can't do is to deal with the connections of the people. And how can we connect with the people if now we are more disconnected than ever? We remain with our phones. I was wondering how to handle this distance, and then I realized I was a doctor that was grown with the technology, and I thought about reaching my patients through the social media in a way of bring science, in a way of educate them. So in the next slide, you'll have my Instagram. It's in Spanish, but it's a way of trying to empathize, to give humanity, and to give wisdom to our patients. Because I have to thank you, not only to all this setting, to the organization, to Eber Pharma, to Uzbekistan, but also to the patients that clear us in mind that we should not lose this bond of humanity. Thank you very much.
Данная секция была разносторонней.
Yes, this section was very, I would say, comprehensive, and we have been discussing a lot of nosologies, and this section is called this section will be hosted with the best specialists, the famous, I would say, famous surgeons who will brief us and help us to have molecular and genetic strategies in combating oncological disease. Please, Mr. Yusufbekov, Mr. Jurayev, and Mr. Yakubov. So our first report will be dedicated to optimizing surgical treatment in case of blind intestine localized forms of tumors. I would like to thank UDIP steering committee, and it's my pleasure to share the results of our research, so-called segmentary resection in case of localized forms of tumors of blind intestine. And we will share our experience of oncological center named after Loginov. You know that the principle of so-called colonic cancer is based on two principle is Western and Eastern school. So Western school comes with dissection principle, and we have a reduction of local recurrences and increase of 5-year survival rate, and Eastern school gives us a chance to probably zone and separate the major lymphatic nodes which should be removed, and therefore we are in this situation. We are changing this fiber, cellular tissue, and so both of these approaches led us to development of hypothesis and development of concept of introducing segmentary resections, and it is based on following techniques including major radicality principles, and all of these types of surgeries are not producing long-term impacts of the surgeries, and they are showing us also the local recurrences rate, and I can tell you as a result that it's very efficient alternative to treatment. And talking about the blind intestine, I can tell you that in most of cases we have a hemicolectomy is, I would say, the gold standard in this situation, and we also removing the distal margins, and we are also removing I would say at the level of ileum, and of course we are having anastomosis definitely, and the concept which we are supposed to have. You can also see that we are going to have I would say lymphatic duodenectomy. It will be limited to groups 201, 202, 203, 213, and it is located at the level of ascending intestine, 10 centimeters from the tumor localization at the line of perfusion, and proximal margin is 10 centimeters from ileocecal line angle, and we have specified also the lines of D3 lymphadenectomy, and of course these issues are quite relevant at the moment, and cranial margins is located 1 centimeter below the vessels, and it is based on the mesenteric arteries left margin, and here you can also see the location of ileum artery, and what are the results which we have received after checking the results of 78 8 patients, we have seen that the treatment was, I would say, compatible in both of the categories of patients, and we came to understand that in frequency was it was 41 for right side helicolectomy, and for ileoresection it was 32.4%, and the frequency of major complications was around 8% in both of groups. So clinical efficiency and safety was quite similar in both of groups. So before surgery data, pre-surgery data, you can see we have managed to get good indicators. For example, we have reduced the hospital stay for right side helicolectomy for from 8 to 7 days, and we have reduced the surgery time from 180 to 140 minutes. And the indicators of recovery of the patient, all the indicators were, I guess, quite equal, but we have also checked the results, and for us it's quite important. It's I would say a positive side of these methods, and analyzing the reports, I can tell you that we have received quite good indicators, and we have also studied lymphatic nodes, and the number of nodes was practically similar, and it was around, I would say, 90%. So I would say it's quite good result, and we came up to a decision that in case of localization of I would say metastatic malignancies, it's in the group 2001 and 2003, and we can tell you that on the right side, the hemicolectomy, it can be related to resection, but also it will be very safe, I guess, surgery. So thank you so much for your kind attention. So thank you so much, Mr. Igor. I guess we can address you to your question, and I would like to give the floor to Mr. Mirjalol Duraev, and please, state-of-the-art approaches to the diagnostic and treatment of treatment, dear colleagues. I guess we have only the person who is so, I would say, committed to have researchers. We have we had around 20 reports, so I would like to be in here, I would say, thesis. We should move as soon as possible, and we have third and fourth sections, so I guess we need to move further, and of course everyone is trying to produce reports, and I will deliver my speech in Uzbek talking about disease, and as Mr. Andrei has mentioned, and yesterday he mentioned everything regarding this disease, and for example, should we have dissemination in surgery, and these surgeons, I mean, no one was treating them surgically, they were just getting the surgeries, they were only getting just a medical treatment. And I remember my patient who was treated for 4 years, and with, I would say, I would say drugs, but still it was a unique case because he had no recurrences. But I can tell you that we have 2 surgeries a month, and whatever we had, I would say, adjunctive chemotherapy, it cannot be, I would say, detected while surgery, but our morphologist will identify it while surgery. Who knows, probably today this is the situation which we have, but who knows, probably in 5-10 years the situation will change and everything will move to chemo or immunotherapy and we will have no surgeries at all. But I can tell you, not all the treatments who underwent just the chemical treatment itself or X-ray treatment itself, so the results probably will be much better. So I would like to draw your attention to the statistical data. You can see here in Uzbekistan we had a patient with stomach cancer, and most of them are at the stages 3 and 4 in Uzbekistan. In pre-surgery treatment, we have 68% at the stages 3 and 4. We should, elevate them to radical surgery, so something which can be inoperated can be operated by means of surgery. And we had 102 patients from 2016 and by 2020, and these patients as you can see, in most of cases we had the major group. They had the pre-surgery chemotherapy, surgery and adjuvant chemotherapy, and the second group surgery and post-op adjuvant chemotherapy. So you can see something which I will just pass by. And talking about adjuvant chemotherapy, it was, you can embrace all 100% of payment. You know that after surgery it's a bit problematic to have problems. They might have so-called agastral syndrome or agastral anemia, so it is not easy to have such a surgery, and we have 60% of our patients, but non-adjuvant chemotherapy, the patient has reserves, and you can conduct it definitely. And one very important thing is that, and I have also mentioned it, that we had 48% with so-called neoadjuvant chemotherapy, and some of them had so-called stabilization of the process, and some patient has no progress at all, and we had so-called endovascular chemotherapy. And talking about the chemotherapy approaches, probably 30% of them had regression, and so it was enough for, I would say, medical treatment, and we are showing you endovascular now treatment. And talking about our first group, in case of non-adjuvant chemotherapy, we had 84% of our patients with radical surgeries and gastrectomy. So, but 14% of patients, they had combined therapy, and of here we also have the control group, and all of the patients, they had the combined therapy, and it was also gastrectomy which was conducted. And talking about clinical cases, you can see that the patient has tumors in both tumor and metastasis in stomach and in liver, and you can clearly see that we have eradicated all the tumors and metastasis, and you have also the bladder metastasis here. And you can see the result of medical treatment, and all these issues have been resolved when you have majority of metastasis in the liver. And of course everything have been resolved, and one thing which is very important, I mean the survival rate. For example, if 1 year is related, and
demak o'tkazilgan preoperatsion ximyoterapiya 10-13%gacha bemorlarni 1 yillik muddatini, 3 yillik muddatini va 5 yillik muddatini.
So talking about our survival rate, a very important thing which I would like to mention is that, for example, even according to global literature, for example, you can see what we have been seeing here, talking about 5 indicators, talking 5-year indicators. It's quite good, but I have managed to touch upon, I guess, very important topic. So thank you so much for your kind attention. Yes, thank you so much, sir. And dear colleagues, now let us move further, and we would like to give the floor to our colleagues.
Assalomu alaykum, hurmatli mehmonlar. Так, уважаемые коллеги, разрешите представить презентацию на тему «Сравнительный анализ различных вариантов панкреатодуоденальной резекции». В мире рак подвздошной железы занимает 15 место по количеству впервые выявленных случаев рака. Это 4,7% от всех случаев онкологических заболеваний. Несмотря на...
And we will be discussing this very important issue because stomach cancer is located at the 9th place, holds 9th place at mortality rate in Uzbekistan. It is also very important case of mortality. It is case number 12. It is included in top 20. So we should also keep in mind that our research has embraced the 184 patients and related to stomach cancer, and they have been treated from 2010 to 2024. I mean, they were observed, and is a average indicator. I mean, we had 184 patients, and they had also pain symptoms. They had significant problems with nausea and with vomiting, and we have shown you the distribution of the patients, and At this particular moment, we would like to show you the localization of these diseases, and what can I tell you is that we have a 54% of adenocarcinoma disease, and of course the patients have been distributed from group to group, and the first group is 25% who have been treated surgically, and of course 24% patients were included in the second group, and the third group is the patients with pancreaduodenal anastomosis, and the fourth group included 26% with additional drainage of and treatment, as well as biliary duct drainage included in the fifth group, and the sixth group with pyloric sphincter preservation, and seven group of standard method treatment. So here we are showing you the distribution group by group, and of course this particular slide shows you resolving the issues of surgical treatment, and we have received the patient the patent for this, and we have the surgery after our gastropancreaduodenal complexes, and here we're showing you anastomosis, pancreatogastranastomosis, and this is the back side, and after anastomosis you can see, and the next stage is related to hepatic anastomosis, and here we are showing you the final anastomosis, gastroenter and enter anastomosis, and we have also shown the surgical treatment methods, and we have used also pancreatic anastomosis, and how you can see these treatment, these anastomosis surgeries. In this particular slide we have shown you the surgery of a combined method of drainage, and actually we had the patent also for this surgery, and we have conducted a drainage, two methods of drainage portrait, and you can clearly see so-called pancreatico, hepatico and pillar-preserving gastroenteranastomosis, and the less survival rate was peculiar to second group, the control group, and it was 81%, but the best result was registered in second group, 29%, and in cases of recurrency, we have analyzed that recurrency was closely related to metastatic processes, and it has no connection from the tactics of surgery, and we have identified that it was clearly seen at the four stage of tumors, and also we had the pancreatic fistula and 3.8 process, and anastomosis also, and anastomosis was 3%, and the less indicator it was related to we had 20 cases, and they were identified in the group 2, 3, and 4, and and the fifth group, it was 32%, and 29% we had in the second group the cases of recurrences and complications, and we have identified that the highest indicators of second-year survival rate was peculiar to second group, and the smallest indicators of survival were peculiar to second group, and moreover we had 12 and 14 months of survival rate, and they strongly worry in case of the tactics of surgery and morphological type of malignancies. So patients with aggressive tumors in the biliopancreatoduodenal zones had high chances of mortality within 12 months from the surgery date, and we also had exocrine cancer incidences which were accompanied with high mortality, 13 times higher comparing to tumors in biliopancreatoduodenal zone. So based on the ISJPS conclusion, none of the methods of anastomosis has any advantages among others, but notwithstanding these randomized clinical trials and methodological analysis conducted by various groups shows that pancreatic and anastomosis, according to Blumgard, conducting with two rows, ductal-mucosa anastomosis is the most reliable and efficient method of reduction of frequency of after surgery mortality and treatments. Thank you so much, Mr. Kenjaev. We can proceed with our questions a bit later. We will give you 5 minutes for discussion. Dear colleagues, you can ask your questions, and now we would like to give the floor to so-called neoadjuvant chemotherapy and fast-track approach. So we have Professor Yusufbekov. Please, sir, floor is yours. Dear colleagues, I would like to deliver our report on our and of course our center has significant experience in treating these kind of cancers, and this experience will be very interesting not only for you but also for our colleagues from neighboring countries, because our experience is very significant and I'm ready to share it with you. It's very important, and of course we are going to inform you because the esophagus cancer is ranked 3 among in terms of incidence, and it has 510,000 of patient, and it causes mortality of 445,000 of people all across the world, and it's ranked 12 among the mortality causes related to cancer. And at the moment, I can tell you that we are having reduction of medical medical cases of esophagus treatment, but still within this period, within these first 20 years of 21st century, you can see first of all it's located on the northwest of Uzbekistan, and also we have quite high indicators, and in the Fergana Valley, and on the central part of Uzbekistan, and Of course, in the center of the country, it is below average, and in Karakalpakstan Republic we have conducted this meta-analysis within these 25 years, which have shown us that 25,000% of patients within these 25 years they are exposed to this cancer after 64 years, and in most of cases 62% of men and 38% of women are exposed to this cancer, but the prevalence is around 21%, and very important to see also the I would say ethnical composition. We have also changed the Uzbeks and Tajiks, but anyway, Uzbeks, I mean, prevalence among Uzbeks is reducing, and growth among Karakalpaks is registered, and remaining ethnic groups, they also facing the reduction of the disease, the incidence, and talking about 5-year survival stages and mortality rate within these 25 years. The mortality has been fluctuating between 1.5, 1.6, but survival rate, 5-year survival rate total 27.7%, and also stages of disease. I mean, the first stage has been showing 1.6% of 5-year survival rate for the cancer of the first stage, and also it is less than 30%. And one thing which I would like to mention is that for esophagus treatment they're using a lot of recommendations of MSO, ELASCO, and we have developed our own methods and standards of diagnostics and treatment which are adjusted to Uzbekistan's realities, and we have everything which is required for diagnostics and molecular methods of treatment, and here we also have various tactics of treatment. And I would like to mention that 70% of our patients came to us at the third and second stage, so we have the surgery of conventional tactics of surgery, and chemotherapy also is conducted for 7 years from within this period till now, and also we have the results of our treatment, and it's around 100% of regression, and in recent 6 years we are using our own approaches which envisaged inter-operational stage and what we received in the end. First of all, we have the surgery planning. In 3 weeks after chemotherapy we are having the treatments, then we are also reducing the period and of intervention, and also we are ensuring the reliability of esophageal anastomosis, and we have developed our own, I would say, methods of anastomosis of Mr. Davidov. We have developed our own methods. We have modified this method, and we have focused our attention on reinforcing the anterior wall, because in 70% of cases, due to the failure of anterior wall, we are facing the problems with anastomosis, and we have very good dissertation defended based on the adjusted protocol of post-op management of disease, and we have the results of treatment treatment of these patients, you can compare, and we receive the best results, including even chemotherapy, and we have all these techniques included, and we can jump onto enteral treatment of our patient, and of course it produces no negative impact on our patients, and we have reduction of mortality rate up to 28.2%, and for 3 years mortality, we can tell you that in case of 3 years mortality, we had quite nice results in a group of adjuvant chemotherapy and gastroenterology technologies, and our non-recurrency period survival is quite also nice. So it was very good in a group with neoadjuvant chemotherapy. So we can also achieve quite good results, including radicality of chemical treatment, and it enables us to improve the results of treatment, and our medical practice helps us ensure not only medical but also social rehabilitation.
Около 2 миллионов человек, при этом около миллиона погибает от этого заболевания. Я вкратце пройду по докладам. На каждые 100 тысяч населения приходится более 15 человек с колоректальным раком и примерно 7 человек именно в азиатской популяции, а в мировой статистике 18 на 15 человек соответственно. А что касается цифр в нашей стране, по данным нашего канцер-регистра, за 2024 год на 100 тысяч населения приходится пациентов с колоректальным раком, уступая лишь раку молочной железы, она вышла уже на 2-е место по причине не только встречаемости, но и по числу смерти из-за онкологических заболеваний. Так, историческая справка: давно уже начато внедрение этих лапароскопических технологий. Ручной ассистенции, первое сообщение о роботе удаления опухоли через естественные пути и однопортовые лапароскопические технологии. Первая лапароскопически ассистированная правосторонняя гемиколоктомия была выполнена Майсом Джобсом в 90-е годы. В первую очередь хотел бы похвастаться нашим новым центром и его операционной. И, конечно, несмотря на то, что в современное время лапароскопическая хирургия является стандартизованной во многих клиниках мира, и, соответственно, никого не удивит данными лапароскопической методики. Лапароскопические методики — это меньшая травматичность, детальная визуализация анатомических структур, меньшие кровопотери, снижение частоты и тяжести осложнений, ранняя активизация, сокращение сроков госпитализации, сокращение сроков утраты трудоспособности и снижение потребности в медикаментах, лучший косметический эффект, наглядность и возможность обучения. Для изучения онкологических результатов были проведены крупные мультицентровые рандомизированные клинические исследования на территории Азии. Это Color Trial, Coast Trial и Barcelona Trial. Так, современная научная литература метаанализирована около 15 рандомизированных исследований, показала нет разницы между открытым и лапароскопическими операциями. Ну, когда говоря о раке прямой кишки, нельзя не вспоминать таких менторов и таких гигантов в области рака прямой кишки. Это Ричард Хилл. Основным принципом хирургического лечения, который он предлагал прямой кишки, это тотальная мезоректомектомия, которая была предложена Ричардом Хиллом, которая привело к снижению количества рецидивов от 40 до 3,6%. Общепринятые схемы комбинированного лечения. Вот внизу, вот сейчас современные методы лечения, которым мы тоже пользуемся, данной схемы лечения. На первом этапе 4 курса индукционной химиотерапии, по следующим химиолучевое лечение, 54 игры на фоне приема капситабина и так называемый сэндвич химиотерапии, консолидирующие 2 курса по сроке ожидания лучевой терапии, дальнейшей операции и проведение адъювантной химиотерапии. Рак прямой кишки, для которого выполнение РНО-резекции возможно только при условии соблюдения мезоректальной фасы, покрывающей мезоректальные клетчатки на основании данных предоперационной МРТ. По аналогии тотальной мезоректомектомии в 2008 году немецким ученым Вернером Хохенбергом было предложено понятие мезоколонэктомии, это удаление участка брыжейки толстой кишки в пределах эмбриональных слоев с обязательной морфометрией препарата. Так, в этом же году патоморфологом Ник Вестом впервые была продемонстрирована взаимосвязь качества сохранения фасциального футляра мезоколон с выживаемостью. Внушающие результаты хирургического лечения колоректального рака мировых центров доказал эффективность, в связи с чем в нашем центре, начиная с 2020 года, функционирует отделение индивидуальной онкохирургии при онкологическом и радиологическом центре, где выполняется минимизм.
And of course we will have new invasive laparoscopic methods, and in these cases it's very important to have ports in place, which we have I would say conflict of instruments or replacement of ports, and of course you need to pay significant attention to this, because this is the good, I would say, sign for treatment. I would like to show you a brief video at the moment, and we are showing you now checking of intersection and how we are penetrating mesenteric arterium, and you can also see our horizontal clipping, and we are clipping the vessels, and why we have retrieved the specimen, and the specimen was removed laparoscopically, and you can also see that we have colorectal access for this, and you know that we are having the total ectomy, and you can see how we are working practically. We are mobilizing our presacral area, we are mobilizing it to pelvic floor, and we have mobilizing of the I guess of intestine, and you can see at this particular stage we are opening this one, and what we have been doing with anastomosis, and in most of cases it is 100 minutes and 130 minutes, and blood loss was 40 milliliters, and in 5 cases we have reduced this issue, and actually we have also resolved the issues of poly-organ failures, and we can also, I mean, after treatment we had one patient, he passed away from TELA, and also we had from 6 to 36 months, and in case of surgeries, it has less traumas, and it has quite nice cosmetic outcomes, and it can improve radical results, and it also depends on the skills of surgeons. So we would like to give the floor to our colleagues. Please, Mr. Lukmanov Said Rahim, state-of-the-art methods of safety of colorectal anastomosis. I would like to express my gratitude to my colleagues, and as a surgeon who is dealing with colorectal anastomosis, I would like to, in most of cases, patients are occupied with their survival rate rather than security of anastomosis, but the problems of anastomosis are related to failure of anastomosis, which can lead to sepsis, and of course blood loss, which is one of the major problems, and after anastomosis we can stop it, and definitely we are reducing these issues. I mean, we can have the persistent fistula, and of course this anastomosis can cause strictures which reduce the functions of the disease, but it's not a problem actually. The major problem is anastomosis. So I guess our report will be related to prevent anastomosis. You have no anastomosis, you have no problem. It means that you have to avoid anastomosis. And who needs anastomosis and who doesn't? We had several research cases, and you can ask various, I would say, patients. You have also factors related to surgeons, and here we have a lot of indicators, a lot of problems. Actually, we cannot check. I mean, we can ask a patient to, I would say, change their diet. They can also avoid smoking or alcohol, and also we have several factors which are related to, for example, steroid consumption and other medical drugs. And surgeons, we can improve the techniques of surgery. We can improve the perfusion of tissues, and as I have mentioned, and it has been confirmed in majority of indicators, it is so-called malnutrition, it's the problems of COASA, and of course alcohol consumption and factors related to disease. So you can modify, I mean, the surgery can move to surgery, and you can also stop the consumption of steroids, and you can stop consumption within these 5 or 3 weeks. And all the surgeons who are dealing with colorectal surgery, they can confirm that even if you will, I would say, check randomized trial, you will find no randomized trial which shows you that this treatment, radio treatment can produce adverse impact on anastomosis failure. And we have also shown here, I would say, the anastomosis failure both after non-adjunctive therapy and talking about localization of surgery, localization of our indicators, and you can see also from the book of Corman, and you can see also the arteries. They are creating some problems with the trophics, and even here you can see that it is not recommended. So the technical aspects you can see even here we have some problems with modern failure of anastomosis in the left side of anastomosis, and also here you can see that this arterium can be crossed and you can also check that the length of resection should go up to lower margin of symphysis, and if you do not have significant area, you can check with arterium, and you can have so-called Dewey's procedure, and you can also use but anyway it will you can use the part of intestine, but it will produce adverse impact on the functionality, you can also see regarding the perfusion, and it is also very important indicator, because as you have also clearly seen that it can produce adverse impact because it is closely related to diabetes, and it produces adverse impact on diabetes here. It can be related to epidural anesthesia or to I would say short time of surgery. So we had several research which are related to organs perfusion. We have pillar 2 also. We have angiography by ICG method, and patients they had treatment, and of course it's quite good. Of course we have indicators also. So what I can tell you is that we have our traditional approach, and talking about epidural anesthesia, and also we can tell you that we can tell you that it of course can lead to anastomosis, and epidural anesthesia is not producing any adverse impact, and if we will be talking about vasopressors, of course it produces no impact on anastomosis, but if you have vasopressors, it's very important indicators, and of course because it will not be something which we should think about, should we have anastomosis or not, because the failure risk will be up to prophylactics, and I can tell you that we have also the stoma, and here we also have no stoma, and of course after chemical therapy, both in retrospective cohort, all research, it is also very important, and I can also tell you that it can secure anastomosis, but we have the problems with stoma, and that in 85% of cases these stomas are closed, but if not, then we have so-called persistent fistula, and according to our data, it will have just 5.3%, and in most of cases, for majority of our patients, the problem is the progression of disease, and moreover, we have some problems with stomas, and we have some stomas which have its own problems, which you can see. It's like peristomal erosion and etc. And of course retraction and etc. So we are closing these issues because we have adjuvant chemotherapy, and we are awaiting for the stoma to adjust to anterior wall, and we can have infections in this area, and the anastomosis, and here we can have the lethal outcomes, and we have, for example, hernia in the area of stoma, and please kindly look at this particular area. So it is totaling 35% of cases. So it is, I mean, we have it with each of the patients. And talking about coloproctologists, we have some other alternative to other sections. So of course it can lead us to stunting devices. It becomes more and more popular at the moment, and the most important issue here is to prevent anastomosis, to prevent movement of fecalia into disease. And one very important thing, so here we had Track, we had Cecile, and our Korean colleagues from Korea also were specifying this, so I will not be focusing on this. Just let me move forward, and I will just focus on two of these devices. And so everything was conducted in both of these areas. So we had the annual conference of the surgeons on treatment of ileum and duodenum, as they have published their preliminary data that this data is very safe for introduction to clinical practice. We need randomized trial, and this randomized trial I expected to be conducted in fall this year. So we will be also awaiting for vertical heel, which are conducted since May 2024 to May 2025, and we have actually installed this device in 30 patients, and only one patient had failure of anastomosis. Thank you so much for your interesting speech. Today's session they have been very important, dear colleagues. We can see it, and dear colleagues, I would like to give the floor for concluding remark. Yes, colleagues, we are concluding our remark, and I would like to give floor to our moderators, to Professor Dinesh Penkahar and to Professor Emrah Eraslan. Please, dear colleagues, Dear colleagues, so we will start with our report of molecular treatment by Muhammad Iman, who is oncologist in Delhi, in Sargodha Hospital. He will be delivering speech online. Please, sir.
Yes, Dr. Imam, you can start. Go ahead.
Good evening, everyone. I'm Dr. Imam from India, and today I have my topic, that is molecular testing in lung cancer. Can you change the next slide, please? So molecular testing, what is molecular testing? Molecular testing is the analysis of tumor's DNA, RNA or protein from biopsy or liquid biopsy to detect genetic mutation, gene fusions, amplification, and biomarkers that influence the treatment. It is the cornerstone of precision oncology in lung cancer, especially in non-small cell lung cancer. Next slide, please. So what is the purpose to do molecular testing in lung cancer? So molecular testing in lung cancer is done to identify drive mutation, find genetic changes that cause cancer growth, for example, EGFR, ALK, ROS, KRAS, BRAF, MET, RENT, NTRK. Or it also done to detect targeted therapy. Certain drugs only work if the tumor has matching mutation. For example, EGFR inhibitors, it can only work if tumor has EGFR mutation. Same as ALK inhibitors only work when tumor has ALK fusion. That molecular testing also done to decide immunotherapy eligibility, whether the patient is eligible for immunotherapy or not. By testing like tests like PDL expression and TMB. Next slide, please. The molecular testing also detect resistant mutation after treatment. In some cases, after treatment, tumors may develop new mutations. Example, EGFR T790M that cause drug resistance. So molecular testing detects these mutation, and at that time therapy can be switched to next line of treatment. Enable precision personalized medicine. Every patient cancer is different. Molecular testing help to choose the right drugs for the right patient at right time, which improve survival, reduce side effect, and avoid ineffective chemotherapy. Next slide, please. So, to test all patients with non-small cell lung cancer that has adenocarcinoma component, especially in case of advanced disease. Also, even if histology is squamous, if tissue is insufficient, we can use liquid biopsy, cell-free DNA, and as alternative. So some mutation, or if patient is young, we can do that testing in squamous cell also. In case of non-smoker patient, in case of metastatic lesion, also we can take biopsy from metastatic lesion. When to test? At the time of diagnosis. If a patient disease is metastatic disease at the time of diagnosis, we can do that molecular testing at the time of diagnosis only. And if case the disease is in advanced stage, that time also we can do that molecular testing, or in case of recurrent disease, especially to detect resistant mutation. For example, EGFR T790M. Next slide, please. So here I prepare one slide. This slide shows the molecular testing in adenocarcinoma versus squamous cell carcinoma lung. So driver mutation, in case of adenocarcinoma, the common driver mutations are EGFR, ALK, ROS, KRAS, BRAF, RENT, HER2, NTRK, and MET. Whereas in case of squamous cell, these mutations are rare. EGFR, ALK, ROS, typically patient profile. So in case of adenocarcinoma, non-smoker patients or light smoker patients or younger patients are enrolled in this condition. Whereas in case of squamous cell, the history of strong smoking history or older patients. So frequency of actionable targeted. In case of adenocarcinoma, there is a high chance, that is 30 to 40% in Asian patient, whereas 20 to 25% in Western population. Whereas in case of squamous cell carcinoma, this actionable frequency of actionable target is very less, that is less than 5%. Guideline recommendation. As per guideline, we can do that routine comprehensive molecular testing in all patients of adenocarcinoma, whereas as in case of squamous cell carcinoma, routinely it is not done. But test can be done if patient is younger, never a smoker, or very light smoker, or biopsy is very small. So we can do that molecular testing in case of squamous cell carcinoma also. Now, therapy implication, targeted therapy plus immunotherapy are used in case of adenocarcinoma, whereas in case of squamous cell carcinoma, mainly chemotherapy plus minus immunotherapy are used. Next slide, please. So sample for molecular testing in lung cancer. What are the sample we use for molecular testing in lung cancer? The main sample is, gold standard sample is tissue biopsy, that is core needle biopsy or surgical specimen from primary tumor or metastatic site. And then we can also take the cytological sample like cell block from body fluid, like pleural effusion. We can prepare block and we can send for molecular testing. Liquid biopsy also can be used to detect circulating tumor DNA, that is ctDNA, or circulating tumor cells, to see the especially to see the resistant mutation, that is EGFR T790M. Next, and other fluid also, that is pleural effusion, cerebral fluids we can take and prepare block and send for molecular testing. Next slide, please. So what are the methods we are using for molecular testing in lung cancer? These methods are polymerase chain reaction, that is PCR based methods. So PCR based methods are real-time PCR, RMS PCR, digital PCR. These methods detect known mutation like EGFR, KRAS, BRAF. What are the advantages of this method? It is very sensitive, rapid, and cost effective. Limited for testing specific that pre-identified mutation only, like EGFR, KRAS, BRAF only. We can use FISH method also to detect gene rearrangement amplification, for example, ALK, ROS, RENT, MET amplification. Gold standard for ALK, ROS in earlier guideline, it was gold standard. Limitation is that it required specialized lab and it is expensive. The next method is immunohistochemistry. It detects protein expression used for ALK, ROS, NTRK fusion for screening, and PDL expression for immunotherapy. The advantage is it is widely used and widely available. It is very cheap method, and the limitation is that it may require NGS or any other molecular testing for further confirmation. Next slide, please. So the next method is next generation sequencing. Next generation sequencing detect multiple mutations, fusion, insertion, deletion, amplification at the same time. And advantage is that it comprehensive, efficient, detect rare and novel variants. Limitation is that it is more costly, required expertise and infrastructures. And another method is liquid biopsy. As I told that circular tumor DNA analysis. Use blood sample to analyze circulating tumor DNA. Method that by PCR or NGS technique. Clinically used to detect EGFR mutation, especially resistant mutation. That is, example is T cell progression. Monitor disease progression. Sorry. Limitation is low. It is low sensitive if tumor DNA setting is low. Next slide, please. So I prepared additional slide, especially for next generation sequencing. What is next generation sequencing and what is the role of next generation sequencing in new era? So next generation sequencing is referred to a set of modern sequencing technology that allow rapid and high throughput DNA RNA sequencing, unlike traditional Sanger sequencing, which sequence only in previous the Sanger sequencing sequence only one DNA fragment at a time, but in NGS can we sequence millions to billions of DNA fragment at a time, generating a massive amount of genetic information quickly and cost effectively. Enable parallel sequencing of millions of DNA fragments simultaneously. Then massive data can be generated at low cost and high speed. Next slide, please. So this slide I prepare to show that the types of next generation sequencing. So types of next generation sequencing is whole genome sequencing. In this type of next generation sequencing, we can sequence the entire genome to see the novel mutations. Whole exome sequencing. In this type of NGS, we can sequence only exome, or we can see that genome only 1 to 2% genome we can sequence in this technique, but especially this one is for exome only, and it used for genetic disease diagnosis. Targeted sequencing, a specific panel gene, example cancer panel, tumor profile for tumor profiling we are doing. RNA sequencing, then bisulfite sequencing, single cell sequencing, then metagenomic sequencing. These are the types of next generation sequencing. Next slide, please. So these are the next generation panel which we do at our center in my hospital. So we do that according as per the number of gene. So we do that 240 gene panel. Colorectal cancer. For colorectal, we do 7 gene panel also. Comprehensive panel with content 161 gene. Comprehensive panel for 270 genes also. So these are the types of next generation sequencing which we are doing at our center. Next slide, please. So here in this slide, I try to mention that important biomarkers, mutations, and targeted drugs. That biomarkers, for example, biomarkers EGFR, if exon 19 deletion is present, then we can give the targeted therapy. For example, ceftinib, erlotinib, afatinib, osimertinib. Same as in case of ALK, if ALK rearrangement is present, we can start that targeted therapy, which mentioned in this slide. So these are the important targeted therapy. This is my last slide. And, thank you so much for giving this opportunity. Thank you so much.
Thank you, Dr.
Thank you very much, Dr. Imam, for a presentation on NGS. So I will go to my presentation, which is on CAR T cells. I would try to be really very short, and because we have no time. So what is next today? So we know all of us targeted therapy. We know all of us immunotherapy. But what is coming in? It's not coming in. It's already settled in America. It's settling in Europe and trying to settle in China and Asia. So it's CAR T cells, or I would rather say cellular therapy. It's not only CAR T cell, but manipulating cells. That is more important for us. So I will tell you about, so this is my hospital where I work. Это моя больница, где я работаю. И на сегодняшний день мы можем использовать клеточную терапию при лимфомах, при лейкозе, при миеломной болезни, при саркоме и меланоме. Это те показания, которые уже разрешены as per US FDA. So для этих заболеваний у нас уже имеется клеточная терапия. Вот июль 25 год и сентябрь 25 год. 2 ПЭТ-КТ больного, это мой больной. Я сделал КАР-Т в моем отделении. И вы видите эффект в течение 2 месяцев об использовании целлюлярной терапии. Это один больной с лимфомой. Это второй больной с лимфомой. Много узлов, шейник и подмышечник, которые вот декабрь и февраль. Это, то есть в течение 2 месяцев с использованием клеточной терапии, Т-клеточной терапии мы можем достигать полной ремиссии. Это новое в онкологии, и мы должны дойти к этому. Это 2 случая из моего личного опыта. Вот еще один случай. Я клинический исследователь этого большого исследования. Подо мной еще работает со мной несколько центров. Вот вы видите, как исчезает заболевание в течение маленького времени. То есть это действительно та терапия, которая имеет будущее. Это не панацея, а терапия помогает только определенному количеству больных, но при лимфомах, когда у нас ничего не остается, когда мы исчерпали первую и вторую линию, CAR-T-терапия – это действительный подход или действительно следующее поколение, которое мы должны использовать. Это первое клиническое исследование, которое проходило в Америке, ZUMA-1. По сравнению с стандартом лечения мы видим, что выживаемость увеличивается намного с использованием клеточной терапии. Вот 3 различные клинические исследования для 3 различных CAR-T cells, которые уже разрешены для приема в Америке. Какой же здесь принцип? Принцип здесь очень простой. Те клетки наши – это наш defense. Те клетки – это наша оборона. Они могут работать только тогда, когда они могут сопознавать какой-то антиген. То есть они должны сопознавать какой-то антиген, который чужой, и тогда они могут бороться с этим антигеном. Обычно дендритические клетки предоставляют этот антиген к Т-клеткам. То есть антиген должен, то есть Т-клетки должны сопознавать этот антиген. И поэтому создается вот такая специальная генная структура, вирусная структура с структурой гена-антигена, который стоит на лимфоцитах. Обычно на сегодняшний день используется антиген CD19, CD19 или CD22. So мы сделаем ген, который кодирует CD19 антиген, сопоставляем его с вирусом, и этот плазмид потом вводится в Т-клетки. И после этого Т-клетки на себя наращивают рецептор. который он уже может сопознавать CD19, CD19 клетки. Вот эта структура и называется химерический антигенный рецептор. То есть те клетки с наращенным антигенным рецептором. CAR, Chimeric Antigen Receptor T-cells. Как только те клетки узнают то есть чужой антиген, они могут нападать на него. То есть что за процедура? Сейчас вот это обычно первого поколения. То есть есть 3 поколения CAR T-cells. Первое поколение, где есть внутри клетки остается очень маленький co-stimulatory, это называется co-stimulaторный домен. И во втором поколении есть один co-stimulatory домен и один дополнительный домен. И второй, in third generation, есть 2 co-stimulatory domains. То есть в Америке все лекарства, которые пока оправданы, они second generation CAR T-cells. So one co-stimulatory domain and one CD3 zeta activating domain. Вот третья картина – это третье поколение. В Индии тоже оправдано 2 индийских, 2 CAR T-cells второго поколения. Я работаю сейчас на CAR T-cells третьего поколения. Мы уже произвели 25 больных, обследование на 25 больных третьего поколения CAR T-cells. Это началось где-то в 2019 году. Первый CAR T-cell, уже 5-6 CAR T-cells уже разрешены к клиническому исследованию в Америке, во всем мире. Что за процедура? Вот 2 минуты, я закончу свое время, у меня еще 3 минуты. То есть берем больного, скажем, лимфомной больной, закончил 2 курса, 2 линии химиотерапии, остается или остаточное заболевание, или рецидив лимфомы, или миеломы. Этот больной идет на аферезис, мы удаляем лейкоциты от больного, тогда потом из этих лейкоцитов вынимаем те клетки, только те клетки, остальное выбрасывается. Эти те клетки потом идет в лабораторию, и туда мы внедряем в эти те клетки вирус. Вирус, обычно это лентивирус или ретровирус, то есть там имеется часть вируса и часть гена, который кодирует этот рецептор. И вот этот комплекс, ген плюс этот ген рецептора, эта генная структура возится внутри те клетки. Потому что вирус, он ходит внутриклеточно. Когда он идет внутри те клетки, он там начинает производить белок. И этот белок потом переходит на поверхность той клетки как рецептор. То есть те клетки уже становятся, уже имеют новые рецепторы, которые может сопознавать антиген. Эти те клетки из лаборатории опять переводятся больному и переливаются больному. То есть это автологичная трансплантация своих же Т-клеток. Эта процедура занимает обычно 3 недели. То есть больному я вытаскиваю кровь сегодня, и через 3 недели я переливаю эти Т-клетки. И после этого я жду, пока они начинают убивать опухоль. Конечно, эти Т-клетки свои же больного, они уже начинают сопознавать опухолевые клетки и убивать опухолевые клетки. Результат я вам показывал картинки. То есть это самое новое в онкологии, называется CAR T-cell терапия. Процедура обычно занимает около 3 недель. Для этого надо сделать химиотерапию в первую неделю, и до введения Т-клетки тоже нужна специальная химиотерапия. Обычно используется лекарства флюдарабин и циклофосфан. Мы это называем как лимфодеплишн терапия. То есть мы убиваем лимфоциты больного, лимфоцитарную массу, чтобы те клетки могли найти себе место там. Поэтому это называется лимфодеплишн химиотерапия. И переливать Т-клетки. Результаты я вам показал. Процедура, то есть простая процедура. Берем больного, убираем клетки, отделяем Т-клетки, внедряем вирус и опять переливаем эти же Т-клетки. Стоимость этого препарата в Америке, этой одной процедуры, на сегодняшний день только, вот если взять эти 3 недели и процедуру, $1 миллион. $1 миллион. В Индии у нас уже 2 препарата, которые разрешены, и они совпадают по всем нормам, стоит около $100 тысяч. То есть уже 10 раз меньше. Я вам могу сказать, что через 6 месяцев это еще спадет. То есть действительно цена намного ниже. И пока такие клетки имеются и в Испании, в Индии, и в Китае тоже очень много таких лекарств. Вот мы начали это исследование 25 ноября 2024 года, и первую фазу 10 больных мы закончили в феврале. То есть в течение 2 месяцев мы сделали 10 больных. Это очень быстрое накопление для любого клинического исследования. Обычно так нигде в мире не бывает. И что же мы достигли? То есть мы взяли больных с лимфомами, с лейкозами, и обычно что происходит? Это не такая простая процедура. То есть ты сделаешь химиотерапию, и, конечно, с химиотерапией идет подавление костного мозга. Конечно, там и лихорадка, и тромбоциты падают, но самое главное в этом есть сейчас, это просто параметры, давайте не будем об этом говорить. Вот анализ. Первая колонна – это наш карты, который я сделаю клиническое исследование, 10 больных, и все 4 это анализы американского, тоже 1-я, 2-я стадия. Мы сравнили наши данные с ними. Если посмотреть, токсичность, CRS это токсичность, у нас grade 3 toxicity было 10%, и в американских чуть больше. То есть, в принципе, наш продукт совпадает с американским продуктом. Но хотя эти продукты 2-го поколения, то есть продукт, который я исследую, это продукт 3-го поколения. Не будем об этом говорить, сейчас я только покажу еще одну схему. Вот. Из 10 больных, которые первые я провел, мы достигли полную ремиссию в 30 дней у 8 больных и при анализе в 60 дней в 9 больных. То есть 90% полная ремиссия при исследовании CAR-T-терапии 3-го поколения. Конечно, если мы анализировали и состояние CAR-T, и вариантов, то есть это очень такое было серьезное исследование. Есть вот так много антигенов, которые идет исследование в мире, что пока используется только CD19. Есть другие антигены, которые под исследованием, и скоро будут многие лекарства для других антигенов. Проблема с антигенами такая, вот это лекарства, те, которые там оправданы, проблема с антигенами такая, этот антиген не должен существовать на нормальных клетках. Если вдруг он существует на нормальных клетках, те клетки, куда мы вводим, они будут разрушать и нормальные ткани. Поэтому проблема с клеточной терапией, мы должны найти такой антиген на опухолевые клетки, который не имеется на какой-нибудь ткани или в нормальной клетке. Вот это индийские продукты. Это токсичность, которую вы должны иметь в виду. Самая главная токсичность называется CRS. Cytokine Release Syndrome. Синдром сбрасывания цитокинов. Больной обязательно у больного бывает лихорадка, гарантия 100%, иногда через 6 часов, иногда через 24 часа, в зависимости от продукта. Обязательно бывает гипоксия, обязательно бывает гипотензия. И больной нуждается в интенсивной терапии. Поэтому это лекарство надо использовать только в случае, если вы умеете делать трансплантацию костного мозга, если у вас есть хорошее интенсивное отделение. Но это не так плохо, но зато результаты очень хорошие. То есть новое, если мы хотим что-то делать сегодня, это CAR T-cells, клеточная терапия. Я здесь заканчиваю, но я хочу сказать, что есть еще, я назвал свою лекцию клеточная терапия. Это я вам сказал только CAR T-cells. Кроме CAR T-cells есть Т-клеточная терапия. То есть мы берем, если у больного есть опухоль, значит мой иммунитет должен работать против этой опухоли. К сожалению, мои Т-клетки или недостаточны, или некомпетентны, или их мало, они не могут заходить внутрь опухоли. Есть новое лечение, уже оправданное, разрешенное при меланоме в Америке. Берут опухоль сам, из этой опухоли вытаскивают Т-клетки, в лаборатории их размножают, их количество увеличивают, опять и эти клетки подводят близко к опухоли, чтобы они распознали антиген и переводят. Называется TIL-терапия, Tumor Infiltrating Lymphocytes. Тоже новое лечение, столько же стоит, и уже оно показывает прекрасные результаты при меланоме. Точно это же лечение придет и в других заболеваниях. Уже CAR T-cell также разрешается для использования при саркомах, и в ближайшем будущем, скорее всего, у нас будет CAR T против многих опухолей. Прежде всего будет острый миелобластный лейкоз, глиобластома, рак желудка и так далее, и так далее. Спасибо большое.
Спасибо большое. Следующий доклад от риска к надежности. Централизованное отделение химиотерапии на базе интеллектуальной технологии будет делать доктор Нурулла Зенгин из медицинского факультета университета Лукмана Хакима.
Thank you very much. I am medical oncolog from Turkey. Before the presentation, I would like to thank the organization committee for their invitation. In my presentation, I will talk about the standards of chemotherapy preparation and the importance of central chemotherapy preparation. As you know, chemotherapeutics are toxic drugs. Mechanism of action based on the killing cancer cells, they also affect the normal body cells, especially those that proliferate frequently. For example, blood cells, intestinal epithelial cells, and hair root cells are the most commonly affected cells. Side effects related to these cells are common in patients receiving chemotherapy. For a successful cancer treatment, optimum effectiveness and minimal side effects, it should be prepared in ideal dose and mixture. Chemotherapeutics are also toxic to those who prepare them. Healthcare personnel preparing chemotherapy may be exposed to chemotherapeutics by injection, dermal contact, ingestion, and inhalation. Therefore, chemotherapeutics should be prepared by experienced personnel, and safety of preparation personnel must be ensured, and chemotherapy preparation standards should be applied. Chemotherapeutics can also be toxic to the environment, and environment protection must also be ensured. Studies on this subject have shown that in many cancer centers may be some mistakes in chemotherapy preparation. These mistakes may be wrong dose of chemotherapy ordering, wrong dose of chemotherapy preparation, patients on chemotherapy leveling errors, and preparation of chemotherapy in wrong mixtures. In conclusion, we can say with exactly Chemotherapy preparation should be standardized by protecting healthcare personnel and environment and preventing possible preparation errors. Chemotherapy preparation is an important issue, and chemotherapy preparation and application standards have been defined in detail by many national and international guidelines. We can say that standard chemotherapy preparation has 5 components. These components are training staff, suitable chemotherapy preparation environment, appropriate chemotherapy preparation cabinet, chemotherapy safety device, and personal protective equipments. In this slide, the 5 components of the standards chemotherapy preparation are shown on this slide: training staff, preparation environment, preparation system and cabinet, safety device, and personal protective equipment. Okay. Evet. Okay. Training staff, preparation environment, preparation system and cabinet, safety device, and personal protective equipment. In this slide, the standard chemotherapy preparation system options are also this slide. As seen here, there are 4 options. Laminar flow for manual preparation, and semi-automated and full automated systems, and robotic compound systems. For all systems, other standard chemotherapy preparation components must be used except safety device in the robotic systems. Advanced technologies have been used globally in chemotherapy preparation for nearly 2 decades. The medical literature contains significant information about the benefits of these technologies offered to our clinical practice. I would like to, in more detail about this systematic review that collectively evaluated 25 studies on the subject. This systematic review reported that significant reduction in preparation errors, reduction in surface contamination, reduced staff chemotherapy exposure, reduced in chemotherapy preparation cost, but not observed in robotic system due to high setup cost. Also, reduction in chemotherapy preparation time also not observed in the robotic systems. We should also note that integrated workflow software programs are an important component of chemotherapy preparation systems. This software program offers significant usability advantages. For example, order management, drug libraries, automatic dose calculation, order approval, 2-dimensional QR labeling system, report and label generation. Based on this information, we can say that semi-automated and fully automated compounding system supported by workflow software appear to be cost-effective options for most cancer centers. In Turkish practice, these 2 preparation systems are paid more than manual preparation. Additionally, full automated systems are considered equal to robotic systems. These slides present chemotherapy preparation system operating in Turkey. Staff personnel, environment, and chemotherapy application area, for example. And other pictures from Turkey. I would like to talk about the UNOPS project, which started in Uzbekistan and completed an important phase regarding chemotherapy preparation systems. In this project, it was planned to establish a fully automatic chemotherapy preparation system in 6 hospitals and a semi-automatic chemotherapy preparation system in 8 hospitals in Uzbekistan. Installation and training completed, and next step, full-scale practical use. What are the all goals for the features? It can be said that chemotherapy are the heart of the cancer treatment. Knowledge in chemotherapy preparation and administration should be supported by other areas. For example, improving diagnostic process, side effect management, and supportive treatment practice. And increased success in chemotherapy will also positively impact other treatment modalities. For example, neoadjuvant chemotherapy, chemotherapy in metastatic patients, and concurrent chemotherapy with radiotherapy. Increasing overall treatment success will also increase the motivation of patients, their relatives, and healthcare personnel. Finally, we believe that Uzbekistan, which has recently made significant strides in the field of health, will also become a leading country in Central Asia in cancer treatment. Thank you very much.
Спасибо большое за содержательный доклад.
Следующий доклад читает доктор Абдуллаев. Современные возможности молекулярно-генетической технологии в диагностике и лечении опухолевых заболеваний.
Hurmatli hamkasblar, mehmonlar, vaqtni hisobga olgan holda dokladni o'zbek tilida qisqacha tushuntirishga harakat qilaman mazmunini. Demak, o'sma kasalliklarini diagnostika va davolashda yangi texnologiyalarning imkoniyatlari. Onkologik markaz texnik modernizatsiya qilish hisobiga biz markazimizga yangi оборудование olganmiz. Osna deyiladi. Bu bir bosqichli yoki bir qadamli nuklein kislotalarni amplifikatsiyasiga asoslangan usul. Agar slaydga e'tibor beradigan bo'lsalaring, bu slaydda limfa tugunlarida sitokeratin 19. Bu yerda umuman ko'rsatilgan sitokeratin 19 ni genining turli organlardagi ekspressiya darajasi ko'rsatilgan. Chap tomondagilar bular yuqorilar. Chap tomondagilar bular yuqorilar. Mana o'ng tomonga borgan sari ular kamayib boradi. Shular qatorida limfa tugunida sitokeratin 19 geni ekspressiya bo'lmaydi. Agar limfa tugunida sitokeratin 19 geni ekspressiyasi bo'ladigan bo'lsa, u shu o'ziga yaqin turgan organdan tushgan hujayralarning hisobiga bo'ladigan ekspressiya. Bu yerda sторожевой limfouzillarni vizualizatsiya qilish usullari ko'rsatilgan. Bunda deylik oddiy kraskalar intraoperatsionni yoki bo'lmasa texnetsi 99 da ishlatgan holda sторожевой limfouzilni aniqlash imkoniyati ko'rsatilgan. Lekin bularni hammasi o'ziga xos allergik va toksik ta'sirga ega bo'lgan va hozirgi kunda umuman boshqa yangi texnologiya qo'llaniladi. Bu texnologiya temir oksidini shu organga yoki to'qimaga kiritish va uni keyinchalik migratsiyasini limfouzillarda to'planishini aniqlashga asoslangan. demak agar yuqoridagi vaqt oralig'ini ko'radigan bo'lsangiz, mana oddiy kraskalarni ishlatilishi yoki texnitsi 99 da radioaktiv usullarni ishlatilishi vaqti deylik kraskalarniki 1 soatgacha bo'lsa, bu texnitsi 99 niki 1 soatdan 1 sutkagacha davom etadi. Lekin yangi bu preparat tarkibida temir oksidi tutadigan bu preparat Mactrace kiritilgan taqdirda 20 minutdan 30 kun davomida asta sekinlik bilan bu temir oksidi shu eng yaqin turgan limfa tugunda to'planadi va 30 kun davomida saqlanadi. To'plangan limfa uzildagi to'plangan bu temir oksidi eng avvalo birinchi shu kiritilgan organda eng yaqin turgan yoki shu patologik o'choqqa eng yaqin turgan joyda to'planadi va u yerda yuqori magnit maydoni paydo bo'lganligini qayd etish mumkin bo'ladi va shu orqali stojavoy limfa uzil olinadi. Olingan limfa uzil keyingi reaksiyalarda keyingi bosqichda undan limfa tuguni ajratib olinadi, u tortiladi, miqdori 100 mg dan to 600 mg gacha olinadi. Olingan limfa tuguni keyinchalik RP10 gomogenizatorida gomogenizatsiya qilinadi, ya'ni gomogen holatga, bir xil holatga keltiriladi, maydalanadi. Buning uchun maxsus probirka bor, linoamp degan tarkibida shu hujayralarni eritadigan, modda tutadigan modda bor. Jarayon bu intraoperatsion bajarilishi ham mumkin. Bu juda qisqa vaqtning ichida oladi. Gomogen paydo bo'lganidan keyin to reaksiyagacha yaroqli biomaterialni ajratib olish 1,5 minut vaqt oladi. Prinsipi, ishlash prinsipi metodni asosan shu polimer zanjirli reaksiyaga asoslangan. Tarkibi достаточно yetarlicha darajada oddiy. Bu bitta enzim, primerlar to'plami bufer va 3 ta turli konsentratsiyada, ya'ni tarkibida 1 mikrolitrdan 250 mingdan to 2,5 milliongacha sitokeratin 19'ini mRNK'sini tutuvchi eritmasi bor. Oxirgisi bu negativ kontrol. Demak, yuqoridagi olingan biomaterial hamda linoam 19 dan foydalangan holda yig'ilgan reaksiya Rda 210 amplifikatoriga qo'yiladi. Bu yerda amplifikatorning umumiy ko'rinishi, u tomonda ichki ko'rinishi keltirilgan. Olingan natijani tahlili. Mana bu yerda bir bemordan 6 ta limfa uzil, 7 ta limfa uzil olingan bir bemordan. Shundan e'tibor bergan bo'lsangiz, amplifikatsiya faqat 4-limfa uzilda topilmagan. U yerda sitokeratin 19 ni tutadigan, to есть epitelial hujayralar yo'q, o'sma hujayralari yo'q. Qolgan limfa tugullarida aniqlangan. Kontrol, ijobiy kontrol, negativ kontrol. Bu yerda solishtirilgan paytda agar histologik o'zi histologiya, klassik histologiya natijasi bilan solishtirganda makrometastaz, ya'ni 2 mm va undan katta bo'lgan limfa tugullarida metastaz o'choqlarida mos keluvchi o'snadagi sitokeratin 19 ning kopiyasi 5000 kopiya mikrolitrda va undan ko'p. Mikrometastazlarda, ya'ni 0,2 mikrolitrdan va undan yuqori bo'lgan metastatik o'choqlari borlarda sitokeratin 19 ning ekspressiyasi 250 dan 4999 kopiyagacha. Negativda 0,2 mm dan kichik bo'lgan metastatik o'choqlarda sitokeratin 19 ni matrichniy RNK'sini kopiyasi 250 dan kam bo'lganligi uchun negativ hisoblanadi. bu yerda bu miqdoriy o'lchash biologik obyektlarga qo'llash umuman o'zining kamchiliklariga ega, chunki u ko'pincha o'sma hujayralari heterogen bo'lganligi uchun hamma vaqt ham sanalgan kopiya hujayralar soniga mos kelmaydi. No, tepadagi ko'rsangiz bu banknotadagi bu Gauss, bu matematiklarning qiroli va uni shunday gaplari bor. Shu математическое невежество лучше всего демонстрируется избыточной точностью представляемых результатов. Когда мы говорим, что какой-то метастатический очаг размером 2 микромиллиметра вырабатывает 4999 копий, это не совсем правильно. Но вот в нижней картинке изображено 40 ножек. Вот то же самое, в разных генах мы не можем сказать по этим 40 ножкам, какой этот организм. Несмотря на это, данная методика применяется во многих исследованиях других раков другого расположения. Благодарю за внимание. Рахмат.
Thank you very much. And our next speaker is Dr. Imra Eraslan, who would be speaking on first-line treatment of metastatic non-small cell lung cancer without driver mutation. Rak Lyokova Biesmutase Licheni.
Hello dear colleagues. First of all, I want to thank organizing committee for a kind invitation. I am Dr. Amir Temur from Ankara, Turkey. Today I will talk about first-line treatment of non-small cell cancer without driver mutations. Lung cancer remains the leading cause of cancer deaths worldwide. Non-small lung cancer accounts for approximately 85% of all cases. Within this group, patients who lack driver mutations such as EGFR, ALK, ROS1 and others, and do not benefit from targeted therapy options still represent the largest population, nearly 50% of the population. Cisplatin-based chemotherapy was the standard of care for several years with an statistically significant hazard ratio, but equivalent and absolute improvement in survival 10% at 1 year, the survival was very short. A meta-analysis, which there was 16 trials, chemotherapy versus best supportive care, was also chemotherapy had better efficacy than supportive care. But also in this meta-analysis, the survival was short and nearly 8 months. Over the last decade, the introduction of chemotherapy combined with immune checkpoint inhibitors has fundamentally changed the treatment algorithm for this patient group. While median overall survival was previously limited to nearly 10 to 12 months with a platinum-based chemotherapy at best only approach, today 5-year survival rates have reached 20 or 30% in some subgroups. Historically, lung cancer was divided in two groups, small cell and non-small cell, and then histologic features, according to histologic features, squamous or non-squamous, large cell or adenocarcinoma, and today we classify the tumors according to molecular pathology features or PD-L1 expression levels. The current paradigm for treatment selection has 3 primary axes: histology, squamous or non-squamous, PD-L1 expression level, TPS more than 50% or 1 to 49% or less than 1%. And clinical factors, disease burden, symptoms, comorbidities, especially rheumatologic diseases or autoimmune diseases, brain metastasis, and performance status. If we look biologic rationale of immune checkpoint inhibition, first priming phase in lymph node, antigen presenting cells activate T cells. Then T cells goes to tissue and make a cytotoxic effect on tumor cells when they met tumor antigen. And CTLA-4 and PD-L1 inhibits this immune reaction by down-regulating this reaction. If we block CTLA-4 or PD-1 or PD-L1, the down-regulation has disappeared. Before selecting first-line therapy, driver mutations should be excluded with a broad NGS panel. PD-L1 TPS should be evaluated. PDL categories high or low or negative. Brain MRI should be performed to assess metastasis. ECOG performance status is critical. Most studies include patients' ECOG scores of 0 or 1. Comorbidity history of autoimmune disease may be determinant of immunotherapy selection. TMB and CTK11 and KEAP1 mutations are not currently routinely used in treatment selection, but their prognostic significance is known. Before selecting first-line therapy, some issues which check male gender and cigarette history and PD-L1, high PD-L1, especially more than 90%, elderly patient, frail patient, and KRAS G12C and TP53 mutations favors monotherapy, and female gender, no smoking history, and KRAS with CTK11 and KEAP1 mutations favors combination. 3 trials in PDL high group, especially this third trial is important because in this group the most important question single agent immunotherapy or combination therapy. Keynote 24, Empower Lung 1 and Empower 110 trials compares the monotherapy or chemotherapy, monoimmunotherapy or chemotherapy with same design in PD-L1 high patients. And some studies support the immunotherapy and chemotherapy combinations. First, Keynote 24 trial, pembrolizumab versus chemotherapy. The median overall survival was duplicated, 26 months versus 13 months. Also, 5-year survival rates nearly duplicated. In long-term follow-up, a portion of patients who receive 2 years of treatment remain progression-free even after treatment ends. Summary message of this trial: single-agent pembrolizumab is a strong standard of care for asymptomatic patients with low tumor burden and PD-L1 high. A same trial with cemiplimab, same results. The median overall survival was duplicated and PFS was 8 versus 5 months, and overall response rate also duplicated. Benefit was maintained in patients with stable brain metastasis. 3 years overall survival was nearly 30% in this group. And the other trial, Empower 110, atezolizumab trial, the median overall survival was 20 months versus 13 months. With these three drugs, clear benefit of survival, FDA approved monotherapy of these three drugs. But some issues important because in PD-L1 high group, even if TMB was low, pembro not better than chemotherapy. Pembro benefit may be restricted to PD-L1 high and TMB high group. Similarly, efficacy in never smokers, several trials didn't show any superiority in terms of survival on chemotherapy with immunotherapy. And many trials shows that in female monotherapy does not work better than chemo. So today in PD-L1 high group, pembrolizumab and cemiplimab are the best options. It looks like they are best options, but new drugs is coming. One of these bispecific antibody for PD-1 and VEGF in Harmony 2 trial, ivonescimab versus pembrolizumab, and in this trial, ivonescimab was better in terms of PFS than pembrolizumab. Also, in squamous cell carcinoma or non-squamous cell carcinoma or PD-L1 low group or PD-L1 high group, ivonescimab was better. And overall response rate, also disease control rate was better. But this drug, overall survival data is not yet, so FDA hasn't approved for this drug. Even case with PD-L1 more than 50% choosing a combination over single agent IO may be advantageous in high tumor burden or symptomatic patients in Key 189 and 407 trials. If we look all of the groups in combination in this trial was better than chemo. Combination was better than chemo in terms of overall survival, all of them PDL levels. In non-squamous carcinoma, adenocarcinoma and others, pembrolizumab, pemetrexed, platinum combination versus chemo, 5-year overall survival rate was 19% versus 11%. Benefit contains all PD-L1 subgroups and overall survival hazard ratio with significance. PFS was 8 to 5 months. This study is the current gold standard in adenocarcinoma. Likely, Empower Lung 3 trial in cemiplimab plus chemotherapy versus chemotherapy show similar results like keynote trials. And Poseidon is the trial that 4 drugs combination versus chemotherapy, durvalumab and anti-PD-L1 and tremelimab and anti-CTLA4 plus chemotherapy, and overall survival was better with combination, also with an statistically significant hazard ratio. But not all group in this trial, squamous histology didn't benefit for drug combinations. And squamous histology keynote 407, pembrolizumab plus carboplatin, paclitaxel or not paclitaxel versus chemotherapy, the overall survival was 17 months versus 11 months. 5-year overall survival was 18 versus 9%. Benefit in all PD-L1 subgroups. And in Empower 101 trial, atezolizumab, it demonstrated a PFS advantage, but no differences in overall survival was found. In long-term analysis, follow-up analysis, both small squamous cell carcinoma and non-squamous cell carcinoma had benefited pembrolizumab combinations, and early mortality was lower in this group. And the last group is PD-L1 negative group, difficult patient group. Single-agent immunotherapy is ineffective in this group. Standard is chemo-IO combination or dual immunotherapy plus short-time chemo. The keynote studies show a benefit even in PD-L1 negative groups. The also benefit is maintained. The most important trial in this group, Checkmate 9LA, nivolumab plus ipilimumab plus 2 cycles of chemotherapy versus chemotherapy. In this trial, median overall survival was 15 months versus 11 months. And notable benefit, especially in PD-L1 negative group. And the other trial with ipi-nivo combination versus chemo, ipi-nivo in this combination without chemo. 5-year overall survival was 24% versus 14% in long-term follow-up. However, in current practice, the 9LA protocol is preferred. If we look closely, Checkmate 9LA study, 2 arms in study, 5-year update analysis in all randomized patients shows combination benefit on overall survival. Overall survival was prominent in PD-L1 negative group, and also hazard ratio were impressive for squamous cell carcinoma. And in PD-L high group and PD-L non-squamous carcinoma also benefited from the combination of nivolumab, ipilimumab, and chemotherapy. PD-L1 negative and brain metastatic group is the worst group, but in Checkmate 9LA, the effect of this combination on brain metastatic patients impressive. And the other trial, Checkmate 227, overall survival better in the ipi-nivo group compared to chemotherapy in both all of the patients and the PD-L1 negative group. In long-term analysis of update analysis, the overall survival benefit continued in favor of ipi-nivo combination. Combined analysis of Checkmate 227 and 9LA in PD-L1 negative patients at 5 years, 20% of patients were alive. And special groups, brain metastasis benefit was maintained in patients with stable brain metastasis in the cemiplimab studies and keynote series. IO therapy is safe to use in conjunction with local therapy. Elderly patients and frail patients, prospective data are limited. Last linear regimes, example, single agent IO in patients with TPS high patients, or a reduced dose combination may be considered. And as TK11 and KEAP1 mutations, unfavorable prognostic factor, IO efficacy may be reduced, but chemo-IO combination remains the best option. As a summary, first, in metastatic non-small cell cancers, confirm driver negativity with NGS, obtain PD-L1 TPS levels. If TPS level more than 50% and low burden asymptomatic patient, pembro or cemiplimab or atezolizumab as a single agent. If high burden symptomatic patient, chemo-IO combination is standard. In TPS low group, standard is chemo-IO combination, and TPS negative group, chemo-IO, especially pembrolizumab or cemiplimab, or dual blockage with nivolumab, ipilimumab plus 2 cycles of chemotherapy. And then surveillance and toxicity, CT or PET-CT at 8 or 12 months, 12 weeks follow-up, immune-related adverse events protocols. Thank you for continuing.
Thank you very much, Dr. Islam. Thank you very much for a great presentation. Any questions? No. Thank you very much, sir. Thank you. Спасибо большое. Сейчас мы заканчиваем сегодняшнюю сессию. И я думаю, что завтра утром мы соберемся вовремя и начнем. И сейчас пойдем на вечерний ужин. Я бы очень хотел, чтобы, если есть даже какие-то вопросы, чтобы завтра люди подняли, хотя здесь очень мало людей, но то, что вы слушали, которые здесь сидят, я бы очень хотел, чтобы вы передали тем, которые здесь не существуют. Спасибо большое.
Imagine a world where information is at your fingertips, literally. Where the room was set up perfectly, every time. Because perfection, well, it's on display. Where every second counts. And connecting is anywhere, anytime. Where drag and drop, well, it goes through walls. Where patients get the big screen treatment. And anesthesia, they get the same. It's a world where setup is the touch of a button. And visualization is like nothing you've ever seen. Any way you want it. Where control is in your hands. For everyone and everything. And when there is something unexpected, well, the room is ready for that. Automatically. And if you need a second opinion, it's on demand. Virtually.